So these three words look the same: arteriosclerosis, atherosclerosis, and arteriolosclerosis. Arteriosclerosis is a general umbrella term describing diseases where the wall of the artery becomes thicker, harder, and less elastic than normal. You can figure that out right from the name: arterio, which is Greek for artery, and sclerosis, which is Greek for hardening. Now, the word arteriolosclerosis is any sort of hardening of small arteries and arterioles. This is also pretty easy to remember since the olo in the middle of the word indicates small arterioles. And then finally, atherosclerosis is the hardening of any artery, even though it's usually medium to large sized arteries, which is caused by the buildup of plaque. These plaques are called atheromatous plaques and happen in the innermost wall of the blood vessel, called the tunica intima or endothelium. Okay, now that we've differentiated between all three of these words, let's first take a look at atherosclerosis. So the blood vessel endothelium is made up of a single layer of cells and does two jobs. First, it protects the rest of the blood vessel wall from the blood, like a coat of varnish on your wood furniture. And then secondly, it secretes proteins on its surface to prevent the blood from clotting, because blood just inherently likes to clot whenever it gets the chance. Now, your endothelium can become damaged in a lot of ways. Low-density lipoproteins, chemicals from smoking cigarettes, and high blood pressure all wreak havoc on the endothelium, because these irritants break down the endothelium. The damaged endothelium allow low-density lipoproteins to enter the endothelial wall. White blood cells, called monocytes, follow the low-density lipoproteins and break them down through oxidation. Okay, so you might think that macrophages eating the embedded low-density lipoproteins is a good thing. But if there are a lot of low-density lipoproteins, then the macrophage will eat so much cholesterol that it can die. It basically eats itself to death. After it dies, it deposits itself under the damaged endothelium. So now we have a dead macrophage filled with low-density lipoproteins stuck in the damaged endothelium as well. These dead macrophages are called foam cells, and that's because some guy a while back looked at these things in a microscope and thought they looked like foam on the beach, hence the name. Also, when the macrophage dies, it releases cytokines, which calls over more monocytes which come over and eat more low-density lipoprotein, inevitably dying while doing so. And thus this vicious cycle of gross overeating and massive fatalities has begun. As more and more of these foam cells build up, they form a lesion we call a fatty streak. Now, the fatty streak is thrombogenic, meaning that blood can clot on it. Platelets begin to gather at the damaged endothelium and release platelet-derived growth factor, which in turn encourages the growth of smooth muscle cells. Now, normally smooth muscle cells are supposed to stay within the middle layer of the blood vessel, the tunica media. The release of platelet-derived growth factor draws the media smooth muscle cells to the tunica intima, where they multiply. The growing smooth muscle secretes collagen, proteoglycans, and elastin fibrous cells that help form a wall around the fatty streak, preventing blood clotting. And we call this extracellular matrix wall a fibrous cap, and together both the fatty streak and the surrounding fibrous cap is called plaque. The presence of fatty streaks cause the underlying smooth muscle in the blood vessel wall to also start depositing calcium into the plaque, creating crystals. Normally, calcium is deposited into the vessel wall by low-density lipoproteins and is then removed by high-density lipoproteins. The accumulation of plaque in the vessel messes up with the ability of the high-density lipoproteins to remove calcium from the vessel, so a buildup of calcium occurs in the vessel wall and it crystallizes. Now remember, calcium makes stuff hard, which is why your bones are full of calcium, right? So this deposit of calcium into the plaque is what stiffens the walls of the arteries. Now remember the word that describes the immune system getting involved with something is called inflammation. So atherosclerosis is an inflammatory disease. Now, as an aside, the protein called C-reactive protein increases in the blood during an infection or when inflammation is occurring somewhere in the body. While an elevated C-reactive protein isn't specific enough to diagnose atherosclerosis, it can act as like a red flag that atherosclerosis might be occurring, especially if someone has atherosclerosis symptoms or other risk factors. From time to time, that fibrous cap can crack and expose the underlying thrombogenic foam cells to blood. And this can happen randomly, and when it does, within moments you can see a blood clot start to form within the already partially occluded artery, quickly leading to even less blood being able to flow by. After about 70% of the blood vessel is occluded from the plaque and the new overlying blood clot, cell injury and death begin in the areas that were relying on that blood flow. If blood flow is reduced in the coronary arteries, angina and myocardial infarctions can occur. Seriously occluded internal carotid and middle cerebral arteries lead to strokes and cerebral atrophy. An occluded superior mesenteric artery affects the small intestine, and an occluded popliteal artery can cause peripheral vascular ischemia like gangrene or claudication, which is frequent leg cramping during exercise. Now, the building up of plaque also weakens the artery walls, which means it can lead to aneurysms, which explains why atherosclerosis is a main cause of abdominal aortic aneurysms. But the complications of atherosclerosis don't stop there. If we move on to the kidneys, plaque buildup in the renal arteries reduces blood flow to the kidney and tricks the kidney into thinking blood pressure is low. The kidneys then activate the renin-angiotensin-aldosterone system, which unnecessarily increases blood volume in the body, causing hypertension. Occasionally, some of the plaque can also break off from the main plaque deposit and become an embolism, floating around in the bloodstream until it gets stuck in a smaller blood vessel or another artery with significant atherosclerotic plaque buildup. And you can totally see this in a tissue biopsy, as the affected blood vessel will have cholesterol clefts, these big white entities in the middle of the blood vessel. So, moral of the story, atherosclerosis isn't great. There are a few things that you can do to prevent it, though. Maintaining a normal blood pressure and avoiding excessive sugary and fatty foods and drinks all reduce your risk of the disease. There are other risk factors that may be out of your control, though. You're more likely to get atherosclerosis as you get older. Males and postmenopausal females are also more prone to the disease, but premenopausal females are less at risk because higher levels of estrogen have a protective effect against atherosclerosis. No big surprise here, but people who have a family history with atherosclerosis are also more at risk. Okay, that's enough atherosclerosis for one day. Another type of arterial sclerosis is called Monckeberg sclerosis, or medial calcific sclerosis. And this is caused by the formation of calcium crystals in the muscular layer of the blood vessel wall, leading to hardening of the blood vessel. But this doesn't affect the diameter of the lumen. Since blood flow isn't impaired, it doesn't really cause any signs and symptoms, so it's usually detected during a diagnostic procedure for something else, like mammograms, since mammographies are used to look for calcification as a sign of breast cancer. So the last arterial sclerosis category we'll talk about is arteriolosclerosis. Arteriolosclerosis is a category of blood vessel hardening diseases that affect small blood vessels and is caused by high blood pressure and diabetes. Hyaline arteriolosclerosis is one type of arteriolosclerosis where instead of a buildup of plaque on the walls of the arteries, the high blood pressure blood flowing through the blood vessels causes proteins floating around in the blood to leak into the blood vessel walls. Over time, you'll see these walls begin to build up with a lot of these proteins, making the blood vessels stiffer. When you look at a blood vessel through a microscope, you'll see a pink hyaline material that's making the blood vessel very thick. Thick walls mean that the lumen of the vessels start to get narrower, and this basically reduces blood flow to the organs that are supplied blood through these vessels, and the organs get starved of oxygen. And this is usually seen in the kidneys, where not enough blood is supplying the small glomeruli blood vessels and the glomerulus itself, causing the glomerulus to scar, which is summed up nicely by the term arteriolonephrosclerosis. If we don't do something to stop it, we'll see scarring occur to enough glomeruli that a person develops chronic renal failure. People with diabetes can have hyaline arteriolosclerosis through a different mechanism. Chronic exposure to high blood sugar can directly damage the endothelium, likely by altering carbohydrate and fat metabolism, which in turn damages the basement membrane of the blood vessels. Another type of arteriolosclerosis is called hyperplastic arteriolosclerosis, which also happens due to the thickening of the blood vessel walls, and occurs when a person has extreme hypertension. The blood vessels compensate for this high blood pressure by adding additional layers of smooth muscle and basement membrane to the blood vessel wall, making the blood vessel stronger. The downside of this extra muscle is that it decreases the space in the lumen for blood to pass through. If you look at these hyperplastic blood vessels under a microscope, you can see the rings of smooth muscle with a small lumen, which kind of looks like an onion. Just like in hyaline arteriolosclerosis, hyperplastic arteriolosclerosis can then cause ischemia in the organs it supplies. Also, just like hyaline arteriolosclerosis, hyperplastic arteriolosclerosis typically affects the arterial walls of the kidney. The high blood pressure destroys the blood vessels in the kidneys, causing renal ischemia. What's unique in hyperplastic arteriolosclerosis is that the kidneys themselves will look a bit like they have insect bites everywhere. And that's because the high blood pressure ruptures the weakened renal blood vessel walls, causing small hemorrhages all over the kidneys. These small blood vessel hemorrhages give the kidney tissue the appearance that they've been bitten by insects.
Narrowed and hardened arteries don't generally cause symptoms until the blockage is significant. Once that happens, there might be pain distal to the affected artery, including chest pain or angina if it's a coronary artery, or foot and leg pain if the blockage is in an artery in the leg. If the artery goes to the brain, it can cause stroke-like symptoms like confusion or weakness. If the artery goes to the kidneys, it can cause high blood pressure or renal failure. Diagnosis usually starts with a physical examination, which can show a weakened pulse below the blockage or bruits, which is a whooshing sound over the arteries heard through a stethoscope. In addition, an imaging study like an angiogram, where a dye is injected into the blood vessel, can show narrowing of the vessels. These diseases can often be treated with lifestyle changes, like stopping smoking and improving diet and exercise. And that can help improve underlying conditions like diabetes mellitus or hypertension. In some cases, medication might be required. Cholesterol medications like statins can be used to improve lipid profiles. Antiplatelet medications like aspirin can be used to reduce blood clotting, and blood pressure medications like beta blockers, diuretics, and angiotensin-converting enzyme inhibitors, or ACE inhibitors, can help lower blood pressure. With severe atherosclerosis, angioplasty can be used to open a blocked artery with a balloon, followed by the placement of a stent to keep the artery open. A surgery called an end arterectomy, often done with the carotid arteries, can also be done to remove fatty deposits. Finally, a blood vessel can be grafted in and used to bypass or go around a blocked artery. Alright, as a quick recap. Arteriosclerosis literally means hardening of the arteries, and describes diseases where arteries become thicker, harder, and less elastic. Arteriolosclerosis specifically refers to the hardening of the arterioles, which often affects blood flow to the kidneys. And atherosclerosis describes the buildup of atheromatous plaques in medium to large arteries. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.
The word aneurysm is based off the Greek word aneurysma, which means dilation. And that makes sense because aneurysms are abnormal dilations in a blood vessel. We officially label a bulge in a blood vessel as an aneurysm when the diameter of that bulge is about 1.5 times larger than the normal diameter of a blood vessel. Aneurysms can happen to any blood vessel in your body, like the aorta, the femoral artery, the iliac artery, the popliteal artery, and the cerebral arteries. They can also happen in your veins too, but those are less common because blood pressure in veins is much, much lower than in arteries. There are two major categories of aneurysms, true aneurysms and pseudoaneurysms. In true aneurysms, all the layers of the blood vessel wall dilate together. True aneurysms that balloon out symmetrically on all sides of the blood vessel are called fusiform aneurysms, whereas asymmetrically shaped aneurysms balloon out only to one side of the blood vessel. This asymmetrical shape usually happens because, for some reason, one side of the blood vessel wall has had to put up with higher blood pressures than the rest of the vessel wall, or because the wall was weaker on one side to begin with. Asymmetrically true aneurysms can be called either saccular or baryaneurysms. You can think of pseudoaneurysms as false aneurysms, as in they're not actually aneurysms at all. They are caused by a small hole in your blood vessel which allows blood to leak out of the vessel and form a pool of blood that looks like a fusiform or berry aneurysm, depending on where the hole is and how big it is. The blood pools because the surrounding tissues act as a wall that contains the blood in one spot. Arterial aneurysms occur most commonly in the aorta, with about 60% of true aortic aneurysms happening in the abdominal section of the aorta, and about the other 40% happening in the thoracic section. Of all the abdominal aortic aneurysms, you can find about 95% of them just below the point where the renal arteries branch off from the abdominal aorta, but above the aortic bifurcation. That's because there is naturally less elastin in the walls of this part of the aorta than the rest of the aorta. Aneurysms are caused by a weakness in the blood vessel wall, so anything, really anything, that causes the wall to weaken can cause an aneurysm. When a blood vessel wall weakens, it struggles to contain the pressure of the blood pushing against the walls, so the diameter of the blood vessel lumen increases. On top of this, pressure tension on the blood vessel walls increases as the diameter of the lumen increases thanks to Laplace's law, making the aneurysm diameter even bigger, creating this cycle of continuous bulging. You've likely experienced this when you blow up a balloon. The first breath into the balloon is tough, but the next several breaths are pretty easy. This is why aneurysms usually get bigger over time. It's because of this positive feedback loop. So what underlying conditions might weaken the wall of blood vessels? Well, one way is if all the layers of those blood vessel walls don't receive oxygen. Typically, the cells of the vessel walls are able to get oxygen from blood as it flows by. But in the first section of the aorta, where the walls are super thick and muscular in order to handle all that blood pressure coming from the heart, they need to have their own set of blood vessels that supply the tunica media and the tunica externa. We call these special blood vessels vasa vasorum. In hypertension, the vasa vasorum can develop hyaline arteriolosclerosis, narrowing their lumen, causing ischemia to the aortic wall, and we end up with atrophy of the smooth muscle of the tunica media. Overall, all this weakens the aorta's wall. The same thing can happen in blood vessels without vasa vasorum if we have a bunch of plaque building up on the tunica intima thanks to our friendly neighborhood atherosclerosis. Oxygen just can't penetrate all of the vessels of the wall. You can see this type of aneurysm often in the abdominal aorta, where blood pressure is high and the aorta walls are nourished by passing blood. If you think about this, it's no wonder then why both aneurysms and atherosclerosis share similar risk factors. They're usually people who are male, who are over the age of 60, and who have hypertension and smoke. If we look at tertiary syphilis, it affects the vasa vasorum as syphilis causes inflammation in the tunica intima of the vasa vasorum, which again are those blood vessels that deliver oxygen to the thick walls of the larger blood vessels. And this ultimately leads to a narrower lumen and restrict blood flow to the vascular walls of the thoracic aorta, causing atrophy. By the way, the name for this vasa vasorum inflammation is endarteritis obliterans. If you were to look at the vasa vasorum in tertiary syphilis, you'd see the inflammation causes fibrosis and scarring on the walls, creating this cool to look at but less cool to have tree bark-like texture. Other bacterial infections can also cause aneurysms, which we label as mycotic aneurysms. The bacteria from an infection somewhere else in the body can break off from the main infection and travel around in the blood. Usually these embolic bacteria will get stuck in the intracranial arteries, visceral arteries, or the arteries feeding the arms and legs. There, the bacteria enter and weaken the blood vessel walls, leading to, you guessed it, an aneurysm. Some of the bacteria that commonly cause mycotic aneurysms are, and these can be tricky to pronounce, so bear with me, Bacteroides fragilis, Pseudomonas aeruginosa, and anything in the Salmonella species. You'll also see mycotic aneurysms are a complication of infective endocarditis. But it's not limited to just bacteria. Infections from the fungi Aspergillus, Candida, and Mucor are also a common cause of mycotic aneurysms. Genetic disorders affecting your body's ability to properly form connective tissues like fibrillin or collagen also weakens the blood vessel walls. So people with Marfan syndrome have weakened blood vessel walls because the elastic properties found within fibrillin is impaired. And people with Ehlers-Danlos syndrome are more likely to develop aneurysms because their ability to form collagen proteins is disrupted. Alrighty then. So intact aneurysms are usually okay and don't cause any symptoms. I say usually because the bulging blood vessel can compress organs or vessels around it. So if an aneurysm compresses a major vein like the inferior or superior vena cava, it could decrease the amount of blood returning to the heart. Usually though, the big worry with aneurysms is the possibility that they might explode, or more like rupture. But it's more fun to say explode. When an aneurysm ruptures, it's like having a water main break. Blood is spewing out of the hole in the blood vessels and less blood is flowing downstream to the cells that need it, which causes ischemia in that downstream tissue. In thoracic aneurysms specifically, a very serious complication can occur if the aneurysm is right above the aortic valve. As the aneurysm dilates, it pulls on the walls around the aortic valve, preventing the aortic valve from closing properly, and allowing blood from within the aorta to flow back into the ventricle during ventricular diastole. This particular condition is called aortic insufficiency and can also cause a high-pitched brassy-like cough because the left recurrent laryngeal nerve, which wraps around the aorta, is stretched by that expanding diameter of the aorta. I don't have an audio clip for that brassy cough sound, but it's pretty distinct when you hear it. Moving on to the brain. If an aneurysm ruptures in the brain, blood will pool into the subarachnoid space, putting pressure on the brain tissue and irritating the meninges, causing symptoms like a very sudden and intense headache, and the inability for someone to flex their neck forward. Another point on this list of terrible things aneurysms can cause is blood clots. As blood flows past the aneurysm, some of the blood might pull over into the extralumen space caused by the aneurysm itself. This blood isn't being pushed along the blood vessel as quickly as the rest of the blood, and when blood stays still for too long, it likes to clot. Given enough time, the blood clot might become so big it blocks off the entire blood vessel, causing tissue ischemia, or it could break into smaller pieces called emboli and get wedged into the small blood vessels, also causing ischemia. As an aside, it's kind of nifty that the clotting property of blood is really useful to stop blood from leaking out of blood vessels, but it also happens to be really, really deadly if it stops the blood from moving altogether. Honestly, blood coagulation could be the plot for like the third installment of the Speed movies. Okay, back on track. Abdominal aortic aneurysms sometimes have signs and symptoms, and sometimes they don't, even if the aneurysm has ruptured. Really severe pain in the left flank, which includes the abdomen, chest, lower back, as well as the groin, a pulsating mass that is in time with the heartbeat somewhere in this painful region, and hypotension occur in about 50% of aneurysms that have ruptured and are considered the classic signs of abdominal aortic aneurysm. Thoracic aorta aneurysms usually don't have any symptoms, although sometimes they can cause severe chest, back, and abdominal pain. Aneurysms can be asymptomatic and are sometimes diagnosed accidentally when an individual gets an imaging study for another reason. Usually they're seen best on an ultrasound, CT scan, or MRI. If an aneurysm is present and large enough to cause risk to an individual, it can be treated surgically. Alright, as a quick recap, aneurysms are blood-filled bulges that form in weakened areas of the blood vessel walls. Left untreated, aneurysms can burst, causing uncontrolled internal bleeding or excessive blood clotting. Based on the size and location of an aneurysm, surgical treatment may be necessary.
An aortic dissection is where part of the tunica intima, which is the endothelial or the innermost layer of the blood vessel, of the aorta is ripped off. What happens is a tear in the tunica intima of the aorta forms, and the high-pressured blood flowing through the aorta begins to tunnel between the tunica intima and the tunica media, separating the two layers. Now, as the high-pressured blood continues to shear more and more of the tunica intima off the tunica media, blood starts to pool between the two layers, increasing the outside diameter of the blood vessel. The area where blood collects between the tunica intima and the media is called a false lumen, and the true lumen is the regular lumen of the blood vessel. Since high pressure is a cause of aortic dissection, it's no surprise that the aorta is the prime target for this problem. So what causes aortic dissections? Well, chronic hypertension is the major cause, whether the hypertension is caused by stress or from increased blood plasma volume, like in pregnancy. Blood vessel coarctation, which is the narrowing of a blood vessel, can also cause dissection. Aortic dissections most often happen in the first 10 centimeters of the aorta closest to the heart. A tear near the heart or in the upper aorta is considered a type A aortic dissection in the Stanford classification system. Type B aortic dissections involve tears in the lower aorta or descending aorta. Both type A and B aortic dissections can extend into the abdomen. In order for an aortic dissection to occur, an underlying condition usually has to exist that weakens the aorta's wall. Connective tissue disorders, like Marfan's and Ehlers-Danlos syndrome, can cause a dissection as well as decreased blood flow to the vasa vasorum. Aneurysms can be a cause of aortic dissection as well. An incidental dissection can also cause aneurysms because, again, the dissection weakens the blood vessel wall. In other words, weak walls can lead to an outpouching of the blood vessel or a break in the tunica intima, and both of these weaken the walls further. Aortic dissections cause a whole bunch of other problems too. A lot of complications are related to where the blood in the false lumen flows. The blood could flow back up the aorta to the heart and enter the heart's pericardial space, filling it with blood and causing pericardial tamponade, a really, really bad and potentially fatal situation. The blood flowing through the false lumen could also puncture a hole through the tunica media and tunica externa and bleed into the mediastinum, which would kill you really fast because that's a lot of blood leaving the vascular system very quickly. The tunneling blood could also puncture a hole in the tunica intima and return into the true lumen. Yet another possibility is that the blood could continue to tunnel between the tunica intima and tunica media until it reaches another artery that branches off the aorta, like the renal arteries or the subclavian arteries. The blood in the false lumen can put pressure on these branching arteries, decreasing blood flow to the kidneys and arms, causing a whole new mess to deal with. The main symptoms of aortic dissection are sharp chest pains that often radiate to the back. A person might also develop weak pulses in downstream arteries, like the brachial or femoral arteries, or sometimes there may be differences in blood pressure between the left and right arm. An aortic dissection is an emergency because it can lead to hypotension or low blood pressure, as well as shock if there's rupture and significant blood loss. On a chest x-ray, there's typically a widened aorta. More sensitive imaging techniques that are commonly used include a transesophageal echocardiogram, which is where an ultrasound probe is passed through the esophagus to obtain a clear picture of the aorta. There's also CT angiography and magnetic resonance angiography, both of which look closely at the blood vessels. An aortic dissection needs to be treated immediately. Type A aortic dissections are treated surgically, where a surgeon takes out as much of the dissected aorta as possible and blocks the entry of blood into the wall of the aorta. The aortic wall is then reconstructed with synthetic graft, and sometimes that graft is propped open with a wire mesh stent. Type B aortic dissections are treated with beta blockers and nitroprusside. Alright, as a quick recap. An aortic dissection is where blood tunnels between the tunica intima and tunica media, separating the two layers and creating a false lumen. This is a rare condition that most often happens with a history of high blood pressure, connective tissue disorders, and aneurysms. An aortic dissection can lead to emergency situations like cardiac tamponade and shock, and should be treated immediately.
Coronary artery disease, or CAD, is caused by atherosclerosis of the coronary arteries, which occurs when plaque builds up in the vessels, eventually narrowing the lumen and causing a mismatch between oxygen supply and demand of the heart. Over time, reduced oxygen supply can lead to myocardial ischemia or even infarction. The diagnosis of CAD is based on atherosclerotic risk factors that categorize patients into low, intermediate, or high-risk groups based on their probability for obstructive disease. Now, if you suspect CAD, first perform an ABCDE assessment to determine if the patient is unstable or stable. If unstable, stabilize their airway, breathing, and circulation. Next, obtain IV access, provide supplemental oxygen, and put them on continuous vital sign monitoring, including blood pressure, heart rate, and pulse oximetry. At this point, you should suspect CAD with acute coronary syndrome, which includes unstable angina, non-ST elevated myocardial infarction, or ST elevated myocardial infarction. Once you stabilize the patient, obtain a focused history and physical examination and order serial troponin levels and an ECG. Okay, let's focus on unstable angina. Your patient may report sudden chest discomfort that doesn't improve with rest and feelings of uneasiness or impending doom. Other common symptoms include dizziness, shortness of breath, sweating, as well as nausea. Physical exam typically reveals a distressed, anxious, and diaphoretic individual. Okay, next, take a look at the serial troponins. If there's no myocardial infarction, troponins will typically be normal, while ECG may or may not show signs of ischemia like ST segment depression or new T-wave inversion. This combination of history, physical exam, labs, and ECG findings are characteristic of unstable angina, where chest pain is caused by an insufficient supply of oxygen to the cardiac tissue. In these individuals, treatment consists of morphine, oxygen, nitrates, and aspirin, also known as MONA, as well as a statin and a beta blocker. Additionally, your patient will likely need an invasive coronary angiography with or without revascularization. Here's a clinical pearl. A non-ST elevated myocardial infarction, or NSTEMI, can present with similar history, physical exam, and ECG findings as unstable angina. But troponin levels are typically elevated in NSTEMI by definition. However, troponins may initially not be detectable and may even take hours to rise after presentation. So be sure to keep NSTEMI on your differential even if troponin is normal. Okay, let's return to the ABCDE assessment and take a look at stable patients. If your patient is stable, obtain a focused history and physical exam. Your patient will typically describe their chest discomfort or pain as a heavy pressure that is worse with exertion, cold weather, or highly stressful situations, and improves when these conditions subside. Your patient might also report shortness of breath with exertion. They may also have ASCVD risk factors such as increasing age, male sex, hypertension, diabetes mellitus, hyperlipidemia, tobacco use, and a family history of premature CAD. Okay, moving on to the physical exam, you may find elevated blood pressure, decreased peripheral pulses, and bruits, which are all evidence of atherosclerotic disease. You may also see xanthelasmas, or yellow cholesterol deposits on the eyelids, which indicate underlying hyperlipidemia. Finally, you might detect nicotine-stained fingertips in patients that use tobacco. These findings should make you suspect CAD, particularly stable angina. Now, here's a high-yield fact. The key thing that distinguishes stable from unstable angina is that pain improves with rest in stable angina, while pain remains present even at rest with unstable angina. You should also keep in mind that if your patient is a biologically female individual, has a positive history of diabetes mellitus, and reports back or epigastric burning or stabbing pain, you should think of atypical angina. Now that you suspect CAD, your next step is to order labs like a high-sensitivity troponin, fasting lipid panel, and hemoglobin A1C. Also, you should obtain a 12-lead ECG. Labs typically reveal troponin levels as normal, lipid panel will reveal an elevated LDL, and hemoglobin A1C elevated too, which is common in patients with poorly controlled diabetes. On the flip side, ECG could be normal or show inverted T waves, which is a repolarization abnormality, pathological Q waves, which indicate an old myocardial infarction, or a left bundle branch block. All these findings are highly suggestive of CAD causing stable angina. So your next step is to assess the pretest probability of obstructive CAD. You can do this by using the patient's age, sex, chest pain symptoms, and risk factors. This allows you to stratify the patient into a low, intermediate, or high risk group and determine the appropriate type of management. Okay, let's first look at individuals who are at low risk. Individuals who are low risk likely have non-obstructive CAD and do not require additional testing. Instead, you should encourage lifestyle modifications such as a diet rich in fruits, vegetables, whole grains, and fish, as well as 150 minutes of moderate exercise each week, often divided up as 30 minutes 5 times a week, and sleep hygiene. Counsel your patient on tobacco cessation and weight loss, annual influenza vaccines, and mental health. Next, start your patient on daily antiplatelet therapy with aspirin or clopidogrel. Additionally, address their underlying risk factors and comorbidities by optimizing therapy for hyperlipidemia, hypertension, and diabetes mellitus. Finally, schedule regular follow-ups every 3 months to reevaluate the patient's condition. Here's a clinical pearl. Non-obstructive CAD, sometimes called functional CAD, is typically associated with coronary vasospasm. Meanwhile, obstructive CAD, sometimes called structural CAD, is characterized by gradual narrowing of the coronary arteries, typically from atherosclerosis. Now, let's switch our focus to intermediate risk individuals who require additional testing to determine the best treatment plan. First, order a stress test based on your assessment of the patient's ability to exercise. If they are able to exercise, assess their baseline ECG findings. If normal, proceed with an exercise stress test, like use of a treadmill with ECG. However, if the baseline ECG is abnormal, you'll need an exercise stress test, like the use of a treadmill, but this time with echocardiogram or nuclear imaging to look for ischemic changes. On the flip side, if your patient can't exercise, then order a pharmacologic stress test with imaging instead. Use medications like adenosine, dipyrimadol, or dobutamine to stress the heart, and imaging methods like echocardiogram or nuclear imaging to look for signs of ischemia. All right, once done, assess the stress test results. Assessing the stress test results will allow you to confirm the severity of the ischemia. No ischemia and mild ischemia confirm the diagnosis of non-obstructive CAD. In these patients, treatment consists of counseling on lifestyle modifications, daily antiplatelet therapy, and optimizing the treatment of their risk factors and comorbidities. Additionally, if stable angina is present, treat with nitrates and beta blockers, as well as ranolazine if needed. Finally, don't forget to do regular follow-ups every 1 to 3 months. On the flip side, if the stress test reveals moderate to severe ischemia, then your patient has obstructive CAD and will need invasive coronary angiography with or without revascularization. They will also require the same treatment as non-obstructive disease after their procedure. Lastly, let's go back and discuss a high-risk individual. This suggests obstructive CAD. These patients will need invasive coronary angiography with or without revascularization. Additionally, they will require the same treatment as non-obstructive disease after their procedure. Here's a clinical pearl. Patients who fail revascularization or who have severe obstruction involving left main or multivessel coronary artery diseases may need a coronary artery bypass graft or CABG, where coronary grafts are used to direct blood around artery stenoses and obstructions. A CABG is often used as a last or emergent operation, as it is a major surgical procedure. All right, as a quick recap, if you suspect CAD, first do an ABCDE assessment to determine if your patient is unstable or stable. If unstable, stabilize their airway, breathing, and circulation. Once stabilized, obtain a focused history and physical and order labs and ECG, which will help you diagnose CAD with acute coronary syndrome. In these individuals, start monotherapy, a statin, and a beta blocker. Your patient will likely need invasive coronary angiography with or without revascularization. On the other hand, in stable individuals with CAD, first determine the risk of obstructive CAD based on atherosclerotic risk factors. Low-risk patients likely have non-obstructive disease, so they don't require additional testing. The treatment primarily relies on lifestyle modifications, antiplatelet therapy, and addresses underlying risk factors and comorbidities. For intermediate risk patients, obtain a stress test based on their ability to exercise. Next, assess test results for signs of ischemia. If the stress test shows no or mild ischemia, then treat with the same non-obstructive CAD management, but don't forget to manage angina, if present, with nitrates, beta blockers, or ranolazine. However, if the test reveals moderate or severe ischemia, your patient has obstructive CAD and will need invasive coronary angiography and revascularization. And finally, high-risk patients likely have obstructive CAD and will also need invasive coronary angiography and revascularization.
Coronary artery disease can lead to myocardial ischemia, which is when the myocardium isn't getting a sufficient blood supply, so there isn't enough oxygen to meet the heart's demands. And coronary artery disease is characterized by a type of chest pain called angina pectoris, which can be due to either vasospastic disease or atherosclerotic disease. Vasospastic disease, also called Prinzmetal angina, is when, for unclear reasons, there's transient vasoconstriction of a coronary artery, leading to transient ischemia. These attacks generally happen at rest, during the night or early morning, and happen in clusters. Atherosclerotic disease is when a coronary artery narrows due to buildup of atherosclerotic plaque, and it can be further divided into stable angina, unstable angina, and myocardial infarction. Unstable angina and myocardial infarction are collectively called acute coronary syndrome. Patients with stable angina don't feel pain at rest, but they do feel chest pain during intense physical exercise, because that's when the myocardium has increased oxygen demand, which leads to transient or demand ischemia. The chest pain stops when the exercise stops, so these patients often just rest rather than going to the emergency department or ED. Now, angina is considered unstable if it presents at rest, or if it becomes more frequent, lasts longer, or happens with less exertion than previous episodes of angina. Are released into the bloodstream, so their blood levels rise. But it can take up to 6 hours for the elevation of cardiac biomarkers to be detectable, so troponin levels should be checked initially and then again after 6 hours. If troponins are negative, it might be that the patient is having unstable angina, a short attack of Prinzmetal angina, or a non-cardiac cause of chest pain. If troponins are positive, that means there's cardiomyocyte death, which means that it's a myocardial infarction. Next, it's important to get a clear history of the chest pain, and the acronym OPQRST can help. O stands for onset, which is usually sudden and at rest, but might also happen while exercising. P stands for provocation, so which activities provoke pain, and palliation, so which activities alleviate pain. Generally speaking, angina pectoris doesn't improve or worsen with respiration or position. Q stands for quality, which might be described as a pressure, heaviness, tightness, fullness, or squeezing. R stands for radiation, which is most often to the neck, jaw, and left arm. S stands for sight, which typically is substernal or in the left chest, and the pain is usually diffuse and difficult to localize. If a person can point to the site of pain with a single finger, it's less likely due to cardiac ischemia. Finally, T stands for time course, which typically lasts over 30 minutes. Myocardial ischemia can also cause dyspnea, palpitations, nausea, and increased sweating. And some important risk factors include being over 55 years old, being male, hypertension, hypercholesterolemia, diabetes mellitus, smoking, obesity, and family history of first-degree relatives with premature coronary artery disease, so males before the age of 55 years and females before the age of 65. Also, women, older adults, and patients with diabetes often have atypical presentations, like just dyspnea, epigastric pain or discomfort, syncope, or sudden death from cardiac arrest. In individuals having myocardial ischemia, so those with unstable angina and myocardial infarction, as well as Prinzmetal angina, nitrates should be used immediately to help widen the coronary arteries and help increase blood flow to the heart, which should relieve the pain and decrease the blood pressure. 3 sublingual doses of 0.4 milligrams of nitrates are generally given, 1 every 5 minutes. If the patient has Prinzmetal angina, nitrates will lead to an immediate and full recovery, so nitrates help with both diagnosis and management. And if the patient has unstable angina or a myocardial infarction, then pain and blood pressure should improve. So if there's really no improvement at all, then intravenous nitrates might be needed. Nitrates are contraindicated in cases of hypotension, myocardial infarction of the right ventricle, and recent use of PDE5 inhibitors, like sildenafil, because in these situations, nitrates can cause really severe hypotension. Additionally, some patients with ongoing chest pain or tachycardia should be given beta blockers to lessen cardiac demand. And if the patient is hypertensive, intravenous beta blockers can be used. Beta blockers are contraindicated in Prinzmetal angina because they can worsen the coronary vasoconstriction. They're also contraindicated in bradycardia, cardiogenic shock, and acute decompensated heart failure, all of which can worsen with beta blockers. Beta blockers are also contraindicated in cocaine-related acute coronary syndrome. That's because cocaine triggers a huge release of sympathomimetic amines. And if the beta receptors are blocked by the beta blockers, then those sympathomimetic amines end up binding to alpha receptors, causing severe coronary vasoconstriction. Now, patients with underlying heart failure must be given an intravenous loop diuretic like furosemide. In addition, patients with severe and persistent chest pain can be given intravenous morphine sulfate at an initial dose of 2 to 4 milligrams, repeated in 5 to 15-minute intervals. Basically, every patient suspected of having myocardial ischemia should get a standard 12-lead electrocardiogram, or ECG, within 10 minutes of arrival to an ED. And the initial ECG is often not diagnostic, so it should be repeated at 5 to 10-minute intervals if there is high suspicion for myocardial ischemia. In addition to making sure that there's a normal sinus rhythm, if we suspect myocardial ischemia, the most important thing is to check the ST segment. In healthy individuals, the normal ST segment has a slight upward concavity. In stable angina, the ST segment is normal, and in unstable angina, the ST segment is generally normal or depressed. Now, myocardial infarctions can be divided into non-ST segment elevation myocardial infarction, or NSTEMI, and ST segment elevation myocardial infarction, or STEMI. In an NSTEMI, the ST segment might be normal, but there might be an ST depression that's more than 0.5 millimeters or 0.05 millivolts in 2 or more contiguous leads, or deep T-wave inversions above 1 millimeter or 0.1 millivolts. STEMI is when there's an ST elevation above 1 millimeter or 0.1 millivolts in 2 or more contiguous leads or new left bundle branch block. ST elevation happens when there's full thickness involvement of the myocardium. The location of a myocardial infarction can be determined by which ECG leads show ST elevation. In anterior wall ischemia, ST elevation will show up in the precordial leads, so V1 to V6. In anteroseptal ischemia, it'll show up in leads V1 to V3. Apical or lateral ischemia will show up in leads AVL and 1, and leads V4 to V6. Inferior wall ischemia will show up in leads 2, 3, and AVF. Right ventricular ischemia will show up in the right-sided precordial leads, which can be obtained by placing leads V1 to V6 in a mirror image position on the right side of the chest. And posterior wall ischemia will show in the septal precordial leads, so V1 and V2, and posterior precordial leads. Now, ST depression in V1 and V2 is also important, because these anterior leads mirror the ST elevation that might be happening in the posterior precordial leads V7, V8, and V9, which are not included in the standard 12-lead ECG. In other words, they represent a posterior STEMI, which needs to be treated as a STEMI and not like an NSTEMI. Now, Prinz metal angina might present with a normal or depressed ST segment in short attacks, or ST elevation in long attacks. However, the ECG changes can only be found during the attack, so to spot it, the patient should be put on Holter monitoring, which is a device that records ECG tracings for 24 hours or longer. Now, if there's no evidence of ischemia, you should do further testing in the ED setting, such as a stress test, which measures the heart's ability to respond to external stress in a controlled clinical environment. The stress response is induced by exercise or by drug stimulation with dobutamine. Cardiac stress tests compares the coronary circulation while the patient is at rest with the coronary circulation during physical exertion. A negative stress test means that the coronary arteries are able to dilate and provide more blood to the myocardium when needed, and that the chest pain is likely from a non-cardiac cause. A positive stress test means that the coronary arteries aren't able to dilate, and that the chest pain is likely due to unstable angina, which is managed the same way as an NSTEMI. So a patient with unstable angina or NSTEMI needs urgent treatment with antithrombotic therapy. Both oral antiplatelet therapy with a P2Y12 inhibitor like clopidogrel, in addition to aspirin, and anticoagulant therapy with heparin to prevent thrombosis or embolism from an ulcerated plaque. After that, individuals at high risk of short-term adverse events should be identified. those are ones with hemodynamic instability or cardiogenic shock, left ventricular dysfunction or heart failure, recurrent or persistent rest angina despite intensive medical therapy, new or worsening mitral regurgitation, new ventricular septal defect, or sustained ventricular arrhythmias. These high-risk patients should get immediate coronary angiography, as well as revascularization, which is also called reperfusion therapy, to restore coronary perfusion. Low-risk patients should get coronary angiography and reperfusion therapy within 12 hours of symptoms. Patients who lack these features should undergo early risk stratification to identify individuals at high risk of long-term adverse events, who therefore should be treated with an early invasive strategy as well. Two common scoring systems are the TIMI risk score and the GRACE score. The TIMI score considers 7 factors, each accounting for 1 point in the final score. Age over 65, at least 3 risk factors for coronary artery disease, prior coronary artery stenosis of 50% or more, ST depression, at least 2 anginal events in the prior 24 hours, elevated serum cardiac biomarkers, and use of aspirin in the prior 7 days. The GRACE score considers 8 factors: age, systolic blood pressure, heart rate, ST segment deviation, so either elevation or depression, cardiac arrest at admission, serum creatinine concentration, serum cardiac biomarkers, and Killip class. The highest total possible score is 363. Now, the Killip classification takes into account physical examination findings like rales or crackles in the lungs, an S3 heart sound, elevated jugular venous pressure, acute pulmonary edema, cardiogenic shock or hypotension, oliguria, cyanosis, or sweating, as well as the development of heart failure. Patients at high risk using the GRACE risk scores are usually referred for coronary angiography and reperfusion therapy. Specifically, if their GRACE score is higher than 140, they're referred for early therapy, so within 24 hours from diagnosis. And if their GRACE score is between 109 and 140, they're referred for delayed therapy, so within 72 hours from diagnosis. Lower risk patients might get non-invasive testing like a stress test to determine their need for coronary angiography and reperfusion therapy. Moving on, patients with STEMI need immediate, so within 2 hours from diagnosis, coronary angiography and reperfusion therapy, ideally within 12 hours from symptom onset. The 2 ways to do reperfusion therapy are mechanical reperfusion with primary percutaneous coronary intervention, or PCI, which usually includes the insertion of a stent to keep vessels open and is strongly preferred. The alternative approach is to do reperfusion therapy using medications, sometimes called pharmacological reperfusion, using fibrinolytics. Typically, that's done when primary PCI can't be done within 2 hours of arrival to the ED. If more than 12 hours have passed since symptom onset, reperfusion should generally not be performed, but emergent PCI might be done for patients with ongoing ischemia or those at high risk of death. After reperfusion therapy, or in cases where it wasn't done, oral antiplatelet therapy with aspirin and a P2Y12 inhibitor, plus anticoagulant therapy with heparin is given to patients. Alright, as a quick recap. Coronary artery disease can be due to either vasospastic disease, so Prinzmetal angina, or atherosclerotic disease, so stable angina, unstable angina, and myocardial infarction, which is further divided into NSTEMI and STEMI. Patients presenting to the ED with suspected myocardial ischemia should be given aspirin, nitrates, morphine, get troponin sent, and get an ECG looking for ST segment changes, all within 10 minutes. In Prinzmetal angina, there's immediate and full recovery with nitrates. If the ST segment is normal or depressed and troponins are negative, it's unstable angina. If the ST segment is normal or depressed and troponins are positive, it's NSTEMI. If the ST segment is elevated, it's a STEMI. So you don't need to wait for the results of the troponins, but they'd definitely be elevated. Unstable angina and NSTEMI are managed with a combination of antiplatelet and anticoagulation therapies, and a risk factor assessment is done to decide if they need immediate coronary angiography and reperfusion therapy. STEMI is managed with emergency reperfusion therapy, either with PCI or systemic thrombolysis. And after reperfusion therapy, patients are given a combination of antiplatelet and anticoagulation therapies.
In an urban emergency department, 3 people came in for chest pain. The first is Anish, a 54-year-old man with a known history of hypertension, hyperlipidemia, and 25-pack years smoking. He's complaining of shortness of breath and squeezing retrosternal chest pain that radiates to his neck, jaw, and left arm. He's been having these episodes, but they only come after riding his bicycle for at least 20 minutes and are relieved once he rests. Investigations reveal a normal ECG and normal troponin levels. Next is Erica, a 66-year-old woman with a history of diabetes mellitus who complains of sudden onset shortness of breath, fatigue, and dizziness, but no chest pain. An ECG reveals ST segment depression, and troponin levels are elevated. Finally, there's Tyrion, a 45-year-old man with a known history of hypertension, diabetes, and hyperlipidemia. He complains of epigastric abdominal pain at rest, shortness of breath, sweating, and lightheadedness for the past 30 minutes. His blood pressure is 80/60, and his heart rate is 45 beats per minute. An ECG reveals ST segment elevation in leads 2, 3, and AVF. All 3 of them have coronary artery disease, which is defined as an imbalance between myocardial oxygen demand and supply from the coronary arteries. Reduced oxygen supply to the heart is defined as myocardial ischemia, which results in a severely reduced ability of the heart muscle to contract. If this is prolonged, it can go on to cause myocardial infarction, otherwise known as heart attack, which refers to death of heart muscle. Now, coronary artery disease is usually caused by atherosclerosis of the coronary arteries, resulting in myocardial ischemia. Risk factors for atherosclerosis can be divided into non-modifiable ones, which include age, with men greater than 45 years and women greater than 55 years being at risk, and family history of coronary artery disease, as well as modifiable ones, like lipid abnormalities including elevated LDL or low HDL levels, as well as hypertension, diabetes mellitus, and smoking. Coronary artery disease can present in many ways, including stable angina, Prince-Meadow angina, acute coronary syndrome, which includes unstable angina, non-ST segment elevation myocardial infarction, or NSTEMI, ST segment elevation myocardial infarction, or STEMI, chronic ischemic heart disease, and sudden cardiac death. Now, aside from atherosclerosis, there are other less common causes of coronary artery disease, such as coronary artery embolus, vasculitis, and vasospasm. In a coronary embolism, pieces of a clot from another site break off and travel into a coronary artery, occluding it. Risk factors for coronary embolism include atrial fibrillation, infective endocarditis, a left atrial or ventricular thrombus, or in individuals undergoing cardiac catheterization. As for vasculitis, coronary artery disease in young children should prompt you to consider Kawasaki disease, a medium vessel vasculitis that classically causes a coronary artery aneurysm. Additionally, other vasculitides like polyarteritis nodosa can also cause coronary artery disease. Now, coronary artery vasospasm, meaning the smooth muscles around the arteries constrict extremely tightly, may also reduce blood flow and result in coronary artery disease. Then, another cause of coronary artery disease is aortic valve stenosis. See, the right and left coronary arteries branch off the base of the aorta, and so in aortic stenosis, not enough blood gets through the aorta and into the coronaries, resulting in myocardial ischemia. Also, any cause of concentric ventricular hypertrophy, such as aortic valve stenosis, hypertension, or hypertrophic cardiomyopathy, may result in coronary artery disease because you essentially have more heart muscle to supply. Now let's take a look at the presentations of coronary artery disease, starting with stable angina. This occurs secondary to myocardial ischemia, caused by a fixed atherosclerotic plaque occluding more than 75% of the coronary artery lumen. What you must remember here is that this results in reversible cell injury. An infarction, on the other hand, is when there's irreversible cell injury or cell death. Now, stable angina manifests as a deep, poorly localized, squeezing, crushing, or suffocating retrosternal pain that may radiate to the arm, jaw, or neck. Lots of adjectives. It's often accompanied by other symptoms, such as shortness of breath, nausea, vomiting, diaphoresis, fatigue, or dizziness. A high-yield fact is that this chest pain is reproducible during any activity that increases myocardial oxygen demand, such as physical exertion or emotional stress, and is relieved within 5 minutes by rest or sublingual nitroglycerin. The term stable refers to the atherosclerotic plaque itself, which hasn't ruptured yet and is structurally stable. Now, sometimes in stable angina, an atherosclerotic plaque can cause near total occlusion of the coronary artery, yet individuals may not develop infarction. The reason is because atherosclerotic plaques grow slowly, giving time for the heart to develop collateral circulation that supplies the hypoperfused area. The ECG in stable angina is typically normal at rest, but may become abnormal on stress testing, which measures the heart's ability to respond to external stress in a controlled clinical environment. The stress response is induced by exercise or by stimulation with medications, like dipyridamol. Now, when a vasodilating medication like dipyridamol is given to an individual with stable angina, coronary still syndrome may occur. That's because it causes vasodilation of all coronary arteries, except the ones which are obstructed, because beyond the obstruction, the coronary artery is already maximally dilated. The end result is that blood is diverted, or stolen, away from the ischemic myocardium to non-ischemic areas, which further worsens the ischemia. This shows in the ECG as an ST segment depression. However, a high-yield fact is that cardiac biomarkers like troponin levels are always normal because there's ischemia but no infarction. A variant of angina is called, variant angina or princemetal angina. Here, there's no atherosclerotic plaque occluding the lumen. Instead, the coronary artery undergoes vasospasm, narrowing the lumen. Individuals typically develop angina at rest, and triggers include smoking, cocaine, alcohol, and triptans. For example, the exam may tell you about an individual with a history of migraines, and triptans like sumatriptan are one of the treatment options for migraine. Due to transmural ischemia, a 24-hour ECG called a Holter monitor classically shows transient elevation of the ST segment, but troponin levels are normal because, once again, there is no infarction. To help with the diagnosis, low doses of vasoconstrictive medication called ergonovine are given to provoke vasospasm, which results in transient ST segment elevation. Treatment includes calcium channel blockers and nitroglycerin, which relax the vascular smooth muscle, and cessation of the trigger. Okay, in stable angina, the atherosclerotic plaque was fixed and not disrupted. But when the atherosclerotic plaques are disrupted, we get the next three disorders: unstable angina, NSTEMI, and STEMI. These three are huddled together under the umbrella of acute coronary syndrome, or ACS. An acute coronary syndrome typically manifests as sudden new-onset angina or an increase in the severity of an existing stable angina. This may be an increase in the frequency or intensity of episodes, when they can be triggered by less exertion than before, or when symptoms occur at rest. Sometimes, though, there can be atypical presentations. Older people, females, and individuals with diabetes can present without chest pain. Instead, they come with vague symptoms like shortness of breath, fatigue, and dizziness. Now, plaques are made of a fibrous cap and a necrotic lipid core, and the composition of the plaque determines the risk of rupture. The high-yield concept here is that a thin fibrous cap and a rich lipid core mean that the plaque is at high risk of rupture. When a plaque ruptures, the underlying collagen is exposed, and in response, platelets quickly aggregate, forming a thrombus. Okay, in unstable angina, the atherosclerotic plaque ruptures and causes near total but incomplete occlusion of the coronary artery. The ECG shows ST segment depression or T-wave inversion, but troponin levels are normal because there's no myocyte necrosis. But if the troponin levels are elevated, then we now call it NSTEMI, which signifies an infarction beneath the endocardium, also called a subendocardial infarct. The infarct happens here because the coronary vessels run along the epicardium, the outer one-third of the heart wall. So this is the farthest area from the blood supply. Now, the reason we call it NSTEMI is because on ECG, a subendocardial infarct manifests with changes like ST depression or T-wave inversion. However, it never shows ST segment elevation. If there's ST segment elevation, then it's a STEMI, which happens when the thrombus occludes 100% of the lumen. The ST segment elevation signifies an acute transmural infarction, meaning it involves the whole wall. Troponin levels are also elevated in a STEMI, but it's the ST segment elevation on an ECG that immediately clinches the diagnosis. The reason why we're talking about troponin, of which there are two types, troponin I and T, is that together with CKMB, which is a combination of creatinine kinase enzymes M and B, they make up what's known as the key cardiac biomarkers. So when there's been irreversible damage to heart cells, their membranes become damaged and these proteins and enzymes inside escape and can enter the bloodstream. Both troponin I and T levels can be elevated in the blood within 2 to 4 hours after infarction and usually peak around 48 hours, but can stay elevated for 7 to 10 days. CKMB starts to rise 2 to 4 hours after infarction, peaks around 24 hours, and returns to normal after 48 hours. Since CKMB returns to normal more quickly, it can be useful to diagnose reinfarction, a second infarction that happens after 48 hours, but before troponin levels go back to normal. Bear in mind, though, that unlike troponins, CKMB is not specific for cardiac injury, and it may also be elevated in cases of skeletal muscle damage elsewhere in the body, like trauma, heavy exertion, and myopathy. Now, for your exam, you might be asked to locate the infarct and the vessel involved based on the ECG. This can be done by locating which leads had the ST elevation. V1 and V2 involvement is an anteroseptal MI, which means the left anterior descending artery, or LAD, is involved. V3, V4 involvement is an anteroapical MI, which means the distal part of the LAD is involved. V5, V6 involvement is an anterolateral MI, which involves the LAD or left circumflex artery. Lateral MI involves leads 1 and AVL, and the left circumflex is occluded. Inferior MI involves leads 2, 3, and AVF, with the right coronary artery being the culprit. Inferior wall myocardial infarctions are very high yield because they can also present as epigastric abdominal pain instead of chest pain. RCA occlusion can also cause right ventricular infarction, but right-sided leads would have to be obtained to see that. Finally, Whenever there's ST depression with tall R waves in V1 to V3, then a posterior MI involving the posterior descending artery is a possibility. Therefore, posterior leads V7 to V9 must be obtained in such a scenario. Okay, exams love to ask about the pathological manifestations and complications of a myocardial infarction based on the elapsed time. Therefore, let's take a look at a timeline illustrating this. In the first 24 hours, the heart looks grossly normal. On light microscopy, after 4 hours, coagulative necrosis begins and the necrotic myocardial cells hypercontract, giving them a wavy appearance. During this period, arrhythmias can occur because the infarction disrupts the electrical flow through the myocardium. Premature ventricular arrhythmias, or PVCs, are the most common arrhythmia, but these are benign. On the other hand, ventricular arrhythmias like ventricular tachycardia or fibrillation are the most common cause of sudden cardiac death, which is death within 1 hour of symptom onset. A common way the exam might try to confuse you is by telling you that the individual is an athlete, which makes you inclined to choose hypertrophic cardiomyopathy. However, ventricular arrhythmias due to coronary artery disease are a more common cause of death in athletes over 35 years old, whereas hypertrophic cardiomyopathy is more common in those under 35 years old. Other complications include heart failure and cardiogenic shock, which are the most common cause of death from MI in the hospital. In the case of right coronary artery occlusion, the infarcted right ventricle dilates, pushing the interventricular septum into the left ventricular cavity, causing decreased left ventricular filling, which results in a decreased stroke volume and hypotension. You can differentiate between right and left ventricular failure clinically because in a right ventricular failure, the lungs are clear on auscultation and there is elevation of jugular venous pressure. It's important to look for a right ventricular MI because venodilating medications like nitroglycerin are contraindicated in these cases as they further decrease the preload, worsening the hypotension. 1 to 3 days after the infarction, the affected area appears grossly red. On light microscopy, there is extensive coagulative necrosis, and a large amount of neutrophils have infiltrated, causing acute inflammation. That inflammation can spread towards pericardium, causing post-infarction fibrinous pericarditis. This presents with a low-grade fever and sharp pleuritic chest pain, meaning it increases with inspiration. Okay, 3 to 14 days after the infarction, macrophages come over to clean up the necrotic mess, and soft yellow granulation tissue begins to develop to repair the infarcted tissue. This soft granulation tissue is quite weak, so there's a risk of interventricular septum or ventricular free wall rupture. Interventricular septum rupture typically presents around 3 to 5 days as a left to right ventricular septal defect, which presents as a new holosystolic murmur at the left sternal border and increased oxygen saturation in the right ventricle. Ventricular free wall rupture classically occurs in anterior wall STEMIs and presents at around 5 to 14 days. As a result, large amounts of blood leak into the pericardial cavity, causing a pericardial tamponade. Sometimes, the rupture is contained by the adherent pericardium, producing a balloon-like sac of blood called a ventricular pseudoaneurysm. This pocket of blood is static, and stasis promotes clotting, producing what's called a mural thrombus. Bits of this thrombus can embolize to the systemic circulation, resulting in peripheral complications like a stroke. Okay, if someone previously had an MI or they have ventricular hypertrophy because of something like hypertension, then this actually protects them against wall rupture due to fibrosis and a thick wall, respectively, a rare instance in which pathology protects from another pathology. Another complication is rupture of the papillary muscles, small muscles that anchor to the atrioventricular valves, by the chordae tendineae. This usually occurs 2 to 7 days post-infarction. Normally, the anterolateral papillary muscle receives a dual blood supply from both the LAD and the left circumflex artery. The posteromedial papillary muscle, however, is solely supplied by the posterior descending artery, so it's more at risk of rupture, and this can cause acute onset mitral regurgitation and pulmonary edema. Alright, now 2 weeks to a couple of months post-MI, macrophages invade the tissue and the healing process begins with the formation of granulation tissue, which is a type of scar tissue that's yellow and soft, along with some new blood vessels, in a process called neovascularization. This scar tissue may cause the ventricular wall to bulge out, forming a true ventricular aneurysm. The affected segment is made of scar tissue, so it doesn't contract. Therefore, there's a risk of developing heart failure as well as a mural thrombus due to stasis of blood in that area. But unlike a pseudoaneurysm, the ventricular wall is now strong, so there's no risk of rupture. Another complication during this period is Dressler syndrome, a fibrinous pericarditis that occurs secondary to formation of autoantibodies that target serosal surfaces like the pericardium. Now, as for treatment, unstable angina and NSTEMI are managed with a combination of antiplatelet and anticoagulation therapies to prevent further thrombosis or embolism from an ulcerated plaque. After that, some patients may also need immediate coronary angiography and revascularization, which is also called reperfusion therapy, to restore coronary perfusion. STEMI is managed with emergency reperfusion therapy, either with percutaneous coronary intervention or PCI, where a tiny catheter is used to place a stent in the coronary artery to physically open up a blood vessel, or fibrinolytic therapy, which uses medications to break down fibrin in blood clots. Then, after reperfusion therapy, patients are given a combination of antiplatelet and anticoagulation therapies. Alright, so reperfusion therapy focuses on reestablishing blood flow to the dying heart cells. Remember that within 60 seconds after the onset of total ischemia, we have myocardial cell injury and contractility loss. However, for about 30 minutes, this remains reversible, which is known as myocardial stunning. So if we manage to reestablish blood flow within the first 30 minutes following blockage, these myocardial cells can be salvaged and contractility will be gradually returning to normal over the next several hours to days. However, after about 30 minutes, ischemic injury becomes irreversible, so no matter what we do, these cells will be destroyed and removed. Now, an important complication of reestablishing perfusion or reperfusion therapy is reperfusion injury, where tissue is damaged by returning blood flow. And this is thought to happen because of a couple mechanisms. First, blood flowing back to cells brings this influx of calcium, and since calcium leads to muscle contraction, the irreversibly damaged cells contract. And since they've been irreversibly damaged, they get stuck like that and can't relax. This shows up on histology as this characteristic contraction band necrosis. Also though, blood brings along oxygen, which paradoxically can actually lead to more cellular damage. The conditions in an ischemic heart seem to cause an increased conversion of returning oxygen to reactive oxygen species, which go on to damage more heart cells. Okay, to review. Coronary artery disease is usually an atherosclerotic disease of the coronary arteries and includes a variety of presentations including stable angina and acute coronary syndrome. Stable angina occurs secondary to a stable atherosclerotic plaque, occluding at least 75% of the coronary artery, and presents with exertional chest pain and is relieved by rest and nitroglycerin. ECG and troponin levels are normal. ACS occurs when the atherosclerotic plaque is disrupted, resulting in thrombosis. ACS includes unstable angina, NSTEMI, and STEMI. Unstable angina presents as new onset angina or a change in the pattern of symptoms. ECG shows ST segment depression or T-wave changes, but troponin levels are normal. And STEMI is similar to unstable angina, but troponin levels are elevated. STEMI shows ST segment elevation, Q waves, and elevated troponin levels. Prince-metal angina is not due to atherosclerotic disease, but is caused by coronary vasospasm and causes transient ST segment elevation with normal troponin levels. Okay, back to our cases. Anish has multiple risk factors for atherosclerosis, including hypertension, hyperlipidemia, and smoking. He's presenting with stable angina because his angina only comes when riding his bicycle and is relieved during rest. Erica has 2 risk factors for a silent MI. She's an elderly lady with diabetes mellitus. Her type of MI is NSTEMI because there is no ST segment elevation on the ECG and troponin levels are elevated. Tyrion came in with epigastric pain, and considering his risk factors and associated symptoms, this is a potential presentation of inferior MI. This was confirmed as the ECG showed STEMI in leads 2, 3, and AVF. Fortunately, the MI was caught early, and he's being treated with percutaneous coronary intervention.
Angina comes from the Latin angere, which means to strangle, and pectoris comes from pectus, meaning chest. So angina pectoris loosely translates to strangling of the chest, which actually makes a lot of sense because angina pectoris is caused by reduced blood flow, which causes ischemia to the heart muscle, or a lack of oxygen to the heart. Almost like the heart's being strangled, which causes terrible chest pain. Stable angina or chronic angina is the most common type of angina, and it usually happens when the patient has greater than or equal to 70% stenosis, meaning 70% of the artery is blocked by plaque buildup. This small opening that blood flows through might be enough to supply the heart during rest, but if the body demands more blood and oxygen, like during exercise or stressful situations, the heart has to work harder and therefore needs more blood and oxygen itself. It's during these times of exertion or emotional stress that people with stable angina have chest pain, since the blood flow isn't meeting the metabolic demands of the heart muscle, or myocardium. But the pain usually goes away with rest. In the majority of cases, the underlying cause of stable angina is atherosclerosis of one or more of the coronary arteries, the arteries supplying blood to the heart muscles. Other heart conditions that might lead to stable angina are ones that cause a thickened heart muscle wall, which would require more oxygen. This increase in muscle size can be due to hypertrophic cardiomyopathy from a genetic cause, or as a result from the heart having to pump against higher pressures, as is the case in aortic stenosis, which is a narrowing of the aortic valve, or hypertension. These larger, thicker heart muscles require more oxygen, and if the patients can't meet the increasing demands, they feel pain in the form of angina. Whatever the case, the heart needs blood, and if we look at the heart wall, there's 3 layers: the outermost layer, the epicardium, then the myocardium in the middle, and then the endocardium inside the heart. The coronary arteries start up in the epicardium, and then dive down and supply all the heart tissue. If blood flow is reduced or the myocardium is thicker, blood has a harder time reaching the deeper layer just under the endocardium, called the subendocardium. Therefore, the classic finding with angina is subendocardial ischemia, meaning less oxygen is reaching the region just under the endocardium. This ischemia is thought to trigger the release of adenosine, bradykinin, and other molecules that stimulate nerve fibers in the myocardium that result in the sensation of pain. That chest pain is usually described as feeling like pressure or squeezing, and it can radiate to the left arm, jaw, shoulder, and back, and sometimes is accompanied by shortness of breath and diaphoresis or sweating.
Usually the pain and symptoms last less than 10 minutes, generally 2 to 5 minutes, and subside after the exertion or stress is taken away, and therefore the heart muscle isn't demanding as much blood.
Now, unlike stable angina, which describes when patients have pain only during periods of exertion or stress, but not during rest, there's also unstable angina, which is when patients have pain during exercise or stress as well as during rest. It never really goes away. Unstable angina is usually caused by rupture of atherosclerotic plaque with thrombosis, meaning a blood clot forms on top of a mound of plaque. Although the occlusion might not block the entire vessel, there's now even less room for blood to flow by, and the heart tissue is starting to feel starved for oxygen even while pumping at a normal rate. Unstable angina, for the same reason as stable angina, involves subendocardial ischemia, and it should be treated as an emergency because patients are at a high risk of progressing to myocardial infarction or heart attack. The key distinction is that unstable angina means that the heart tissue is alive, but ischemic or starving for oxygen, whereas myocardial infarction means that the areas of the heart tissue have already begun to necrose or die.
Now, a third type of angina is vasospastic angina, also known as Prinzmetal angina, and patients may or may not also have atherosclerosis. Ischemia and resulting chest pain is due to coronary artery vasospasms, meaning the smooth muscles around the arteries constrict extremely tightly and reduce blood flow enough to cause ischemia. Episodes of vasospastic angina don't correlate with exertion and can happen anytime, including at rest. The underlying mechanism causing vasospasms isn't well understood, but likely involves vasoconstrictors like platelet thromboxane A2. Unlike both stable and unstable angina, in this case the coronary arteries constricted so severely that all layers of the heart wall being supplied are affected. Therefore, it's referred to as transmural ischemia.
Alright, so if we line these three up side to side, there's some important clinical similarities and differences. First, it's super important to remember that in each case, the injury to cardiomyocytes isn't permanent, meaning it's reversible and the cardiomyocytes don't die, which is how this differs from myocardial infarction. On an electrocardiogram, or ECG, both stable and unstable angina show an ST segment depression, since ischemia is limited to the subendocardium.
In contrast, vasospastic angina shows ST segment elevation due to transmural ischemia. Rest tends to relieve stable angina, whereas unstable angina and vasospastic angina can happen anytime, including at rest. In terms of medications, all three can be treated with nitroglycerin, which is a vasodilator that increases blood vessel diameter to allow more blood flow. In addition, vasospastic angina also responds to calcium channel blockers. Alright, as a quick recap. Angina pectoris is chest pain caused by reduced blood flow resulting in a lack of oxygen in the heart muscle. There are three types: stable angina, unstable angina, and vasospastic angina. Rest tends to relieve stable angina, but not the other two types, and all three can be treated with nitroglycerin.
Coronary steal syndrome is a condition that occurs due to dilation of coronary arteries in the presence of coronary artery disease, which is when there's a partial or complete blockage in the lumen of another coronary artery. The result is a redirection of blood flow from heart muscle supplied by the blocked artery to other regions of the heart. Coronary steal syndrome is a finding observed during a pharmacological cardiac stress test, which is used to diagnose coronary artery disease. Now, the heart pumps out blood for all of our organs and tissues to use, but the heart also needs blood. So it also pumps blood to itself through the coronary arteries on the outside of the heart. And coronary arteries are linked to one another through teeny tiny blood vessels called collateral vessels, which are normally in an inactive state, meaning blood doesn't flow through them. Now, with coronary artery disease, there's ischemia, or reduced blood flow to the region of myocardium supplied by that artery. In this context, collateral circulation may become active. For example, let's say two coronary arteries, A and B, are linked by a collateral vessel, and coronary artery B has developed a block. As a result of ischemia in the myocardium supplied by coronary artery B, the myocardial cells don't receive enough oxygen, which is called hypoxia. In response to hypoxia, myocardial cells release signaling molecules called cytokines, which cause dilation of the segment of coronary artery B beyond the blockage. This slightly improves the blood flow and ameliorates hypoxia. But at the end of the day, blood flow within coronary artery B is still decreased, while blood flow in coronary artery A remains the same. This creates a pressure gradient across the collateral vessel, which pulls blood from the region of higher pressure of coronary artery A through the collateral vessel and into the region of lower pressure or the dilated segment of coronary artery B. In other words, the low pressure region acts like a vacuum. Now the sudden gush of blood through the collateral vessel stretches its walls and deforms the endothelial cells, which stimulates the production of growth factors, like the vascular endothelial growth factor, or VEGF, from the vessel wall. These growth factors act on the collateral vessel wall and bring about two changes. First, they cause vasodilation, which allows more blood to flow through the collateral vessel. Second, they promote the proliferation of the smooth muscle cells in the vessel wall, which makes the vessel wall thicker and stronger. Over time, this results in maximal vasodilation beyond the obstruction, and it helps the collateral vessel redivert blood to the ischemic myocardium. But when a vasodilating medication like dipyridamole is given to an individual with coronary artery disease, coronary steal syndrome may occur. Dipyridamole is usually given intravenously for a pharmacological cardiac stress test, and the heart's response is observed on an electrocardiogram or ECG to diagnose cardiac ischemia. When the test is done in an individual with coronary artery disease, it results in vasodilation of all coronary arteries except the ones which are obstructed, because beyond the obstruction, the coronary artery is already maximally dilated. Dilation of the non-obstructed coronary arteries decreases the pressure within them. So if we look at coronary arteries A and B again, now a low pressure region is formed at both ends of the collateral vessel, one by the already dilated coronary artery B, and the other by the newly dilated coronary artery A. So the pressure gradient across the collateral vessel vanishes, resulting in diminished collateral circulation. The end result is that blood is diverted, or stolen, away from the ischemic myocardium to non-ischemic areas, which further worsens the ischemia. In severe cases, blood flow can be completely cut off, which results in myocardial infarction or the necrosis of a portion of myocardium. This typically happens if blood flow has been cut off for more than 20 minutes. Symptoms of coronary steal syndrome mimic that of a myocardial infarction and include a typical type chest pain, which is described as a squeezing pain or pressure that might radiate up to the left arm, jaw, shoulders, or back. It's often accompanied by other symptoms such as shortness of breath, diaphoresis or sweating, nausea, and fatigue. Coronary steal syndrome is diagnosed when the electrocardiogram shows an ST segment depression during a pharmacological cardiac stress test. A coronary angiography can be done to look for coronary artery obstruction and collateral vessel formation. Treatment of coronary steal syndrome involves opening up the obstructed coronary artery. A balloon angioplasty might be done, which is a minimally invasive endovascular procedure where a deflated balloon is inserted into the blockage, then inflated to open the artery up. Another procedure is a percutaneous coronary intervention, where a tiny catheter is used to place a stent in the coronary artery to physically open up a blood vessel. Alright, as a quick recap, coronary steal syndrome is a condition where there's a fall in blood flow to a certain section of the heart in favor of another during coronary vasodilation, typically caused by the use of vasodilators like dipyridamole in individuals with coronary artery disease. Common symptoms include typical type chest pain, which is described as a squeezing pain or pressure that might radiate up to the left arm, jaw, shoulders, or back, shortness of breath, diaphoresis or sweating, nausea, and fatigue. Coronary steal syndrome is diagnosed with the help of an ECG, which shows an ST segment depression, and coronary angiography, and treated using a balloon angioplasty or percutaneous coronary intervention.
According to the World Health Organization, cardiovascular disease is the leading cause of death worldwide, as well as in the US. Of those, a large proportion are caused by heart attacks, also known as acute myocardial infarctions or just myocardial infarctions, sometimes just called MIs. The word infarction means that some area of tissue has died due to a lack of blood flow, and therefore a lack of oxygen. Myo refers to the muscle, and cardial refers to the heart tissue. So with a heart attack, or MI, you have a death of heart muscle cells because of a lack in blood flow, a process called necrosis. Now, the heart's main job is to pump blood to your body's tissues, right? Well, the heart also needs blood, and so it also pumps blood to itself, using the coronary circulation. The coronary circulation is the system of small arteries and veins that help keep the heart cells supplied with fresh oxygen. Heart attacks happen when these small arteries become blocked and stop supplying blood to the heart tissue. And if this happens for long enough, heart tissue dies. Almost all heart attacks are ultimately a result of endothelial cell dysfunction, which relates to anything that irritates or inflames the slippery inner lining of the artery, the tunica intima. One classic irritant are the toxins found in tobacco, which float around in the blood and damage these cells. That damage then becomes a site for atherosclerosis, a type of coronary artery disease where deposits of fat, cholesterol, proteins, calcium, and white blood cells build up and start to block blood flow to the heart tissue. This mound of stuff has two parts to it: the soft, cheesy textured interior, and the hard outer shell, which is called the fibrous cap. Collectively, this whole thing's ominously called plaque. Usually, though, it takes years for plaque to build up, and this slow blockage only partially blocks the coronary arteries. And so, even though less blood makes it to the heart tissue, there's still blood. Heart attacks happen when there's a sudden, complete blockage or occlusion of a coronary artery. So let's see how that can happen. Since these plaques sit right in the lumen of the blood vessel, they're constantly being stressed by mechanical forces from blood flow. And interestingly, it's often the smaller plaques with softer caps rather than the larger ones with harder caps that are especially prone to break or get ripped off. Once that happens, the inner cheesy filling, which remember is this mix of fat, cholesterol, proteins, calcium, and white blood cells, is thrombogenic. And this means that it tends to form clots very quickly. So platelets, or blood clotting components in the blood, flow by and get excited, and they adhere to this exposed cheesy material. In addition to piling up, the platelets also release chemicals that enhance the clotting process. Now this happens super fast. Think about how quickly a small cut stops bleeding. That's a very similar process. It happens in a matter of minutes, right? And now that coronary artery is fully occluded. So now let's change views a bit. If we take a slice of the heart like this side being posterior or the back, and this being anterior or the front, with the left and the right ventricles here, and then we have the three most commonly blocked arteries, the left anterior descending or LAD, which supplies blood to the anterior wall and septum of the left ventricle, which accounts for about 40 to 50% of cases, the right coronary artery, or the RCA, which covers the posterior wall, septum, and papillary muscles of the left ventricle, accounts for about 30 to 40% of cases, and finally the left circumflex artery, or the LCX, which supplies the lateral wall of the left ventricle, about 15 to 20% of cases. Notice that the majority of these areas supply the left ventricle. Most heart attacks therefore involve the left ventricle, where the right ventricle and both atria, the upper chambers, aren't as often affected. Each of these areas is called the artery's zone of perfusion, and if we take a closer look at one of these zones, we'll see that basically you've got the endocardium, which is the smooth membrane on the inside of the heart, and then the myocardium, all the heart muscle, and then the epicardium, the outer surface of the heart, which is where the coronary arteries live. Let's say the LAD gets blocked. The area of perfusion is now at serious risk, and within about a minute, the muscle cells in this zone don't see enough oxygen and become ischemic, and the muscle layer's ability to contract is severely reduced. This initial stage is extremely sensitive, since the ischemic damage to cells in the perfusion zone is potentially reversible. After about 20 to 40 minutes, though, damage starts to become irreversible and the cells start to die, and this zone changes to a zone of necrosis, or dead tissue. Once lost, those cells can never return or regrow. That's why quickly identifying and treating an MI is super important. The first area affected is the inner third of the myocardium, since it's the farthest from the coronary artery and the last area to receive blood, and it's subject to higher pressures from the inside of the heart. If the blockage suddenly lyses or breaks down and blood flow returns, sometimes patients' damage will be limited to the inner third, and this would be called a subendocardial infarct. An ECG or electrocardiogram done at this point typically shows an ST segment depression, or in other words, it doesn't show ST segment elevation. So sometimes we call this an NSTEMI, which stands for non-ST elevation myocardial infarction. Other causes of this sort of subendocardial infarct would be severe atherosclerosis and hypotension, anything that ultimately leads to poor perfusion of the heart tissue. After about 3 to 6 hours, though, the zone of necrosis extends through the entire wall thickness, called the transmural infarct, which this time shows up as ST segment elevation on ECG, which is why they're sometimes called STEMIs, or ST elevation myocardial infarctions. So the difference between NSTEMIs and STEMIs is that NSTEMIs don't have ST segment elevation, and these are caused by partial infarct of the wall, whereas STEMIs have ST segment elevation and involve the whole wall thickness. Patients that have an MI will most commonly have severe and crushing chest pain or pressure that might radiate up to the left arm or jaw. They might have diaphoresis or sweating, nausea, fatigue, and dyspnea. All of these are either a direct result of an end organ, like the heart or the brain not getting enough perfusion, so think chest pain and dizziness, or from the sympathetic response from the body to help the heart work harder and preserve blood pressure, so think sweating and clammy skin. Many people also have referred pain, where the nerves in the heart are irritated, but that pain can be felt in the jaw, shoulder, arm, or back instead. In addition to an ECG, labs can be very useful in diagnosing an MI. When there's been irreversible damage to heart cells, their membranes become damaged and the proteins and enzymes inside escape and can enter the bloodstream. 3 key ones are troponin I, troponin T, and CKMB, which is a combination of creatine kinase enzymes M and B. Both troponin I and T levels can be elevated in the blood within 2 to 4 hours after infarction, and usually peak around 48 hours, but stay elevated for 7 to 10 days. CKMB starts to rise 2 to 4 hours after infarction, peaks around 24 hours, and returns to normal after 48 hours. Since CKMB returns to normal more quickly, it can be useful to diagnose reinfarction, a second infarction that happens after 48 hours, but before troponin levels go back to normal. A second heart attack happens following 10% of MIs. A major complication with MIs are arrhythmias, or abnormal heart rhythms, with the highest risk being immediately following an MI, since the damage or injury can disrupt how the cells conduct electrical signals. Kind of along the same lines, depending on how much contractile or muscle tissue is affected, patients' hearts might not be able to pump enough blood to the body, resulting in cardiogenic shock. In the days following an infarction, the tissue around the infarcted area becomes inflamed and is invaded by neutrophils, which can lead to pericarditis, inflammation of the pericardium. In the next couple weeks, macrophages invade the tissue, and the healing process begins with the formation of granulation tissue, which is new connective tissue that's yellow and soft. At this phase, the tissue is most at risk of myocardial rupture. After 2 weeks to several months, the cardiac tissue scarring process finishes, and the resulting tissue becomes grayish-white in color. Since the scar tissue doesn't help pump blood, over time the remaining heart muscle can grow or change shape to try and compensate for these lost cells and pump harder, but they ultimately continue to fail, which can lead to heart failure. Now, a potentially life-saving treatment that can be done immediately following an MI is fibrinolytic therapy, which uses medications to break down fibrin in blood clots.
An angioplasty might also be done, which is a minimally invasive endovascular procedure where a deflated balloon is inserted into the blockage and then inflated to help open up the artery.
And finally, percutaneous coronary intervention might also be performed, where a tiny catheter is used to place a stent in the coronary artery to physically open up the blood vessel. Each of these focuses on re-establishing blood flow to the dying heart cells, since time is tissue. If early enough following blockage, some of these cells that haven't entered into the irreversible stage can be salvaged and saved, while the others will be destroyed and removed. This can improve both short-term and long-term function as well as prevent further damage and reduce the overall zone of necrosis. Now, an important complication of reestablishing perfusion, or reperfusion therapy, is reperfusion injury, where tissue is damaged by returning blood flow. And this is thought to happen because of a couple mechanisms. First, blood flowing back to the cells brings this influx of calcium. And since calcium leads to muscle contraction, the irreversibly damaged cells contract. And since they've been irreversibly damaged, they get stuck like that and can't relax. This shows up on histology as this characteristic contraction band necrosis. Also, though, blood brings along oxygen, right? Yeah, it does. But that oxygen, paradoxically, can actually lead to more cellular damage. The conditions in an ischemic heart seem to cause an increased conversion of the returning oxygen to reactive oxygen species, which can go on to damage more heart cells. In addition to reestablishing blood flow, though, there are a number of medications that might be given in the acute setting, including antiplatelet medications like aspirin, anticoagulants like heparin, nitrates, which relax the coronary arteries and help lower preload, beta blockers that slow down the heart rate and thereby cardiac demand, pain medication to help relieve discomfort, and statins which help improve a patient's lipid profile. Now, there are a ton of individual factors to consider when it comes to acute management of a myocardial infarction, and of course many long-term issues to consider as well, the most important of which is to address the underlying risk factors like an improved diet and quitting smoking.
Alright, as a quick recap. Heart attack, also known as a myocardial infarction, or MI, is the death of heart muscle cells due to the lack of blood flow, most commonly caused by atherosclerosis of the coronary arteries. The most common symptoms of myocardial infarctions include crushing chest pain or pressure that might radiate up to the left arm or jaw, sweating, nausea, and dyspnea. Treatment of myocardial infarction includes reestablishing blood flow using medications, angioplasty, or percutaneous coronary intervention. But underlying risk factors should be addressed for long-term management. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.
Jamie is a 24-year-old male presenting to the emergency department complaining of sudden onset chest pain and shortness of breath when playing soccer. On further evaluation, his ECG showed ST segment elevation, and laboratory evaluation showed elevated troponin I levels. After instituting treatment, Jamie and his family inquire about the odd early onset of his disease. The physical examination of the skin showed numerous xanthomas. A lipid panel is ordered and shows marked elevation of LDL. Jamie had a myocardial infarction, which was caused by an underlying lipid disorder. Lipid disorders include both hyper- and hypolipidemia. Hyperlipidemia can manifest as a high level of cholesterol, a high level of triglycerides, or a combination of both. Hypolipidemia is the opposite, where there's a low level of these lipids. So let's do a quick overview of the physiology of lipid metabolism. After eating a fatty meal, cholesterol and fatty acids enter the intestinal cells. The fatty acids are assembled into triglycerides, and then they, along with a small amount of cholesterol, are packaged together with lipoproteins to form chylomicrons. Chylomicrons move into the lymphatic vessels and eventually end up getting emptied into the left and right subclavian veins, where they enter into the blood. Now, an enzyme in capillaries called lipoprotein lipase breaks down the chylomicrons to free the triglycerides, and then it also breaks the triglycerides down into fatty acids. These can be taken up by nearby tissues to generate energy, like in the muscle cells, or for storage, like in adipocytes. The remains of the chylomicrons will contain lipoproteins and a small amount of triglyceride and cholesterol. So these chylomicron remnants head to the liver to deposit the leftover lipid molecules. The liver is also synthesizing fatty acids and cholesterol, and it will combine these with the ones from the chylomicron remnants and package them together. But instead of chylomicrons, they are packaged into very low-density lipoproteins, or VLDLs. Compared to chylomicrons, these are made of different lipoproteins and contain a bit more cholesterol. VLDLs are released from the liver and enter into the blood where lipoprotein lipase in the capillaries break them down again to release triglycerides for nearby tissue to use. As more and more triglycerides leave the VLDL, it becomes an IDL, or intermediate density lipoprotein. And when there's more cholesterol left than triglyceride, it becomes an LDL. LDLs then travel around in the blood, where they are endocytosed by cells with LDL receptors. This can happen when they go back to the liver or in peripheral tissues that need cholesterol to function. Alright, the causes of hyperlipidemia can be broadly classified into primary hyperlipidemias, which are the familial, inherited hyperlipidemias, and secondary or acquired hyperlipidemias, which are caused by various other diseases and medications. Depending on the type and severity, hyperlipidemia can result in various clinical manifestations, or it can be completely asymptomatic. Beginning from the outside, skin manifestations include xanthomas, which are deposits of fat under the skin and in the tendons. These occur when extremely high levels of lipoproteins or triglycerides in the blood leak out of the blood vessels. When these deposits occur around the eyelid, it gets a special name, xanthelasma. Speaking of the eyes, lipids can deposit around the cornea, creating a brown ring of fat called a corneal arcus. Lipid deposition in the liver can cause fatty liver disease, also called hepatic steatosis. Now, the most worrisome complication of hyperlipidemias is atherosclerotic cardiovascular disease, including coronary artery disease, stroke, peripheral vascular disease, and carotid artery stenosis. Okay, so let's look at the primary or familial hyperlipidemias, which are inherited in either an autosomal dominant or recessive manner. Although there are many, the most high-yield ones, often tested on exams, are types 1 through 4. Type 1 hyperlipidemia is an autosomal recessive disorder characterized by elevation of chylomicrons in the blood, so it's also referred to as hyperchylomicronemia. This occurs secondary to a deficiency in lipoprotein lipase. This enzyme also normally requires a cofactor called apolipoprotein C2, so deficiency of this cofactor can also lead to type 1 hyperlipidemia. This condition is characterized by the rapid development of many xanthomas on the back and buttocks that can be itchy. Due to the rapid nature of their development, they're referred to as eruptive xanthomas. In addition, the high concentration of triglycerides in chylomicrons can often lead to the development of acute pancreatitis. This occurs because when the pancreatic cells encounter triglycerides, they release the enzyme lipase, which breaks them down into free fatty acids. Too many free fatty acids can be toxic to the pancreatic cells, leading to acute pancreatitis. Another unique feature of type 1 hyperlipidemia is that atherosclerotic cardiovascular disease is not a complication. That's because the development of an atherosclerotic plaque is usually related to the elevation of other lipoproteins, like low-density lipoprotein, or LDL, and not related to the elevation of chylomicrons. Finally, people with this condition can develop hepatosplenomegaly. An important clue that might appear on your exams is that when fasting serum is chilled, the chylomicrons will form a creamy layer at the top of the test tube. Alright, Type 2 familial hyperlipidemia is an autosomal dominant condition, also known as familial hypercholesterolemia. It's characterized by the elevation of LDL cholesterol, if it's type A, and both LDL and VLDL, if it's type B. Okay, so normally, the liver can decrease cholesterol levels by recycling LDL in the blood. LDL attaches to its own LDL receptor on the surface of liver cells, and with the help of a protein called apolipoprotein B100, or ApoB100, it enters the liver cells. So in this condition, either the LDL receptor or ApoB100 are absent or defective, causing LDL levels to go up. Because the liver cells aren't getting any LDL back, they begin to think that cholesterol is actually low in the blood, and so they start making even more cholesterol and sending them out in VLDL. As you can imagine, this would worsen the problem. Unlike type 1, type 2 hyperlipidemia will increase the risk of developing atherosclerosis, and this is high yield. In fact, individuals may present with coronary artery disease as early as 20 years old. In addition, tendon xanthomas, particularly on the Achilles tendon, and corneal arcus are common in this type. On the exam, think of this disorder in someone with a family history of myocardial infarction at an early age. Alright, type 3 familial hyperlipidemia is a rare autosomal recessive disorder, also known as familial dys-beta lipoproteinemia. In this disorder, the apolipoprotein E, or ApoE, is defective. This protein normally assists with the uptake of chylomicron remnants and VLDL by the liver, so they are elevated in this condition. It's also characterized by the development of premature atherosclerosis. However, unlike type 2 hyperlipidemia, the xanthomas in this condition tend to develop on the palms. Okay, type 4 familial hyperlipidemia is also known as familial hypertriglyceridemia. In this subtype, for some unknown reason, the liver pumps out large amounts of VLDL. In addition, lipoprotein lipase activity is decreased, so VLDLs are not broken down. This also applies to chylomicrons, which will also be elevated. The high-yield concept here is that since VLDLs and chylomicrons both contain mainly triglyceride, serum triglyceride levels can increase dramatically. This condition is characterized by premature atherosclerosis and the risk of developing acute pancreatitis. Alright, on to the acquired causes of hyperlipidemia, starting with the most common cause, diabetes mellitus. Normally, one of the functions of insulin is to increase lipid uptake in adipose tissue. It does this by increasing the activity of lipoprotein lipase to liberate fatty acids from VLDL and chylomicrons. In both type 1 and type 2 diabetes, insulin levels eventually drop, causing a decrease in lipoprotein lipase activity. So now instead of being broken down and stored, large amounts of VLDL particles just awkwardly sit in the blood, and these eventually get converted to LDL, the culprit in atherosclerosis. In hypothyroidism, the body's metabolism slows down. This includes synthesizing LDL receptors. Without LDL receptors, LDL particles can't return to the liver, so they lurk in the blood. In nephrotic syndrome, plasma proteins like albumin are lost in the urine. In attempt to compensate for the decrease in plasma protein, the liver starts making VLDL. Through various mechanisms, certain groups of medications can also cause hyperlipidemia. These include estrogen-containing oral contraceptives, beta blockers, and thiazide diuretics. Alright, now let's look at hypolipidemia. And the most common cause that will show up on your exams is A-beta lipoproteinemia. Normally, a protein called microsomal triglyceride transfer protein, or MTP, is responsible for packaging triglycerides into lipoproteins like VLDL and chylomicrons so that they can be carried in the blood. In A-beta lipoproteinemia, an autosomal recessive genetic defect happens to the MTP protein. There's also a deficiency of ApoB48 protein, which is also made in the small intestine and are found in chylomicrons, and ApoB100, which is made in the liver and found in VLDL and LDL. So the result is low levels of VLDL, LDL, and chylomicrons. And both cholesterol and triglyceride levels will be low. A-beta lipoproteinemia presents early in infancy. A key symptom is malabsorption of fat in the small intestine due to low levels of chylomicrons. So infants don't grow properly, a condition called failure to thrive. In addition, the lipids accumulate inside intestinal cells and the intestinal lumen, resulting in diarrhea that contains large amounts of fat, also called steatorrhea. On the exam, a clue towards steatorrhea would be malodorous stools that float in the toilet bowl and are difficult to flush down. Over time, individuals develop signs and symptoms of fat-soluble vitamin deficiency, and this is another high-yield fact. This includes osteomalacia from vitamin D deficiency, retinitis pigmentosa from vitamin A deficiency, as well as spinocerebellar degeneration and acanthocytosis on peripheral blood smear from vitamin E deficiency. To confirm the diagnosis, an intestinal biopsy is performed, which shows intestinal cells that contain large amounts of fat. The treatment of the disease is based on reducing dietary fats, especially long-chain saturated fatty acids, to reduce gastrointestinal problems. Vitamin supplements should also be taken, the most important of which are vitamin E to prevent neurological problems and vitamin A to prevent retinal damage. Alright, as a quick recap, lipid disorders cause abnormal changes in the levels of blood lipid components such as triglycerides, cholesterol, and lipoproteins. Hyperlipidemia can be divided into primary or familial, which is usually caused by an inherited genetic defect, or acquired, caused by various systemic disorders and medications. Familial hyperlipidemias are subclassified into 4 major types. Type 1, caused by a deficiency of lipoprotein lipase or its cofactor, apolipoprotein C2, results in elevation of chylomicrons. Type 2 is caused by an absent or defective LDL receptor, resulting in elevation of LDL in type A and both LDL and VLDL in type B. Type 3 is caused by defective ApoE, leading to elevation of VLDL and chylomicrons. Type 4 hyperlipidemia is characterized by increased hepatic production of VLDL. Acquired causes include diabetes, hypothyroidism, and medications like thiazide diuretics. Hypolipidemia can be caused by A-beta lipoproteinemia, which is a genetic disorder that affects the MTP protein. This leads to decreased levels of chylomicrons, VLDLs, and LDLs. The symptoms are caused by malabsorption of fats and fat-soluble vitamins. Okay, back to our case. Jamie is presenting with an acute myocardial infarction. Considering his relatively young age, it's important to consider familial hyperlipidemias. Tendon xanthomas on examination, combined with elevation of LDL on lab testing, all point towards type 2 familial hyperlipidemia, usually caused by a decrease in the number of LDL receptors or ApoB100 protein in the liver.
With familial hypercholesterolemia, familial means the disease runs in families, so it has a genetic predisposition. Hyper means excess, and lastly, cholesterolemia refers to the level of cholesterol in the blood. So, familial hypercholesterolemia is a genetic disorder associated with high levels of cholesterol in the blood. Now, cholesterol is a lipid molecule, so a type of fat, that normally helps maintain the structure of cell membranes and is a precursor to steroid hormones, bile acids, and vitamin D. There are two main types of cholesterol: LDL, or low-density lipoprotein, which is sometimes called bad cholesterol, and HDL, or high-density lipoprotein, which is sometimes called good cholesterol. But good and bad is overly simplistic, and like with all things, the subtleties matter. LDL is produced by the liver, and it carries cholesterol out to the rest of the body. If all of the cholesterol from LDL is not completely distributed to the peripheral cells, then HDL brings some of that cholesterol back from the peripheral tissues and sends it to the liver. Now, what makes LDL bad and HDL good is that whenever there's a high blood concentration of LDL, the LDL can be ingested by macrophages that sit along vessel walls, forming atherosclerotic plaques. Over decades, large atherosclerotic plaques can lead to myocardial infarctions, strokes, and peripheral vascular disease. That's why we want to keep LDL blood levels under control. On the other hand, HDL can remove cholesterol from cells, and that can help reverse the process of atherosclerosis. Now, our body usually keeps LDL cholesterol levels in check by clearing our excess LDL from the plasma. This is mainly done by the LDL receptors present on the surface of the liver cells. First, the LDL molecules bind to the LDL receptors, which are clustered in specialized regions of the cell membrane called coated pits. After binding, the coated pits, along with the receptor-bound LDL, are internalized by invagination, and they form coated vesicles inside the cell. Next, the LDL receptor releases the LDL in the cytoplasm, and it gets recycled back to the cell surface. At the same time, the coated vesicles fuse with an intracellular organelle called a lysosome. Inside the lysosomes, LDL molecules are enzymatically degraded and free cholesterol molecules are released, which then cross the lysosomal membrane to enter the cytoplasm. From the cytoplasm, free cholesterol can be used for cell membrane synthesis and other metabolic processes. Now, in familial hypercholesterolemia, mutations occur in the LDL receptor gene. There are over 900 different types of mutations that can cause familial hypercholesterolemia, but luckily they've been grouped into 5 major classes. Class 1 mutations mainly affect the quantity of synthesized LDL receptors, so there are less available receptors to take up LDL from plasma. Class 2 mutations affect the intracellular transport of LDL receptors back to the cell surface. Class 3 mutations affect the binding of LDL to LDL receptors. With Class 4 mutations, LDL receptor proteins can bind to LDL efficiently, but they're not located in the coated pits. So even if they bind to LDL, the internalization of LDL fails. Lastly, Class 5 mutations affect the recycling of LDL receptors to the cell surface, which ultimately lowers the total number of functional LDL receptors present on the cell surface. Now, all these mutations have one thing in common. That is, they decrease the clearance of LDL from the plasma, which results in accumulation of LDL cholesterol in the circulation. These excess cholesterols are then engulfed by the macrophages and vascular walls, resulting in premature atherosclerosis. Now, familial hypercholesterolemia is an autosomal dominant type of genetic disorder, so you only need one mutated gene from either parent to get the disease. If only one mutated gene is present, and its counterpart from the other parent is normal, the person is a heterozygote. And if both genes have the mutation, the person is a homozygote. So clinical signs and symptoms present at a far younger age, and they're more severe in homozygotes than in heterozygotes. Speaking of which, symptoms of familial hypercholesterolemia are related to how excess cholesterol is deposited in various places of our body as xanthomas, which are yellowish collections of cholesterol that can appear in various places around the body. For example, there can be tendon xanthomas in the tendons of the hands, elbows, and knees, and they are especially common in the Achilles tendon. Another such common place is around the eyelids, which is often referred to as xanthelasma palpebrarum. When excess cholesterol is deposited in the arterial walls, it can narrow the arterial lumen, causing signs of ischemia, which differ depending on the affected organ. For example, when the coronary arteries are affected, that can block blood flow to the heart muscle, causing chest pain during physical effort, which is called angina pectoris. If blood flow is cut off entirely, that may even cause a heart attack. Similarly, when cerebral arteries are blocked, that can cause signs of an ischemic stroke, like weakness on one side of the body, slurring of speech, dropping of one side of the face, and loss of balance. Diagnosis of familial hypercholesterolemia is done with lipid profile tests, which show high levels of total cholesterol and LDL. Confirmatory diagnosis, however, can only be done by genetic testing, which identifies the specific mutation in the LDL receptor gene. Treatment of familial hypercholesterolemia mainly aims to reduce LDL levels in the blood in order to decrease the risk of cardiovascular disease. Lifestyle modifications include quitting smoking, alcohol, and lowering the amount of saturated fats in the diet like those found in dairy and fast food. Medications like statins can also be given to lower cholesterol levels. All right, as a quick recap, familial hypercholesterolemia is a genetic disorder in which individuals have high levels of cholesterol in the blood. The excess cholesterol is often deposited in various places of our body, causing xanthomas in the tendons, around the eyelids, and atherosclerotic plaques inside the blood vessels. Atherosclerotic plaques may cut off blood supply to organs like the heart or the brain, causing a heart attack or ischemic stroke, respectively. Treatment involves lifestyle modifications and medications like statins.
With hypertriglyceridemia, hyper means high, emia refers to blood levels, and triglycerides are the most abundant fatty molecules in an organism. So hypertriglyceridemia is when there's excess triglycerides in the blood. Specifically, hypertriglyceridemia is when there are more than 150 milligrams of triglycerides per deciliter of blood. Triglycerides can be deposited in subcutaneous tissue and around organs, and function as energy storage in the body. We can either get triglycerides from our diet, which are called exogenous triglycerides, or our liver can synthesize them from other molecules, in which case they're called endogenous triglycerides. Now, exogenous triglycerides are first absorbed in the small intestine, and then they undergo a series of changes in order to be transported and deposited in the body. So, after triglycerides are absorbed, they enter the intestinal mucosal cells, inside of which they're coupled with various apolipoproteins and phospholipids to create chylomicrons, which are one type of lipoprotein. Lipoproteins are made up of lipids, like triglycerides or cholesterol, or phospholipids and proteins, like apolipoproteins C2, C3, or E. The main job of lipoproteins is to carry insoluble molecules, like triglycerides, from the intestines to the circulation. That's because normally triglycerides are insoluble in liquid environments like blood. Now, the newly created chylomicrons enter the bloodstream and bind to the wall of capillaries and adipose and skeletal muscle tissue. At the binding site, they interact with the lipoprotein lipase enzyme, leading to the breakdown of the triglyceride core and liberation of free fatty acids directly into the adipocytes or skeletal muscle cell, where they're either stored or used for energy. After triglycerides leave the chylomicron, what's left is called a remnant chylomicron. Remnant chylomicrons are high in cholesterol esters, and they're cleared from circulation by the liver when the apolipoprotein E binds to apolipoprotein B100E receptor on the hepatic cell membrane. The remnant chylomicrons are then degraded by acid hydrolases to a mixture of amino acids, free fatty acids, and cholesterol. Now let's switch gears and look at how endogenous triglycerides are synthesized. First, the liver makes another type of lipoproteins called very low density lipoproteins, or VLDL. The fatty acids are either synthesized from scratch from carbohydrates or released from adipose tissue. Then the liver exports the triglyceride-rich, very low-density lipoprotein molecules into the bloodstream, which carries them to muscle and adipose cells. Here, very low-density lipoproteins are cleaved by lipoprotein lipase to intermediate density lipoproteins, IDL, also called VLDL remnants. The intermediate density lipoproteins are further metabolized to low density lipoproteins, LDL, and are released into the bloodstream, which are taken up by the low density lipoprotein receptor in numerous tissues, including the liver. So hypertriglyceridemia can result from anomalies in either the exogenous or the endogenous pathways, but in either case, excessive triglyceride levels accumulate in the body. Depending on where they accumulate, they may cause complications like atherosclerosis and acute pancreatitis. Now, atherosclerosis can occur via a pathway that involves an endothelial dysfunction. This dysfunction allows small triglyceride remnants to reach the intimal layer, where they get taken up by the macrophages, leading to the formation of foam cells. Foam cells promote fatty streak formation, the precursor of atherosclerotic plaque. Acute pancreatitis, on the other hand, occurs due to high concentrations of large chylomicrons in the blood, which can obstruct the capillaries, leading to ischemia of the pancreas. Now, hypertriglyceridemia is commonly classified as either primary or familial hypertriglyceridemia and secondary or acquired hypertriglyceridemia. Secondary causes are more common, and they may be associated with obesity, diabetes mellitus, high carbohydrate diets, hypothyroidism, or increased alcohol intake, all of which impact lipid metabolism. So 3 of the most common secondary forms of hypertriglyceridemia are obesity, diabetes mellitus type 1 and 2, and high carbohydrate diets. With obesity-associated hypertriglyceridemia, there's a hepatic overproduction of very low-density lipoproteins and decreased circulating triglycerides breakdown. On the other hand, in uncontrolled diabetes mellitus, both type 1 and 2, hypertriglyceridemia is associated with a lipoprotein lipase that is either ineffective or less effective than normal. Finally, high carbohydrate diets, where carbohydrates make up more than 60% of the total caloric intake, lead to increased carbohydrate breakdown and increased production of free fatty acids as a consequence. The excess free fatty acids can be used to synthesize more triglycerides, therefore causing hypertriglyceridemia. Other conditions cause hypertriglyceridemia through different mechanisms. For example, in hypothyroidism, triglycerides are elevated due to reduced hepatic lipase activity, which slows very low-density lipoprotein remnant catabolism. Next, excessive alcohol intake causes hypertriglyceridemia, mainly because alcohol impairs lipid breakdown, causing increased plasma VLDL with or without hyperchylomicronemia. Finally, several drugs like glucocorticoids, beta blockers, thiazide diuretics, HIV antiretroviral agents, retinoids, and oral estrogen replacement can also cause hypertriglyceridemia, although the mechanisms are not well understood. On the other hand, primary or familial hypertriglyceridemia usually occurs due to genetic causes, such as mutations of the genes encoding a type of apolipoprotein. Primary hypertriglyceridemia is included in what is known as familial dyslipidemias. There are 4 hyperlipidemias, of which only 3 cause hypertriglyceridemia. Type 1 is called familial hyperchylomicronemia and is defined as high levels of chylomicrons in the blood. It occurs due to autosomal recessive mutations. Now, mutations in at least 5 different genes cause hyperchylomicronemia, but the ones encoding for lipoprotein lipase and its cofactor, apolipoprotein C2, are most common. Basically, these mutations lead to a severely reduced or absent lipoprotein lipase enzyme activity and to an absent or non-functional apolipoprotein C2. With lipoprotein lipase being the primary enzyme for triglycerides breakdown and release of fatty acids in the circulation, its absence or reduction will lead to high levels of these lipids. Type 3 or familial dysbeta lipoproteinemia occurs when the chylomicron remnants cannot be removed by the liver. The mechanisms through which it is produced are not fully revealed yet, but it is suspected that since the clearance of chylomicron remnants from the circulation is done with the help of apolipoprotein E, any defects related to apolipoprotein E or its receptor will affect this process, leading to hypertriglyceridemia. Finally, type 4 or familial hypertriglyceridemia involves autosomal dominant mutations of the lipoprotein lipase gene. In this case, there's an increase in hepatic synthesis of VLDL and a decreased removal of VLDL, resulting in hypertriglyceridemia. Now, regarding symptoms, hypertriglyceridemia usually doesn't cause symptoms until triglyceride levels are greater than 1,000 to 2,000 milligrams per deciliter, which is why most people have asymptomatic hypertriglyceridemia. Above that level, due to excessive accumulation of triglycerides in the body, signs and symptoms may include hepatosplenomegaly and lipemia retinalis, which can be observed as a creamy appearance within retinal blood vessels. Hypertriglyceridemia can also manifest as small papules on the skin known as xanthomas. With atherosclerosis, symptoms can include chest pain and shortness of breath, while with acute pancreatitis, symptoms like epigastric pain, nausea, and vomiting can occur. The initial diagnosis of hypertriglyceridemia is made with blood tests, usually as the lipid profile part of a cardiovascular risk assessment. Then, hypertriglyceridemia can be classified as mild when triglycerides blood level is from 150 to 499 milligrams per deciliter, moderate from 500 to 886 milligrams per deciliter, and severe when the triglycerides blood level is higher than 886 milligrams per deciliter. Then other tests can be done to distinguish between primary and secondary hypertriglyceridemia. These may include lipid analysis, liver function tests, urinalysis, fasting blood glucose level, or genetic testing. So when it comes to treatment, hypertriglyceridemia may be improved with the help of diet, exercise, and alcohol reduction. Medication is required when triglyceride levels are above 886 milligrams per deciliter. Fibrates, such as fenofibrate, are the best initial medical treatment for hypertriglyceridemia. Niacin and omega-3 fatty acids may also be used. HMG-CoA reductase inhibitors, also known as statins, such as atorvastatin or simvastatin, are the first choice drugs for moderate hypertriglyceridemia. Okay, quick recap. Hypertriglyceridemia is characterized by high blood levels of triglycerides. Hypertriglyceridemia can be primary or secondary. Primary is mainly caused by genetic defects, while secondary hypertriglyceridemia occurs due to several conditions, among which obesity or diabetes are most common. The diagnosis is made based on blood tests, but other tests are required to differentiate between primary and secondary hypertriglyceridemia. Treatment includes diet and exercising to help improve the level of triglycerides, but when those are not enough, medication such as fibrates or statins are required.
Hypertension, or high blood pressure, affects over 1 billion people around the world. Now, normal systolic blood pressure is defined as less than 120 millimeters of mercury, and normal diastolic pressure is less than 80 millimeters of mercury. Elevated blood pressure is when systolic blood pressure is between 120 and 129 millimeters of mercury, and less than 80 millimeters of mercury on the diastolic side. Stage 1 hypertension is between 130 and 139 millimeters of mercury on the systolic side, and between 80 and 89 millimeters of mercury on the diastolic side. Stage 2 hypertension is defined as anything that is 140 millimeters of mercury or higher on the systolic side, and 90 millimeters of mercury or higher on the diastolic side. Typically, both systolic and diastolic pressures tend to rise or fall together, but that's not always the case. Sometimes you can have systolic or diastolic hypertension, when one number is normal and the other's really high. This is referred to as isolated systolic hypertension or isolated diastolic hypertension. There are two main types of blood pressure measurements: office blood pressure, which is taken in a clinic, emergency department or hospital, and out-of-office blood pressure. The out-of-office blood pressure is either a home blood pressure, which is taken by the patient at home, or an ambulatory blood pressure monitoring, or ABMP, which involves 24-hour monitoring of blood pressure as the patients live their normal daily life and while they sleep, to see if their blood pressure falls at night compared to during the day. It uses a small digital blood pressure machine that's attached to a belt around the body and is connected to a cuff around the upper arm. Ambulatory blood pressure monitoring is the best way to diagnose hypertension, but it's not always feasible, so it's usually done when office and home blood pressure measurements are really discordant from one another. Now, the first step for an office blood pressure is to make sure that the patient has rested for at least 5 minutes and is positioned properly, sitting with their arms and back supported and their feet flat on the floor. And the measurement should be repeated at least twice. Most of the time, blood pressure is taken in the brachial artery in the upper arm, because if the pressure is high there, it's probably high throughout the arteries. And keep in mind that just being in the office can cause blood pressure to change. In white coat hypertension, a person's blood pressure rises, and in masked hypertension, a person's blood pressure falls. So the diagnosis of hypertension should be done by looking at both office and out-of-office blood pressure measurements. The second step is taking the patient's history and physical examination. Now, there are two main types of hypertension. Primary, or essential hypertension, has no clearly identifiable underlying reason, and secondary hypertension, which does have a specific identifiable underlying condition. Primary hypertension is way more common, and it generally isn't accompanied by symptoms. It's sometimes called a silent killer, because over time, pressure in the arteries slightly creeps up and causes blood vessel damage, which is a risk factor for serious problems, like myocardial infarctions, aneurysms, and strokes. Risk factors for primary hypertension include old age, obesity, family history, a salt-heavy diet, a sedentary lifestyle, heavy alcohol consumption, smoking, and race. For example, people of African descent are more likely to develop hypertension. And some of these risk factors can be improved with lifestyle changes that help to reduce hypertension. Now, secondary hypertension often is accompanied by a variety of symptoms associated with the underlying cause. In general, the younger the patient, the more likely it's secondary hypertension. For example, anything that limits the renal blood flow can cause hypertension, like fibromuscular dysplasia, which generally affects young women, but also atherosclerosis in older patients. Other examples include obstructive sleep apnea, vasculitis or aortic dissection, as well as pheochromocytoma, Cushing's syndrome, and other endocrine disorders. It's also important to identify signs of end organ damage and whether the patient takes any medications or exogenous substances that can worsen hypertension. Sympathomimetic agents like decongestants or even cocaine, cyclosporin or tacrolimus, sodium-containing antacids, stimulants like amphetamines, atypical antipsychotics like clozapine, antidepressants, oral contraceptives, erythropoietin, and even NSAIDs and licorice, that delicious chewy black candy. A basal metabolic panel and electrocardiography should be performed to screen for secondary forms of hypertension. Management for hypertension is mainly based on the hypertension stage, risk of developing cardiovascular events and organ damage, as well as taking into account any concomitant diseases, such as diabetes or chronic kidney disease. Lifestyle changes are crucial for all patients, especially in the long term, and include things like quitting smoking, drinking alcohol in moderation, and maintaining a healthy weight, reducing dietary sodium, and staying physically active. Not all patients with hypertension need antihypertensive drug therapy. In fact, medication is generally suggested for only patients with out-of-office daytime blood pressures higher than 135 mm of mercury systolic or higher than 85 mm of mercury diastolic, or an average office blood pressure of higher than 140/90 mm of mercury if out-of-office readings aren't available. It's also recommended for patients with an out-of-office blood pressure of higher than 130 mm of mercury systolic or 80 mm of mercury diastolic, or, if out-of-office readings are unavailable, an average office blood pressure higher than 130 mm of mercury systolic or 80 mm of mercury diastolic, who also have other features. Specifically, they need to have at least one of the following: cardiovascular disease, type 2 diabetes mellitus, chronic kidney disease, be over 65 years old, or have an elevated risk of coronary artery disease. On the flip side, it's generally recommended not to give an antihypertensive medication to patients with stage 1 hypertension and are either over 75 years old or have no organ damage. There are 4 main classes of medications that are used to treat hypertension: ACE inhibitors, angiotensin receptor blockers or ARBs, thiazide diuretics, and long-acting calcium channel blockers like dihydropyridine. There is a lot of variability in terms of how individuals respond to different medications, so it's important to follow up to see how the medications are working. Usually, therapy begins by choosing one medication. Broadly speaking, ACE inhibitors are started in patients at high risk for coronary artery disease, including those with a prior STEMI, heart failure, asymptomatic left ventricular dysfunction, diabetes, and chronic kidney disease. A common side effect of ACE inhibitors is chronic cough, so ARBs are often started in patients who don't tolerate ACE inhibitors, mostly because of the cough. Thiazide diuretics and calcium channel blockers show very similar efficacy to ACE inhibitors, and they're first-line therapy in patients of African descent. But diuretics have a lot of metabolic effects, so they can't be given to patients with high blood glucose and cholesterol levels. The blood pressure goal while on medications varies based on the initial blood pressure, as well as age and other health conditions. But in general, it's ideal to have an out-of-office blood pressure below 135/85 mm of mercury and an office blood pressure below 140/90 mm of mercury. If the blood pressure isn't improving within a month, then the dose is usually increased or a second medication from a different class is often started. Some combinations are useful, while others aren't. ACE inhibitors and ARBs should not be combined, and instead, either can be combined with a thiazide diuretic or a calcium channel blocker. In some cases, diuretics may be combined with beta blockers. If blood pressure is not kept under control after combining 2 medications, then an ACE inhibitor or ARB should be combined with both a thiazide diuretic and a calcium channel blocker. If a thiazide diuretic isn't well tolerated or is contraindicated, for instance in patients with metabolic conditions, then a mineralocorticoid receptor antagonist, like spironolactone or eplerenone, can be used instead. And if those medications also can't be used because it isn't well tolerated or is contraindicated, then a beta blocker can be used. If the blood pressure isn't controlled with a combination of 3 antihypertensive medications, including a diuretic, then it's considered drug-resistant hypertension. Often, patients with hypertension feel pretty well and forget to take their hypertension medications. That's why regimens of daily pills have got better medication adherence as compared to twice-daily pills. In fact, when there's a patient with drug-resistant hypertension, it's important to confirm that they are actually taking the medication. Finally, if the blood pressure gets really high really fast, it's called a hypertensive crisis. In hypertensive crisis, either the systolic pressure is greater than 180 mm of mercury, or the diastolic pressure is greater than 120 mm of mercury. Hypertensive crisis can be further split into hypertensive urgency and hypertensive emergency. With hypertensive urgency, there hasn't yet been damage to end organs like the brain, kidneys, heart, and lungs. In hypertensive emergency, there is damage to end organs, and patients have symptoms like confusion, drowsiness, chest pain, and dyspnea. The most common cause of hypertensive crisis is not taking antihypertensive medications, but it can also be due to causes of secondary hypertension, like renovascular disease, pheochromocytoma, hyperaldosteronism, and erythropoietin intake. For treatment, it's important to gradually reduce the blood pressure over 1 to 2 days to make sure that the brain never gets underperfused. Treatment of hypertensive urgency is done with oral medications like ACE inhibitors. On the other hand, in a hypertensive emergency, the goal is to lower the mean arterial pressure by 20% within the first hour, and treatment is given intravenously with medications like beta blockers, calcium channel blockers, and vasodilators, like nitroprusside and nitroglycerin. Alright, as a quick recap, Stage 1 hypertension is defined as 130 to 139 millimeters of mercury for the systolic blood pressure and between 80 to 89 millimeters of mercury for the diastolic pressure, while Stage 2 hypertension is defined as greater than 140 millimeters of mercury on the systolic side and greater than 90 millimeters of mercury on the diastolic side. Hypertension usually doesn't cause any symptoms, and the first line of treatment is lifestyle changes, like changes to the diet, exercise, and stress reduction. In addition, drug therapy may be given to patients with really high blood pressure or risk of adverse events. The four main medication classes used are ACE inhibitors, angiotensin receptor blockers or ARBs, thiazide diuretics, and long-acting calcium channel blockers like dihydropyridine.
Anthony is a 40-year-old male with a history of type 2 diabetes mellitus presenting to a family medicine clinic for his annual health checkup. His blood pressure measurement is 145 over 95 millimeters of mercury, and his BMI is 32. On further history, he explains that his job as a truck driver has prevented him from exercising regularly. His father had a history of hypertension and passed away from a stroke. A follow-up appointment showed a blood pressure of 150 over 90. Alicia is a 30-year-old female who came in because she's concerned that she might be pregnant. Her pregnancy test is negative. However, her blood pressure is 170 over 90. On her second appointment, her blood pressure remains elevated. She is placed on lisinopril. A couple of days later, she presents with a decreased urine output and an elevated blood urea nitrogen and creatinine. Finally, there's Vikander, who is a 62-year-old male with a history of hypertension. He complains of headache, altered mental status, and visual changes. On further history, he mentions he is sick of all the medications he has to take. Fundoscopic examination reveals a swollen optic disc and his blood pressure is 200 over 120. Okay, so all three people present with hypertension. Now, normal blood pressure is less than 120 systolic over 80 diastolic. According to the recent 2017 American Heart Association and American College of Cardiology guidelines, hypertension is currently defined as a blood pressure over 130 systolic and 80 diastolic. Now, typically, both systolic and diastolic pressures tend to rise or fall together, but that's not always the case. Sometimes you can have systolic or diastolic hypertension. This is referred to as isolated systolic hypertension or isolated diastolic hypertension. Okay, just because you see an elevated blood pressure on the exam, it doesn't mean that that individual has hypertension. The blood pressure must be persistently elevated in order to define it as hypertension. So, on your exam, remember that the diagnosis requires at least 2 separate readings on 2 separate visits. The reason for this is because of the phenomenon of white coat hypertension. This is hypertension on physical exam that occurs because of anxiety experienced by the individual. Hypertension is classified into primary or essential hypertension and secondary hypertension. Primary hypertension occurs without a known secondary cause and accounts for 90% of cases. The pathophysiology of primary hypertension is thought to be related to decreased renal sodium excretion. Reduced sodium excretion increases plasma volume, increasing the stroke volume and, as a result, the systolic blood pressure. Also, the increased plasma volume causes decreased renin release from the juxtaglomerular apparatus, producing what's called low renin hypertension, and this can be high yield. Additionally, decreased sodium excretion promotes vasoconstriction of the peripheral arterioles, increasing the systemic vascular resistance, which increases diastolic blood pressure. Okay, so risk factors for primary hypertension include age, physical inactivity, obesity, diabetes mellitus, smoking, family history of hypertension, as well as excess salt or alcohol consumption. It's thought that in type 2 diabetes, high levels of insulin promote renal sodium retention. Okay, before diagnosing an individual with primary hypertension, the causes of secondary hypertension must be ruled out. Your exams will often try to clue you towards this by mentioning that the individuals were on multiple antihypertensives and they didn't work, or by having a relatively young individual with hypertension. The best approach is to look at different organ systems, starting with the adrenal gland. Important causes include primary hyperaldosteronism, or Conn syndrome, Cushing syndrome, and tumors like pheochromocytoma and neuroblastoma. Clues in the question stem will help you identify which one it is. Hypokalemia, metabolic alkalosis, and an increase in the aldosterone to renin ratio indicate Conn syndrome. Abdominal striae, supraclavicular fat pads, truncal obesity, and hyperglycemia point towards Cushing syndrome. Paroxysmal hypertension, that is, hypertension that comes and goes, associated with headaches, palpitations, and sweating, indicate a pheochromocytoma. Neuroblastomas are common in children and present with an abdominal mass. Next is the kidney. Renal artery stenosis, also called renovascular disease, is usually caused by an atherosclerotic plaque, occluding the renal artery, especially in 60 to 70-year-old males. Less commonly, it can be caused by fibromuscular dysplasia, especially in 20 to 30-year-old females. This classically causes the string of beads appearance of the renal artery. Regardless of the cause, renal artery stenosis decreases renal perfusion. This makes your body think that it's in a hypotensive state. So in response, the renin-angiotensin-aldosterone system, or RAS, is activated, resulting in vasoconstriction and increased renal sodium and water reabsorption, and eventually hypertension. Decreased renal perfusion causes the affected kidney to shrink, and histologically, there will be glomerular tubulointerstitial atrophy and fibrosis. A high-yield fact to remember for your exams is that unilateral renal artery stenosis does not cause CKD, because the contralateral kidney is functioning normally, and, in fact, it hypertrophies to compensate. However, bilateral renal artery stenosis results in CKD because both kidneys are affected. Also, it's important to not give ACE inhibitors to people with bilateral renal artery stenosis. This is because angiotensin II constricts the efferent arteriole in the glomerulus, which maintains the GFR. If an ACE inhibitor is given, the efferent arterioles dilate, causing a drop in the GFR. Okay, renal parenchymal diseases like diabetic nephropathy, glomerulonephritis, or polycystic kidney disease can also cause hypertension by retaining sodium. Moving on, coarctation of the aorta is also an important cause of hypertension, especially in children. And the mechanism is quite similar to renal artery stenosis, since renal perfusion is decreased, just that the obstruction is more proximal. Speaking of the aorta, aging causes the amount of elastin in the arterial wall to decrease, and the amount of collagen to increase, producing a stiff, non-compliant aorta. This manifests in elderly adults as isolated systolic hypertension, which means an elevated systolic blood pressure, but a normal diastolic. Okay, now, both hyperthyroidism and hypothyroidism can cause hypertension. Hyperthyroidism increases the cardiac output, causing an elevated systolic blood pressure. For some reason, hypothyroidism increases renal retention of sodium, and interestingly, causes an isolated elevation of the diastolic blood pressure. The adjacent parathyroid glands are also potential suspects because primary hyperparathyroidism causes hypercalcemia, which increases vasoconstriction of the peripheral arterioles, resulting in an increased total peripheral vascular resistance. Alright, if the person presents with hypertension, bradycardia, and an irregular respiratory pattern, think of an increased intracranial pressure, which triggers a reflex that results in Cushing's triad. In pregnancy, it's crucial to consider preeclampsia and eclampsia. Finally, always be aware of what medications the individual is taking. Estrogen-containing oral contraceptives are common causes of hypertension, especially in young women. Estrogen works by increasing the synthesis of angiotensinogen in the liver, which is ultimately converted to angiotensin 1 and 2. Cocaine is another potential drug that can cause hypertension by increasing sympathetic activity. Additionally, in people taking monoamine oxidase inhibitors, ingestion of tyramine-containing foods like cheese and wine may initiate an acute hypertension. Remember that sometimes the exam might not mention the medication, but they'll simply state that the person has a history of atypical or drug-resistant depression, which is an indication for MAOIs. Chronic hypertension can result in multiple complications affecting different organ systems. Let's start with the heart. Hypertension increases the afterload, that is, the resistance the heart has to pump against. In response, the left ventricle hypertrophies to overcome the resistance. Concentric hypertrophy increases the myocardial oxygen demand, which means the heart needs more coronary blood supply than usual. Also, concentric hypertrophy makes the heart stiff, which limits diastolic relaxation. This is why heart failure from hypertension is a diastolic heart failure, so the ejection fraction will actually be normal. Hypertension is also a risk factor for atherosclerosis, so there's an increased risk of coronary artery disease, which is the most common cause of death from hypertension. Aortic dissection is another important complication, and hypertension is the most important risk factor contributing to it. Alright, next up, onto the brain. Hypertension can weaken the walls of the small brain vessels, resulting in Charcot-Bouchard aneurysm, which can rupture and cause an intracerebral bleed. Larger arteries can form Barry aneurysm, which can rupture and cause a subarachnoid hemorrhage. Also, hyaline arteriosclerosis of the small blood vessels can occlude them, resulting in small lacunar infarcts. In fact, properly managing hypertension has been shown to provide the greatest reduction in the risk of stroke. Okay, so in the kidneys, hyaline arteriosclerosis of the afferent and efferent arterioles can lead to ischemia and atrophy of the renal tubules. Over time, renal failure manifests. Finally, we have to keep an eye on the eyes. Remember for your exams that hypertensive retinopathy manifests as dot-inflame-shaped hemorrhages that result from rupture of microaneurysms, arteriovenous nicking when enlarged arteries compress veins, as well as silver and copper wiring, which are occluded arteries that appear white or orange instead of red. Alright, aside from the chronic complications, hypertension can also result in acute presentation. Both hypertensive urgency and emergency have a blood pressure greater than 180/120. The difference is that in hypertensive emergency, there is evidence of acute end organ damage. Now, both usually develop when someone is not consistently taking their antihypertensive medication. Hypertensive urgency is usually found incidentally, so there's no evidence of end organ damage. In hypertensive emergency, end organ damage can manifest in a variety of ways. For example, CNS manifestations include headache, altered mental status, seizures, papilledema, or stroke. Cardiac manifestations include myocardial infarction, acute left ventricular failure resulting in pulmonary edema, and aortic dissection. Renal manifestations include acute kidney injury, presenting as an elevation in the BUN and creatinine, hematuria, and microalbuminuria. Now, let's switch gears and discuss the treatment of hypertension. The first choice of treatment is lifestyle changes, like a low-sodium diet, exercise, and stress reduction techniques. In some cases, antihypertensive medications can be given as well. In general, for essential hypertension, there are 4 main classes of medications that are used: angiotensin-converting enzyme, or ACE inhibitors, angiotensin receptor blockers, or ARBs, thiazide diuretics, and long-acting calcium channel blockers, like dihydropyridine. But what the examiners are often going to do is try to clue you towards the medication you should choose based on the comorbidity of the patient. So, if there's hypertension with heart failure, it's high yield to remember that the treatment should include ACE inhibitors or ARBs, diuretics, aldosterone antagonists, and beta blockers. Bear in mind, though, that beta blockers must be used with caution in decompensated heart failure, which is when heart failure rapidly worsens. That's because of their ability to decrease heart rate and their negative inotropic effect, meaning that they decrease the force of heart contraction. Moving on, if there's hypertension with diabetes mellitus, the optimum treatment is ACE inhibitors, or ARBs, thiazide diuretics, calcium channel blockers, or beta blockers. What's important to remember is that ACE inhibitors, or ARBs, are protective against diabetic nephropathy. And when using beta blockers, hypoglycemia is the side effect to watch out for, as it may go unnoticed, since beta blockers blunt the counter-regulatory effects and symptoms of catecholamines, like tachycardia and tremors. That's particularly dangerous for people with diabetes, who already take a bunch of other hypoglycemic medications like insulin. Next, hypertension in individuals with asthma should be treated with ARBs, thiazide diuretics, calcium channel blockers, or cardioselective beta blockers. What we should avoid here is ACE inhibitors, since their most common side effect is cough, and non-selective beta blockers, which also block beta-2 receptors in the lungs, causing bronchoconstriction. Finally, for hypertension in pregnancy, choose hydralazine, methyldopa, labetalol, or nifedipine. To remember this, you can use the mnemonic "Hypertensive moms love nifedipine." Another thing to know is treatment of acute complications of hypertension. Hypertensive urgency just needs adjustment of oral antihypertensive medication, so there's no need to lower the blood pressure acutely. On the flip side, in hypertensive emergency, it's crucial to lower the blood pressure immediately with intravenous medications like nitroprusside or labetalol. Alright, as a quick recap. Hypertension is defined as an elevation of blood pressure above 130/80 as per the AHA. Hypertension can be classified into primary or essential hypertension and secondary hypertension. Risk factors for primary hypertension include age, obesity, diabetes mellitus, smoking, and family history. Secondary hypertension causes are classified based on the organ of origin. Examples include Conn syndrome from the adrenals, renal artery stenosis in the kidney, or coarctation of the aorta. Drugs like cocaine and oral contraceptives are also potential causes. Chronic complications of hypertension can affect a variety of organ systems, and include left ventricular hypertrophy, coronary artery disease, stroke and subarachnoid hemorrhage, renal failure, and hypertensive retinopathy. Hypertension can also present acutely as hypertensive urgency, which has a blood pressure greater than 180/120 without end organ damage, or hypertensive emergency, which is with end organ damage. Treatment of hypertension varies depending on any concomitant conditions, like heart failure, diabetes, asthma, or even pregnancy. And finally, back to our cases. Anthony has multiple risk factors for primary hypertension, including a history of diabetes, obesity, lack of exercise, and family history of hypertension. After performing a physical exam to check for the chronic complications of hypertension, he's given antihypertensive medication. Alicia presented with hypertension and was placed on lisinopril, an ACE inhibitor. However, she developed oliguria and an elevated BUN and creatinine, signifying that her GFR declined after the initiation of lisinopril. This is characteristic of renal artery stenosis. Labs showed elevation of renin and aldosterone levels, and an angiogram confirmed the stenosis. Vikander is presenting with hypertensive emergency as his blood pressure is above 180/120, and his symptoms include headache, altered mental status, and papilledema, which means there's end organ damage. His probable history of medication noncompliance also supports this diagnosis. Intravenous esmolol is given to quickly lower his blood pressure and prevent further damage.
Over 1 billion people around the world have hypertension, or high blood pressure. So that pretty much means it's pretty common. Let's start by defining it. Typically, it's represented by two numbers. The top number is the systolic blood pressure, which is the arterial pressure when the heart's contracting. And the lower number is the diastolic blood pressure, which is the arterial pressure when the heart's relaxing or refilling. Most of the time, blood pressure is taken in the brachial artery in your upper arm. Because if the pressure's high there, it's probably high throughout all of the arteries. The guidelines for categorizing blood pressure have recently changed to reflect a growing body of evidence that shows even moderately high blood pressures can significantly increase your risk for developing heart disease. Now, normal systolic blood pressure is defined as less than 120 millimeters of mercury, and a normal diastolic pressure is less than 80 millimeters of mercury. Elevated systolic blood pressure is considered between 120 and 129 millimeters of mercury, and less than 80 millimeters of mercury on the diastolic side. Stage 1 hypertension is between 130 and 139 millimeters of mercury on the systolic side, and between 80 and 89 millimeters of mercury on the diastolic side. Stage 2 hypertension is defined as anything that's 140 millimeters of mercury or higher on the systolic side, and 90 millimeters of mercury or higher on the diastolic side. Typically, both systolic and diastolic pressures tend to climb or fall together, but that's not always the case. Sometimes you can have systolic or diastolic hypertension, when one number is normal and the other is really high. This is referred to as isolated systolic hypertension or isolated diastolic hypertension. High blood pressure is a serious problem for the blood vessels because it causes wear and tear on the endothelial cells that line the inside of the blood vessels. Just like a garden hose that's always under higher pressure, in the long term, blood vessels can develop tiny cracks and tears that can lead to serious problems, like myocardial infarctions, aneurysms, and strokes. Now, about 90% of the time, hypertension happens without a clearly identifiable underlying reason, and we call this primary hypertension or essential hypertension. In other words, over time, pressure in the arteries starts to silently creep up. And there are a bunch of risk factors that we've identified for primary hypertension, and these include old age, obesity, salt-heavy diets, and sedentary lifestyles. With the exception of age, all of these can be improved with lifestyle changes, and those changes can help reduce hypertension. About 10% of the time, though, there is a specific, identifiable underlying condition that's the cause of the hypertension, and we call this secondary hypertension. For example, anything that limits the blood flow to the kidneys or the renal blood flow can cause hypertension, as well as things like atherosclerosis, vasculitis, or aortic dissection. This is because the kidneys play a super important role in blood pressure regulation. When not enough blood flows to the kidney secretes the hormone renin, which ultimately helps the kidneys retain more water. That water contributes to more blood in the arteries, making them more full, which leads to higher pressures. Other diseases can also cause secondary hypertension. Fibromuscular dysplasia, which affects young women, can cause the walls of the large and medium-sized arteries to thicken. If it involves the renal artery and limits blood flow to the kidneys, it triggers more renin. Another example is a tumor that produces excess aldosterone, and just like renin, this leads to fluid retention. Finally, if the blood pressure gets really high really fast, it's referred to as hypertensive crisis. It involves a systolic pressure greater than 180 millimeters of mercury or a diastolic pressure greater than 120 millimeters of mercury. Hypertensive crisis can be further split into hypertensive urgency and hypertensive emergency. With hypertensive urgency, there hasn't yet been damage to end organs, like the brain, kidneys, heart, and lungs. In hypertensive emergency, there has been shown to be evidence of damage to end organs. So for symptoms, usually primary hypertension isn't actually accompanied by any symptoms, which is why it's sometimes referred to as a silent killer. Secondary hypertension might involve a variety of symptoms associated with the underlying cause. And finally, hypertensive emergency might involve symptoms like confusion, drowsiness, chest pain, and breathlessness. The first choice for treatment of hypertension is lifestyle changes, like changes to the diet, exercise, and stress reduction techniques. In addition, there are a variety of antihypertensive medications that might be given in some cases as well. Alright, as a quick recap, hypertension or high blood pressure affects over 1 billion people around the world, and over time is a major risk factor for heart disease and stroke. Stage 1 hypertension is defined as 130 to 139 millimeters of mercury for the systolic blood pressure, and between 80 to 89 millimeters of mercury for the diastolic pressure. While stage 2 hypertension is defined as greater than 140 millimeters of mercury on the systolic side, and greater than 90 millimeters of mercury on the diastolic side. Hypertension usually doesn't cause any symptoms, and the first line of treatment is lifestyle changes. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.
Cushing syndrome, or Cushing's disease, is an endocrine disorder with elevated cortisol levels in the blood. Cortisol production is normally under the control of the hypothalamus and pituitary. The hypothalamus secretes corticotropin-releasing hormone, or CRH, which makes the pituitary gland secrete adrenocorticotropic hormone, or ACTH. ACTH then stimulates the release of cortisol from the adrenal glands. For cortisol levels to stay within the normal range, there's also a negative feedback mechanism in place. This means that high levels of cortisol tell the hypothalamus and the pituitary to decrease their production of CRH and ACTH, respectively. Now, with Cushing syndrome, the high cortisol levels are usually due to a benign tumor of the pituitary, called an adenoma, that secretes excess ACTH. Excess cortisol can also appear in the context of some other tissue that secretes ACTH, or an adrenal mass that secretes too much cortisol. In fact, even exogenous glucocorticoids given for an autoimmune condition can also cause Cushing syndrome. No matter the cause, the symptoms are the result of the effects of excess cortisol on various target tissues. There's increased breakdown of most types of tissue, which leads to muscle wasting in thin extremities, skin thinning, easy bruising, abdominal striae or lines, and bone thinning or osteoporosis, which can lead to fractures. At the same time, there's fat redistribution, so classic findings include a round, full moon-shaped face, a buffalo hump, which is a fatty hump on the upper back, and truncal obesity, where fat gathers around the abdomen and trunk rather than in the limbs. Finally, excess cortisol causes hypertension and hyperglycemia, which can progress into diabetes mellitus, as well as increased vulnerability to infections, particularly fungal infections of the skin. Individuals might also experience poor wound healing, menstrual irregularities, and psychiatric disturbances. When Cushing syndrome is suspected, the first step is to exclude an iatrogenic cause, like glucocorticoid therapy for an autoimmune condition. If that's ruled out, there are 3 tests that can be performed to assess cortisol levels. First, a late-night salivary cortisol level test can be determined because that's usually when levels are low. In Cushing's, the circadian secretion of cortisol is lost, so cortisol levels are high all throughout the day. A value higher than 2 nanograms per milliliter suggests Cushing's. However, this test may not be the best first choice for people who don't have a usual sleep schedule, like night owls or people who do shift work. A second test is a 24-hour urinary-free cortisol level test. When there's excess plasma cortisol, it leads to excess cortisol in the urine, and a value that's greater than 3 times the upper limit of normal suggests Cushing syndrome. For both of these tests, it's necessary to repeat an abnormal test, because the diagnosis requires having 2 abnormal results. The third testing option is the low-dose overnight dexamethasone suppression test, and there are 2 ways to do it. The first way is to administer 1 milligram of dexamethasone at 11 p.m. Dexamethasone has a similar structure to cortisol, so it normally inhibits ACTH and cortisol secretion. Then, if the serum cortisol level is higher than 1.8 micrograms per deciliter between 8 and 9 a.m. the following morning, then it confirms the diagnosis of Cushing syndrome. The second way takes 2 days, and it starts with determining serum cortisol levels at 9 a.m. on day 0, followed by administration of 0.5 milligrams of dexamethasone every 6 hours for 48 hours. So, 4 milligrams in total. This is then followed by a check of the serum cortisol levels. As before, a value higher than 1.8 micrograms per deciliter confirms the diagnosis of Cushing syndrome. Okay, so once the diagnosis is established, the next step is to determine the cause. This means determining whether increased cortisol secretion is ACTH dependent, which is the majority of cases, or ACTH independent. An elevated serum ACTH above 20 picograms per milliliter means that it's ACTH dependent, whereas a decreased serum ACTH value below 5 picograms per milliliter means that it's ACTH independent. So, in the ACTH dependent category, we've got 2 major causes. First, there's Cushing's disease, which is where there's an ACTH secreting pituitary adenoma. Then, there's ectopic ACTH secretion, which is when ACTH is coming from some tissue other than the pituitary, the most common culprit being small cell lung carcinoma. To differentiate between Cushing's disease and ectopic ACTH secretion, we use a high-dose dexamethasone suppression test. This is where serum cortisol is measured at 8 a.m. one morning, then 8 milligrams of dexamethasone are given at 11 p.m., much higher than 1 or 4 milligrams used in the low-dose test. Then, serum cortisol is measured at 8 a.m. the following morning. High doses of dexamethasone are able to suppress pituitary ACTH secretion, but not ectopic ACTH secretion. So, a serum cortisol lower than 5 micrograms per deciliter the following morning, or 50% lower than the previous day, is indicative of Cushing's disease. A serum cortisol above 5 micrograms per deciliter is more likely to be due to ectopic secretion. However, to confirm the diagnosis, an additional test is recommended to clearly differentiate Cushing's disease from ectopic ACTH secretion. The 2 main options are the CRH stimulation test and inferior petrosal sinus sampling. With the CRH stimulation test, intravenous CRH is administered, and serum ACTH and cortisol samples are obtained before the CRH injection and 45 minutes afterwards. Individuals with Cushing's disease respond with a rise in ACTH and cortisol, whereas those with ectopic ACTH secretion do not. Inferior petrosal sinus sampling is a more complicated procedure, where a catheter is inserted in the left and right jugular or femoral veins and advanced all the way up to the left and right inferior petrosal sinuses, which drain the blood coming from the pituitary. A CRH injection is administered to stimulate ACTH secretion, and ACTH is sampled from the peripheral vein, as well as from the petrosal sinus, before and 10 minutes after the CRH injection. Then we compare the values. If the inferior petrosal sinus ACTH is 2 times greater than the peripheral vein ACTH before the CRH injection, or 3 times greater after the CRH injection, then the ACTH is coming from the pituitary, confirming Cushing's disease. Once Cushing's disease is confirmed, the next step is to get an MRI of the head to identify the pituitary adenoma that's wreaking havoc with cortisol levels. Once identified, the tumor can be removed through transsphenoidal resection, which is a fancy way of saying that it's taken out through the nose. If the entire tumor can't be removed, then radiation therapy may also be used to eliminate the tumor. However, it may take anywhere between 6 months and 3 years for hypercortisolism to disappear. And during this time, drugs that block the adrenal synthesis of cortisol, like metyrapone, may be used to control the symptoms. If medications aren't sufficient to block cortisol effects, a last resort is to surgically remove both adrenal glands. In that situation, lifelong substitution therapy with glucocorticoid and mineralocorticoid hormones is needed. Now, if there is ectopic ACTH secretion, a CT or an MRI of the thorax, abdomen, and pelvis can identify the tumor, and treatment here depends on what kind of tumor it is and its stage. Finally, there are ACTH-independent causes of excess cortisol secretion due to either iatrogenic glucocorticoids or due to an adrenal mass with autonomous cortisol secretion. Iatrogenic Cushing's can be identified in an individual's history, so if that's not the cause, then the next step is to get an abdominal CT scan to look for adrenal masses. Now, adrenal masses are more frequently benign adenomas, but sometimes they may be malignant carcinomas. Some clinical signs of adrenal carcinoma include age below 10 or over 50, as well as signs of androgen excess in women, like acne, hirsutism, and deepening of the voice, which are not usually present with adenomas. Also, on an abdominal CT, adrenal carcinomas usually have necrosis, hemorrhage, and calcifications, whereas adenomas typically don't. If an adenoma is identified, treatment is laparoscopic adrenalectomy of the affected adrenal gland. With carcinomas, treatment is usually an open adrenalectomy, and nearby lymph nodes are often removed as well. If the carcinoma is invasive, then surgical resection of nearby organs like the kidney, liver, or spleen may be needed. Alright, as a quick recap. Cushing's syndrome is caused by excess cortisol levels. To confirm hypercortisolism, a late-night salivary cortisol test, a 24-hour urine cortisol test, or a low-dose dexamethasone suppression test can be used. Serum ACTH levels higher than 20 picograms per milliliter point towards ACTH-dependent causes, which are Cushing's disease and ectopic ACTH secretion. To differentiate them, a high-dose dexamethasone suppression test can be used. A low serum cortisol following this test is indicative of Cushing's disease, whereas persistent high levels of cortisol indicate ectopic ACTH secretion. Usually, either the CRH stimulation test or inferior petrosal sinus sampling is performed along with this test to confirm the diagnosis. If Cushing's disease is suspected, an MRI can be done to identify the pituitary tumor, which can be removed through transsphenoidal resection. If ectopic ACTH is the cause, further imaging studies are required to identify the tumor, and treatment depends on what tumor it is. At the other end of the spectrum, when serum ACTH is lower than 5 picograms per milliliter, we're talking about ACTH-independent causes like iatrogenic Cushing's and adrenal tumors. Adrenal tumors can be benign or malignant, and a CT scan can be used to differentiate between the two. Either way, treatment is to surgically remove the affected adrenal gland, and, in the case of carcinoma, sometimes surrounding tissues and organs.
Cushing syndrome, named after the famous neurosurgeon Harvey Cushing who first described it, is an endocrine disorder with elevated cortisol levels in the blood. In some cases, Cushing syndrome results from a pituitary adenoma making excess ACTH, and in those situations it's called Cushing disease. Normally, the hypothalamus, which is located at the base of the brain, secretes corticotropin-releasing hormone, known as CRH, which stimulates the pituitary gland to secrete adrenocorticotropic hormone, known as ACTH. ACTH then travels to the pair of adrenal glands, on top of each kidney, where it specifically targets cells in the adrenal cortex. The adrenal cortex is the outer part of the adrenal gland, and is subdivided into 3 layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. The zona fasciculata is the middle zone and also the widest zone, and it takes up the majority of the volume of the whole adrenal gland. The ACTH specifically stimulates cells in this zone to secrete cortisol, which belongs to a class of steroids, or lipid-soluble hormones called glucocorticoids. Glucocorticoids are not soluble in water, so most cortisol in the blood is bound to a special carrier protein called cortisol-binding globulin, and only about 5% is unbound, or free. In fact, only this small fraction of free cortisol is biologically active, and its levels are carefully controlled. Excess free cortisol is filtered in the kidneys and dumped into the urine. Free cortisol in the blood is involved in a bunch of stuff, and it's part of the circadian rhythm. Cortisol levels peak in the morning when the body knows we need to get up and go, and then drop at night when we're getting ready for bed. In times of stress, the body needs to have plenty of energy substrates around. So cortisol increases gluconeogenesis, which is the synthesis of new glucose molecules, as well as proteolysis, which is the breakdown of protein, and lipolysis, which is the breakdown of fat. Cortisol also helps to maintain the blood pressure by increasing the sensitivity of peripheral blood vessels to catecholamines, like epinephrine and norepinephrine, and this narrows the blood vessel lumen. Cortisol also helps to dampen the inflammatory and immune response by reducing the production and release of inflammatory mediators, like prostaglandins and interleukins, as well as inhibiting the proliferation of T lymphocytes. Finally, cortisol receptors are present in the brain, where their full effect is still actually unclear, but might influence things like mood and memory. For all this to work properly, though, the levels of free cortisol have to stay within the normal range. To do that, the body uses negative feedback, which means that high levels of cortisol tell the hypothalamus and pituitary gland to decrease their secretion of CRH and ACTH, respectively. Less CRH also tells the pituitary gland to make less ACTH, so the pituitary gland ends up having 2 reasons not to make ACTH. With less ACTH floating around, the zona fasciculata gets less stimulation to make cortisol, and eventually cortisol levels go back down to the normal range again. In Cushing syndrome, cortisol levels are constantly higher than normal, so its effects are exaggerated. Excess cortisol leads to severe muscle, bone, and skin breakdown, which are the major protein stores of the body. It also leads to elevated blood glucose levels, and that leads to high insulin levels. Insulin, among its many actions, preferentially targets adipocytes, or fat cells in the center of the body, around the waist and buttocks. In those cells, the insulin activates lipoprotein lipase, which is an enzyme that helps those adipocytes accumulate more fat molecules. The result is central obesity. In addition to this, the high cortisol levels cause hypertension, and this is for 2 reasons. First, they amplify the effect of catecholamines on blood vessels. And second, cortisol starts cross-reacting with mineralocorticoid receptors, which normally only bind a related steroid hormone, mineralocorticoid, which are secreted from the zona glomerulosa layer of the adrenal cortex. In other words, because the cortisol is structurally similar to mineralocorticoid, it can bind to that receptor, and it can trigger the mineralocorticoid effect, which is mainly to increase blood pressure by retaining fluid. High levels of cortisol also inhibit the secretion of gonadotropin-releasing hormone from the hypothalamus, which messes up normal ovarian and testicular function. Excess cortisol also dampens the inflammatory and immune response, making individuals more susceptible to infections. Finally, high levels of cortisol seem to impair normal brain function, but the exact mechanism here is unclear. Cushing syndrome can happen because of exogenous cortisol, meaning that it comes from outside, usually in the form of medications. But it can also happen because of endogenous cortisol, meaning that the excess cortisol is made by the body. The majority of cases of Cushing syndrome happen in individuals using exogenous steroid medications over a long period of time, often to treat autoimmune and inflammatory disorders, like asthma or rheumatoid arthritis. That's because the molecular structure of exogenous steroid medication is so similar to cortisol that they mimic its actions on various tissues. In fact, exogenous steroid medication can also cause negative feedback on the hypothalamus and the pituitary gland. This causes a decrease in CRH and ACTH, which in turn shuts down cortisol production from the zona fasciculata. Over time, this lack of stimulation can cause the zona fasciculata to physically shrink or become atrophic. Since that's the widest part of the adrenal cortex, it can have a measurable effect on the overall size of the adrenal gland. Even though this results in less endogenous cortisol production, it still doesn't quite compensate for the huge levels of exogenous cortisol, and that causes Cushing syndrome to develop. In addition to taking exogenous steroid medications, Cushing syndrome can also result from increased levels of endogenous cortisol. The most common reason for that is excess ACTH. The leading cause of that is a pituitary adenoma, which is a benign tumor of the pituitary gland, and this specific condition is called Cushing disease. The exact reason for the development of this sort of benign tumor isn't known, but unlike a malignant tumor, the cells don't invade neighboring tissues or spread to other parts of the body. Instead, the pituitary adenoma simply grows in size and secretes too much ACTH. The excess ACTH overstimulates the zona fasciculata of both adrenal glands, which grow larger and secrete excess cortisol. Apart from pituitary adenomas, there are ectopic sources of ACTH, like small cell lung cancer. And in these cases, the excess ACTH is coming from somewhere other than the pituitary. Another common cause of endogenous Cushing syndrome is tumors of the adrenal glands that make excess cortisol, like adrenal adenomas, which are benign tumors, and adrenal carcinomas, which are malignant tumors. In both adrenal adenomas and carcinomas, the cells of the zona fasciculata within the adrenal cortex start dividing abnormally and secrete excess cortisol. As before, the excess cortisol provides negative feedback to the hypothalamus and pituitary gland, suppressing both CRH and ACTH production. Although this doesn't have any effect on the zona fasciculata of the involved adrenal gland, since the neoplastic cells are autonomous, meaning that they've grown independent from any stimulatory signals, the zona fasciculata of the uninvolved normal adrenal gland shrinks and produces less than the standard amount of cortisol. The net result, though, is still abnormally high levels of cortisol, and that causes Cushing syndrome to develop. Regardless of the cause, the symptoms of Cushing syndrome are directly related to the effects of excess cortisol on its various target tissues. Resulting from the increased breakdown of most types of tissue, the individual presents with muscle wasting in thin extremities, skin thinning, easy bruising, and abdominal striae or lines, as well as fractures due to osteoporosis or brittle bones. At the same time, there's fat redistribution. So classic findings include a round, full moon-shaped face, a buffalo hump, which is a fatty hump on the upper back, and truncal obesity, where fat gathers around the abdomen and trunk rather than in the limbs. Finally, excess cortisol causes hyperglycemia, or high blood sugar levels, that can progress to diabetes mellitus, hypertension, or increased blood pressure, along with a high risk for cardiovascular disease, as well as increased vulnerability to infections, poor wound healing, amenorrhea or absent menstrual bleeding, and psychiatric or mental disturbances. Diagnosis of Cushing syndrome is initially based on measuring the free or unbound cortisol in a 24-hour urine sample, in order to assess the total amount of cortisol excreted in the urine over a 24-hour period. Alternatively, blood or saliva tests late at night can help check if there's a normal daily rise and fall of cortisol levels. Another option is also the dexamethasone suppression test, which is when a person is given a low dose of dexamethasone, which is an exogenous steroid that suppresses ACTH production in the pituitary gland. Normally, that should cause a decrease in serum cortisol levels. But if Cushing's syndrome is caused by endogenous cortisol production, then the serum cortisol levels should remain unchanged. If that test is positive, the next step is to determine the exact cause of endogenous cortisol production. And ACTH plasma levels can be checked. Low ACTH levels can be seen in adrenal adenomas and carcinomas, whereas high ACTH levels can be seen in Cushing disease and ectopic ACTH production. If the ACTH level is high, the next step is to give an injection of a high dose of dexamethasone. Unlike pituitary adenomas, ectopic sites of ACTH productions typically don't respond even to high doses of dexamethasone, and the serum cortisol remains high. After all that, imaging can be used. An MRI of the pituitary gland in the case of Cushing disease, a CT scan of the adrenals when adrenal pathology is suspected, or a CT of the chest, abdomen, or pelvis if there seems to be an ectopic site of ACTH production. Treatment of Cushing's syndrome depends on the underlying cause. If it's due to exogenous medications, then the offending drug is gradually decreased and eventually stopped if possible. It's important to avoid sudden steroid withdrawal, though, because that can cause an adrenal crisis, which is life-threatening. That's because the adrenal glands might be atrophied and might need months to recover fully, and during that time, the body needs the exogenous steroids to function normally. If Cushing syndrome is due to a pituitary adenoma, like in Cushing disease, then surgical excision of the adenoma might be needed. Alternatively, medications like adrenal steroid inhibitors, like ketoconazole and metirapone, can be helpful, especially for cases of ectopic ACTH production or adrenal carcinomas that have already spread. Alright, as a quick recap, Cushing syndrome is any condition or situation that causes increased levels of cortisol. It can be exogenous, meaning drug-related, or endogenous, meaning that it's from an adrenal tumor or excess ACTH from a pituitary adenoma, in which case it's called Cushing disease, or from an ectopic site like small cell lung cancer.
Hey guys, thanks so much for watching. So this one was kind of a long one, but hopefully you learned a lot more about Cushing syndrome. Special kudos to Antonia for writing this awesome script, Rishi and Kyle for editing, and Tanner for the voiceover. And I actually did the illustrating and video editing for this one, which was a lot of fun. As always, if you guys love our videos, be sure to share us with your friends on social media. And if you're looking for more studying materials on this topic or any of the topics of our other videos, definitely check us out at osmosis.org. Thanks again, guys. See ya.
In pheochromocytoma, pheo means dark, chromo refers to color, cyto refers to a cell, and oma means tumor. So, a pheochromocytoma is a rare adrenal gland tumor where the cells darken when they form tumors. Now, there are two adrenal glands, one above each kidney, and each one has an outer layer called the cortex and an inner layer called the medulla. In the medulla, there are cells called chromaffin cells, and their job is to make hormones called catecholamines. The catecholamines include epinephrine and norepinephrine, the fight or flight hormones. Normally, the chromaffin cells in the adrenal gland secrete epinephrine and norepinephrine into the blood when something scary happens, like someone saying boom. The epinephrine and norepinephrine bind to alpha and beta receptors in various tissues throughout our bodies and cause an increase in cardiac output, increased blood pressure, dilated pupils, increased blood flow to skeletal muscles, and increased blood sugar. Pheochromocytomas are tumors that form when these chromaffin cells start to divide uncontrollably. They typically form in one of the adrenal glands, but rarely can be in both, and sometimes can even develop in other parts of the body where chromaffin cells are found, like the carotid arteries in the neck, the bladder, and the abdominal aorta. Most pheochromocytomas arise sporadically, but some are associated with an inherited syndrome. One of these is multiple endocrine neoplasias type 2A and type 2B, where pheochromocytoma is caused by a mutation in the RET gene, which is a proto-oncogene that encodes for proteins that promote cell growth and division. When the RET gene mutates, it becomes an oncogene that causes the cells to divide constantly. Another disease associated with pheochromocytomas is von Hippel-Lindau disease, which develops when there's a mutation in the VHL gene, which codes for the von Hippel-Lindau tumor suppressor protein. Tumor suppressor proteins normally inhibit cell growth and division, and mutations result in uncontrolled cell proliferation leading to tumors. A third disease is neurofibromatosis type 1, which is caused by a mutation in the gene NF1 that encodes for another tumor suppressor protein called neurofibromin, and the mechanism here is similar to von Hippel-Lindau disease. Once pheochromocytomas develop, they cause problems by releasing too many catecholamines into the blood. The catecholamine release is unregulated and could happen continuously or randomly. However, certain things like stress, physical exertion, and even certain foods that contain the molecule tyramine, like chocolate, cheese, and wine, can trigger the release of catecholamines. Imagine getting stressed, and then going to the gym, and then indulging in a plate of chocolate and cheese washed down with a glass of wine. A recipe for triggering catecholamine release. Once released into the blood, catecholamines cause smooth muscles around blood vessels to contract, raising the peripheral vascular resistance and causing hypertension. If blood pressure rises above 180/120 millimeters of mercury, it's called hypertensive urgency. When blood pressure is that high, it can break the small arteries and capillaries in various organs like the heart, brain, eyes, and kidneys, leading to hemorrhage and ischemia. When that happens, it's called hypertensive emergency. At that point, a person can develop congestive heart failure, have an ischemic stroke, a hemorrhagic stroke, retinal hemorrhages, and kidney failure. The high blood pressures also make it more difficult for the heart to pump blood to the body, causing blood to start backing up in the heart, and over time, that can worsen the congestive heart failure. Finally, like many tumors, pheochromocytomas can sometimes spread to other locations, most commonly to lymph nodes, liver, bones, and lungs. The most common symptom in pheochromocytoma is high blood pressure. Other symptoms include anxiety, headaches, sweating, and palpitations. Pheochromocytoma can be diagnosed by testing for high levels of catecholamines in the blood or urine, as well as their breakdown products like metanephrine, which can be found in the urine. If it seems like there's a pheochromocytoma, then an ultrasound or CT scan can be used to identify the location. For treatment, if a hypertensive crisis occurs, medications can be used to aggressively lower the blood pressure, and ultimately, surgery can be done to remove the tumor. Alright, as a quick recap, pheochromocytoma is a tumor of chromaffin cells in the adrenal medulla, which can sometimes be associated with genetic mutations. Pheochromocytomas cause problems by manufacturing too much of the catecholamines epinephrine and norepinephrine, which then causes high blood pressure. They can be diagnosed by testing the urine for catecholamines and metanephrine. The catecholamine release is unregulated and could happen continuously or at random times.
Polycystic kidney disease, or PKD, is a genetic disease in which the kidneys become filled with hundreds of cysts, or fluid-filled sacs, causing them to be larger than normal and to quit functioning over time. These cysts develop in the outer layer, the cortex, as well as the inner layer, the medulla, of both kidneys. These cysts, which are lined with renal tubular epithelium, fill up with fluid and get larger and larger over time, making the kidneys much larger than normal. The blood vessels that feed neighboring healthy nephrons can get compressed by growing cysts, which literally starves them of oxygen. Poorly perfused kidneys respond by activating the renin-angiotensin-aldosterone system, which facilitates fluid retention and leads to hypertension. Also, expanding cysts can compress the collecting system, causing urinary stasis, and in some cases this can lead to kidney stones. Additionally, destruction of the normal renal architecture can cause symptoms like flank pain and hematuria, or blood in the urine. Over time, as enough nephrons are affected, it leads to renal insufficiency and eventually renal failure. Now, the first type of PKD is autosomal dominant PKD, or ADPKD, which used to be called adult PKD since symptoms usually manifest in adulthood. The first gene responsible for ADPKD is PKD1, which when mutated causes the more severe and earlier onset variety, and PKD2, which when mutated causes less severe disease and is also later in onset. PKD1 and PKD2 code for the polycystin 1 and polycystin 2 proteins, respectively, which are components of the primary cilium. Now, the primary cilium is an appendage that sticks out from most cells in the body and receives developmentally important signals. More specifically, in the nephron, as the urinary filtrate flows by and causes it to bend, polycystin 1 and polycystin 2 respond by allowing calcium influx, which activates pathways in the cell that inhibit cell proliferation. If either component's absent, that signal to inhibit cell growth isn't received, and so cells proliferate abnormally and start to express proteins that cause water to be transported into the lumen of the cyst, which makes them get larger and larger, compressing the surrounding tissue more and more. And this is how cysts develop and grow. As expected for a dominant disease, a person who develops ADPKD would have inherited a single heterozygous mutation in PKD1 or PKD2. This leaves one functional copy of the gene in every cell, and this turns out to actually produce enough polycystin 1 or polycystin 2 to prevent cyst formation. So how do cysts occur then? Well, it turns out that a random mutation in the remaining good copy of the gene is almost guaranteed to happen in some of the tubular cells as the kidney develops. This second hit causes polycystin 1 or 2 to be absent and is what impairs normal signaling through the cilium and leads to cyst formation. So on the level of the person as a whole, ADPKD shows a pattern of dominant inheritance. But on the cellular level, it's technically a recessive trait. Polycystins are important in the kidney, but are developmentally important in other places in the body too. Patients can have cysts that are typically benign, pop up in the liver, seminal vesicles, and pancreas. The vasculature can also be affected. For example, individuals might develop aortic root dilation, which can lead to heart failure, and have Barry aneurysms of the cerebral arteries, usually in the circle of Willis. These aneurysms can have a thin wall, allowing them to rupture and develop into a subarachnoid hemorrhage. Autosomal recessive PKD, or ARPKD, used to be called infantile PKD, since symptoms usually manifest in infancy. ARPKD happens when someone inherits a mutation on both copies of the PKHD1 gene, which codes for the fibrocystin protein. Fibrocystin co-localizes with polycystin 2, where, although largely unclear, it might be involved in the regulation pathway and calcium signaling described with ADPKD. And therefore it's thought that a similar mechanism might cause cyst formation in ARPKD. In any case, with ARPKD, this cyst formation can lead to renal failure even before birth, which means the fetus has trouble producing urine, and since amniotic fluid comes from the fetal urine, fetuses with ARPKD can develop oligohydramnios, or low amniotic fluid. In fact, if enough amniotic fluid is missing, then it can cause Potter sequence. Without the amniotic fluid, the uterine walls actually compress the fetus, which causes physical developmental abnormalities, like club feet and a flattened nose. Also, as a part of Potter sequence, is pulmonary hypoplasia, or underdeveloped lungs, since the amniotic fluid is important in helping the lungs expand and develop normally. Underdeveloped lungs can cause respiratory insufficiency after birth, which ends up being fatal in a lot of cases of ARPKD. For diagnosis, ARPKD is one of the many conditions that can be picked up via prenatal ultrasound, which could show bilaterally large kidneys with cysts and oligohydramnios. ARPKD also causes congenital hepatic fibrosis, which over time can cause portal hypertension or compromise blood flow through the portal venous system. Portal hypertension can cause esophageal varices, upper GI bleeds, hemorrhoids, and splenomegaly from blood being shunted through the collateral veins. Since cholangiocytes, or the epithelial cells that line the bile ducts, also have primary cilia that express fibrocystin, ARPKD can also cause defects in the bile ducts, which leads to dilation. Dilated intrahepatic ducts can cause cholestasis, or poor bile secretion, and dilation of the common bile duct can lead to ascending cholangitis. The treatment of PKD is usually directed at specific symptoms and organ dysfunction. For example, for hypertension, medications like angiotensin-converting enzyme inhibitors or angiotensin receptor blockers can be used to counteract activation of the renin-angiotensin-aldosterone system. Also, ursodiol is sometimes taken to help treat cholestasis, since it slows down the rate at which cholesterol is absorbed by the intestines. In cases of kidney failure, dialysis or kidney transplants are sometimes needed. For individuals with portal hypertension, a portal caval shunt, which bypasses the liver by connecting the portal vein to the inferior vena cava, or again, a liver transplant might be needed. Alright, as a quick recap, polycystic kidney disease is a genetic disorder in which the kidneys become filled with hundreds of cysts, causing them to be larger than normal and to fail over time. PKD comes in two varieties, autosomal dominant, which presents in adulthood, and autosomal recessive, which presents in infancy or even before birth.
Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media. With renal artery stenosis, stenosis means narrowing, which refers to a progressive narrowing of the renal artery, which is the artery that carries blood to the kidney. This means that the blood downstream of the narrowed spot that goes to the kidney is at lower pressure, which gets sensed by the kidney. Since an important role of the kidney is to sense and help maintain a normal blood pressure, the kidney then tries to raise blood pressure throughout the body. Inside the kidney, there are millions of nephrons, each of which help to filter the blood and then fine-tune the composition of blood by carefully reabsorbing and secreting electrolytes as fluid passes through various parts of the nephron. Blood approaches the nephron via the afferent arteriole. You can remember it as A for approach, and then forms a tangle of capillaries called the glomerulus before exiting via the efferent arteriole, E for exit. That efferent arteriole goes on to split into another set of capillaries, the vasa recta, which surrounds the nephron, and then blood leaves via the venule. So there are two capillary beds per nephron. Usually we think of it going arterial, capillary, venule, but in the nephron it goes arterial, capillary, and finally venule. So nephrons have the general shape of the letter U, with the beginning and end portions getting pretty close to each other. The reason that this matters is that over here, lining the inside of the afferent arteriole are endothelial cells,
Wrapped around them are juxtaglomerular cells, which are super special smooth muscle cells that contract down like normal smooth muscle cells. But they also have the ability to release a hormone called renin in response to low blood pressure. Over here, close to the distal convoluted tubule, there's another special group of cells that line the tubule called macula densa cells, which are sodium chloride sensing cells that detect the sodium concentration in the tubule. These two clusters of special cells work together, because if the blood pressure falls, less blood's filtered and less sodium gets into the tubule. This is then detected by the macula densa cells, and they send out a local prostaglandin signal that reaches the juxtaglomerular cells and causes them to release renin. In addition, the juxtaglomerular cells are able to directly sense low pressure in the afferent arteriole, and also respond to sympathetic nerve fibers to release renin. Now, renin helps to constrict blood vessels and increases sodium reabsorption in the nephrons, which ultimately causes blood pressure to rise. Normally, as the blood pressure rises, the juxtaglomerular cells are no longer triggered to release renin, so balance gets restored. One cause of renal artery stenosis is atherosclerotic plaque buildup, which is where a mix of fat, calcium, and immune cells form a crusty rim on the inside of the artery. Another cause, though, is renal fibromuscular dysplasia, where fibro refers to fibrous collagen connective tissue, muscular refers to smooth muscle in the artery wall, and dysplasia means abnormal development. So renal fibromuscular dysplasia is when something goes wrong with connective tissue and smooth muscles in the walls of the renal artery, resulting in a series of bulges and narrow spots that leaves the artery looking like a string of beads, instead of a uniform cylinder. Fibromuscular dysplasia classically develops in young women, but the exact underlying cause is still unclear. In both atherosclerosis and renal fibromuscular dysplasia, the renal artery narrows, and that causes the blood pressure to stay low in the kidney, as well as all the kidney's nephrons. As a result, the juxtaglomerular cells release renin, which might raise the blood pressure in the body and vessels before the stenosis, but the pressure in the kidney and the afferent arterioles stays low, so they just keep releasing renin. So renal artery stenosis creates a vicious cycle of high blood pressure, or hypertension, which puts incredible stress on the blood vessels and can contribute to having a stroke or heart attack. Also, since the affected kidney receives less blood than usual, it eventually starts to atrophy or shrink in size, as the kidney cells die off and get replaced by fibrotic scar tissue. If the renal artery stenosis involves only one of the kidneys, then the other kidney can often pick up the slack. But if both kidneys are affected, then it can lead to acute kidney injury or acute renal failure. Symptoms are often a result of the hypertension, which if it gets severe can cause things like headaches and blurry vision. The diagnosis is therefore based on seeing if there's an underlying cause for hypertension. Physical exam might reveal a bruit, which is a whooshing sound heard with a stethoscope over the renal arteries in the abdomen, caused by the turbulence of blood flowing through the stenotic part of the renal artery. Basic screening labs like serum creatinine and a urinalysis can help assess kidney function as well. And imaging studies like ultrasound, CT scan, and MRI can visualize the kidney. For example, in this CT scan of the abdomen, the atrophied kidney is a lot smaller than the healthy one on the other side. Ultimately, since the problem's in the renal artery, a renal arteriography can be done to visualize the renal artery with dye, to see if there's evidence of a blockage. Generally, atherosclerosis forms in the beginning portion of the renal artery, where it branches from the aorta, whereas fibromuscular dysplasia develops in the middle to far end of the renal artery, nearest to the kidney. Treatment of renal artery stenosis is aimed largely at trying to manage hypertension, through using medications as well as adopting healthy eating and exercising habits. In addition, a surgical procedure called a balloon angioplasty can sometimes be used, and this is where a balloon's used to open up the narrowed portions of the renal artery, and in rare cases, a tiny stent is left behind to keep the artery propped open. An alternative option is to simply bypass the stenosis with another artery that's grafted into place. Ultimately, if one kidney becomes atrophied and non-functional, it also might be necessary to remove it. Alright, as a quick recap. Renal artery stenosis is where the artery that carries blood to the kidney becomes narrowed, which reduces the amount of blood that the kidney receives as well as the blood pressure. The kidney senses that low blood pressure and responds by releasing the hormone renin, which increases blood pressure, ultimately causing hypertension. Over time, the lack of blood flow can also cause the affected kidney to atrophy. Hey guys, thanks for watching. Hope you liked that video. Special thanks goes to Charles B. Davis for writing the script, as well as Kyle, Rishi, and Andrea for editing the script, and then I put together the illustrations. It's pretty much all I got for you, besides to remind you to check out our new subreddit, which is called r/osmosit. It is really new, so it needs some love. So check that out if you have time. Otherwise, you can always support us by following us on social media, as well as donating on Patreon and subscribing to our channel. All right, guys. Bye. Lymph is the fluid circulating in the lymphatic system. And edema refers to fluid buildup in the body's tissues. So lymphedema is a buildup of lymph somewhere in the body's tissues, typically as a result of some obstruction in the lymphatic system. Alright, so let's back up and real quick talk about this lymph stuff. So oxygenated blood gets sent from your heart to your tissues via arteries, which get smaller and smaller until they feed the capillary beds, which then provide nutrients to your cells, as well as pick up waste. And now deoxygenated blood then feeds back into larger and larger veins, and goes back to the heart. Pressure on the arterial side is a lot higher than on the venous side, so as blood comes into the capillary bed from the smaller arteries, called arterioles, the plasma, this colorless fluid part of the blood, is literally forced out into the interstitial space, the space between the cells. The majority of that fluid is reabsorbed on the venous side, but typically there's more forced into the tissue through the arterial side than is taken out by the venous side. And that's where the lymphatic system comes into play. All of that excess fluid gets pulled into the afferent lymphatic capillaries, which are these closed-ended vessels found throughout the body, even the brain, which is actually a discovery made in 2015. These lymphatic capillaries also have larger openings than the venous capillaries, which means that, in addition to the interstitial fluid, they can accept larger proteins, cellular debris, and even bacteria, which got squeezed out of the arterial side but were too large to get back into the venous capillaries. Once all that stuff's in the lymphatic system, it's called lymph. And those afferent lymphatic vessels have one-way valves which, along with smooth muscle contraction, keep lymph moving along toward the lymph nodes, which have immune cells that once again filter the fluid, getting rid of potential microbial threats. The fluid then leaves the lymph nodes and drains back into the systemic veins via the thoracic duct, which empties into the left subclavian and jugular veins, and right thoracic duct, which empties into the right subclavian and internal jugular veins, and rejoins the blood once again. So, getting back to lymphedema, when something blocks the normal flow in the lymphatic system, then the lymph gets backed up, which means the interstitial fluid can't drain properly, and fluid accumulates in the interstitial space. This also means those proteins and cellular debris build up as well, right? And when all that stuff stagnates, an inflammatory reaction is initiated, which causes macrophages to release inflammatory molecules which ultimately damages surrounding cells and leads to fibrosis, which is the thickening of the connective tissue, or scar tissue. This fibrosis causes hardening of the affected area, which is commonly the limbs. One of the most common global causes of lymphedema is filariasis, an infection with nematode parasites, which are these tiny worms. The most common species being Wuchereria bancrofti, Brugia malayi, and Brugia timori. Filariasis happens when one of these nematodes gets in the lymphatic system and causes a bit of fibrosis, both of which create a physical blockage and obstructs the normal flow of lymph. In developed nations, lymphedema is most commonly caused by cancer malignancy and/or its treatment. This could either mean the lymphatic system itself develops a cancer that causes an obstruction, which is called a primary lymphoma,
Or it could be the result of metastatic tumor cells from somewhere else that travel to the lymphatic system and cause an obstruction. Or it could be the result of cancer treatment, like for example if an affected lymph node or group of nodes are removed via surgery. The most common cancer-associated cause of lymphedema is removal of the lymph nodes as a treatment for breast cancer. All of these causes of lymphedema, you'll notice, are a result of some other disease. So these are situations that represent secondary lymphedema. Primary lymphedema, on the other hand, is when there isn't some other disease or factor that leads to lymphatic obstruction. Usually primary lymphedema is a congenital condition that's been present since birth, maybe as a result of part of the lymphatic system not developing right. For that reason, most people develop primary lymphedema early on, before age 35, which is called lymphedema precox. When someone develops primary lymphedema later on, usually after age 35, it's known as lymphedema tarda. Primary lymphedema is sometimes associated with other genetic disorders as well, like Turner syndrome. Diagnosis early on is difficult with lymphedema, since there aren't many obvious signs, and because it can sometimes mimic chronic venous insufficiency, or CVI, where blood collects in the veins. Though this usually happens bilaterally, meaning on both sides of the body, as opposed to one side of the body with lymphedema. That being said, sometimes lymphedema can be diagnosed by comparing the affected limb to the opposite limb. To help out with diagnosis, staging systems are often used, the most commonly used one being defined by the World Health Organization. During stage 0, the latent stage, there's some damage to the lymphatics, but enough lymph is still being removed, so lymphedema is not present. During stage 1, the spontaneously reversible phase, the tissue's in the pitting stage, where it indents when pressed and reverses when it's elevated. Also, usually that affected area is normal or almost normal in size in the morning. Stage 2, or the spontaneously irreversible stage, the tissue takes on a spongy consistency and is now non-pitting, and so it bounces back when it's pressed. Also, fibrosis starts to develop and the limbs harden and increase in size. Finally, during stage 3, or lymphostatic elephantiasis, swelling becomes irreversible, and the affected limbs are really large and hardened from fibrosis. Treatment depends on how severe the edema is, and how far along the fibrosis is in the affected limb. People might wear compressive bandages that can help keep fluid from accumulating, as well as have compression lymphatic massages to help with lymph flow. If these options don't work, sometimes people with lymphedema can have surgery to help either improve drainage or reduce fluid load.
Alright, as a quick recap. Lymphedema is a buildup of lymph in the interstitial space as a result of an obstruction in the lymphatic system, which can cause edema, inflammation, and fibrosis in the tissues. Lymphedema can be primary when it happens alone, or secondary when it happens as a result of another disease like filariasis or cancer. Treatment includes compressive bandages, compression lymphatic massages, and surgery to help either improve drainage or reduce fluid load. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media.
Tariq is a 52-year-old individual who presents to the clinic complaining of left leg pain. He describes the pain as cramping and mostly located in his calf. He also mentions that the pain comes every time he walks from his home to the supermarket and is relieved when he rests. Tariq also has a known history of hypertension, diabetes mellitus, and a myocardial infarction 2 years ago. On physical examination, there's a noticeable decrease in hair growth on the left side compared to the right, and the skin appears dry and shiny. There is no leg swelling, and there's no back pain. Peripheral artery disease is insufficient tissue perfusion due to narrowing or occlusion of the aorta or one of its peripheral branches supplying the limbs. Similar to coronary artery and cerebrovascular disease, The development of an atherosclerotic plaque that narrows or completely occludes an artery is the number one cause of peripheral artery disease, and so these diseases often coexist together. So on the exam, an important clue may be an individual with a past medical history of a myocardial infarction or a stroke. In addition, look for risk factors of atherosclerosis, such as hypertension, diabetes mellitus, smoking, and hyperlipidemia. The symptoms of peripheral artery disease depend on how bad the occlusion is. In the early stages of the disease, individuals may be completely asymptomatic. One of the first symptoms is intermittent claudication. This is characterized by cramping pain in the affected area that comes about during exercise and is relieved with rest. Individuals often describe a specific and often consistent distance that brings about the pain, such as walking 2 blocks. The location of the pain can also help give a clue about which artery is occluded. For example, hip claudication indicates aortic or iliac artery occlusion, whereas calf claudication points toward femoral or popliteal artery occlusion. In addition to claudication, chronic limb ischemia may produce some physical changes. This includes a decrease in the skin temperature called poikilothermia. Also, hair and nail growth decrease and sensation can be lost. On physical exam, the pulse distal to the obstruction is weak, and there's diminished capillary refill in the affected area. As the arterial narrowing worsens, individuals begin to complain of pain at rest. This is classically worse at night when the individual is sleeping, and gets better when they stand up or hang their leg off the bed due to the effect of gravity on blood flow. Eventually, the peripheral tissue dies, which manifests as gangrene and ulcers. The end-stage manifestation is critical limb ischemia, which includes pain at rest as well as tissue loss in the form of gangrenes and ulcers. Critical limb ischemia is limb-threatening if operative intervention is not performed. For diagnosis, when there's suspicion of peripheral artery disease, an ankle brachial index test, or ABI, is performed. ABI is the ratio of ankle systolic blood pressure to brachial systolic blood pressure. Normally, both pressures should be equal, and so the ratio should be equal to 1. In individuals with intermittent claudication, the ABI usually lies somewhere between 0.4 and 0.9, since the blood pressure in the ankle is decreased. In severe peripheral artery disease, usually when the individual begins to develop resting pain, the ABI is less than 0.4. After doing the ABI, the diagnosis is further confirmed with imaging, such as ultrasound or CT angiography. For treatment, lifestyle changes like exercise programs and diet are the first steps. For medication, cilostazol, a phosphodiesterase inhibitor, can directly dilate the arteries, easing symptoms. In addition, it's an antiplatelet, which can prevent platelet aggregation and decrease the risk of thrombosis. Even without cilostazol, they should still take an antiplatelet medication like aspirin as prevention for coronary artery disease and stroke. Now, when there's severe obstruction and tissue necrosis, endovascular or surgical procedures are done to preserve the affected limb. Now, let's take a look at some of the other less common causes of peripheral artery disease other than atherosclerosis. Although they're less common, they make for good exam questions. Think of these when the case is of someone with no atherosclerotic risk factors. First, vasculitides can cause peripheral vessel occlusion. A particularly high-yield one is thromboangiitis obliterans. This affects individuals between 20 and 40 years and commonly occurs in people who smoke and can cause claudication in the feet, calves, and hands. An additional high-yield clue is the presence of Raynaud's phenomenon, which is a gradual discoloration of the hands from white to blue and then to red, and happens following exposure to cold. A popliteal artery aneurysm is another potential cause. Due to the stasis of the blood in the area of the aneurysm, a clot can form. That clot can then embolize and occlude smaller vessels in the legs. In addition, atrial fibrillation can dislodge clots that travel from the heart to the limbs, causing the same kinds of problems. A high-yield concept is that with an arterial embolus, there is a sudden onset of symptoms rather than the gradual onset of symptoms caused by atherosclerosis. All right, next are important mimickers of peripheral artery disease that should be on your differential diagnosis list. First is deep vein thrombosis, which can also present with leg pain. However, deep vein thrombosis is usually associated with leg swelling and redness, and individuals have risk factors such as immobility and hypercoagulability. Next is lumbar spinal stenosis, a condition in which the central canal or neural foramina of the vertebrae are narrowed due to degenerative changes associated with aging. Because it compresses the nerves that run down the leg, individuals present with unilateral or bilateral leg pain that is worse with walking and is relieved with rest. This presentation is very similar to peripheral artery disease, but you can tell them apart since when the pain is neurogenic, the peripheral pulses should be completely normal. In addition, the pain in neurogenic claudication is also relieved by flexing the back, or bending forward, and is worsened by extending the back, or bending backward. All right, as a quick recap, peripheral artery disease is narrowing of the peripheral arteries, usually because of atherosclerosis, but other causes include vasculitis and arterial emboli. Individuals typically present with a spectrum of symptoms ranging from intermittent claudication to resting pain, to eventually developing gangrene and ulcers. Other symptoms of chronic ischemia include hair loss in the affected area, dry skin, decreased peripheral pulses, and loss of sensation. The diagnosis is initially made by performing an ankle brachial index with an ABI less than 0.9 being abnormal. Imaging with ultrasound or CT angiography further determines the location and extent of arterial narrowing. Important differential diagnoses to consider include deep vein thrombosis and lumbar spinal stenosis. Okay, back to our case. Tariq is presenting with symptoms suggestive of intermittent vascular claudication. The pain is reproducible when he walks a certain distance, in his case to the supermarket. Supporting the diagnosis, Tariq has risk factors for atherosclerosis, like hypertension and diabetes, and also has a history of myocardial infarction. In addition, he has physical signs of peripheral artery disease, like decreased hair growth. He also doesn't appear to have symptoms of the mimickers, with no leg swelling and no back pain. Tariq underwent an ABI test, which showed a ratio of 0.5. CT angiography confirmed narrowing of his left femoral artery, which is consistent with the location of his pain in the calf.
With peripheral vascular disease, vascular refers to the blood vessels, and peripheral means the outer limits or edge of something, which in this case refers to essentially any vessels that aren't supplying the heart or the brain, like the legs, arms, or other organs. Peripheral vascular disease is when one of these arteries becomes narrowed, which reduces blood flow, and this often affects the limbs. Peripheral vascular disease, or PVD, usually involves the arteries, and so sometimes it's also referred to as peripheral artery disease, or PAD. PVD is most often caused by a blockage called organic PVD, most commonly caused by atherosclerosis, which is a buildup of lipids and fibrous material just under the inner lining of the blood vessel, called the tunica intima. When plaque builds up, it narrows the artery, which reduces perfusion to whatever tissue it tends to supply. And this buildup usually happens over the course of years. Also, though, the vessel could be blocked by an embolus, which can happen suddenly if a blood clot from some upstream artery lodges in a peripheral artery, which obviously stops blood flow from getting to the tissue the vessel supplies. Besides organic PVDs, though, there are also functional PVDs, where blood vessels stop blood flow by changing diameter, like with vasospasms, where the vessel constricts and blood flow is reduced. This type is usually short-term and can come and go. Alright, so the most commonly affected vessels in peripheral vascular disease are the arteries supplying the legs. So when less blood gets to the muscle tissue in the legs, that tissue sees less oxygen and becomes ischemic. Ischemic cells release adenosine, a type of signaling molecule which is thought to affect nerves in these areas, which is felt as pain. This pain in the legs is often referred to as claudication. Sometimes, even though it's narrowed, at rest there's enough blood to meet the tissue's demands, and many people are usually asymptomatic. But if that person is walking or exercising, then the leg muscles start to work harder and demand more oxygen. so demand becomes greater than what's being supplied, which causes the claudication or pain. The location of the pain is a clue on which artery is involved. If it's the hips and the buttocks, think lower aorta or iliac. If it's the thigh, then think iliac or common femoral artery. For the upper 2/3 of the calf, the superficial femoral artery. The lower 1/3, the popliteal artery. And finally for the foot, think tibial or peroneal artery. Other symptoms include leg or foot wounds or ulcers that don't heal up normally, as well as color changes of focal areas of the skin. So for example, if the leg's been affected, the foot might turn pale white when it's raised, called elevation pallor, since gravity's sort of working against blood flow to the lower extremities, which already has a hard time getting through that narrowed artery. Likewise, the foot might turn red when it's lowered, called dependent rubor, since gravity's now working with the blood flow. We can see that gravity seriously starts to affect blood flow in the affected arteries. As that arterial blockage gets bigger, less and less blood gets to the tissues, which can lead to more serious complications. First, rest pain describes a continuous burning or pain in the forefoot and toes when the legs are elevated, and then the pain is relieved when they're lowered, like hanging the feet over the bed or walking around the room, which allows more blood to get down to the foot. If the blockage is severe enough, then the limb might be at risk of gangrene, death of the tissue, because without oxygen for long enough, the cells can actually die, or necrose, in which case the dead tissue would likely have to be removed, and in some cases the limb would have to be amputated. The major risk factors and causes of peripheral vascular disease are the same as those for atherosclerosis. The same process that, if involved in the neck arteries, can cause a stroke, and if involved in the coronary arteries, can cause a myocardial infarction or a heart attack. Smoking seems to be the biggest contributor to PVD, but other diseases and conditions are also linked to higher risk of PVD, like diabetes, dyslipidemia, or an abnormal amount of lipids in the blood, and hypertension. Diagnosing PVD usually involves listening to the pulse in the iliac arteries of the legs with a stethoscope.
Since that artery's been narrowed, it can make a whooshing sound, called a bruit.
Another test that can be done is a Doppler ultrasound, which is a non-invasive way of visualizing blood flow. The most common test, though, to diagnose peripheral artery disease is the ankle brachial index, or ABI, where blood pressure is taken in the ankle and in the arm, and then compared. Peripheral artery disease is typically diagnosed if the systolic blood pressure in the ankle divided by the systolic blood pressure in the arm is less than 0.9. In general, claudication is often seen in people with an ABI between 0.4 and 0.9. Rest pain is seen between 0.2 and 0.4, and tissue loss, ulcers, and gangrene between 0 and 0.4. Treating PVD often requires significant lifestyle changes that address the underlying risk factors, like quitting smoking, for one, as well as adopting healthy eating habits and exercising regularly. Alongside these, though, sometimes people with PVD will also get certain medications that typically aim to reduce the likelihood of blood clotting and obstruction of the blood vessels. Surgical intervention like angioplasty or bypass surgery is rarely needed.
Alright, as a quick recap. Peripheral vascular disease, or PVD, refers to narrowing of a blood vessel, usually an artery that does not supply the heart or brain. PVD can be organic, where the narrowing is caused by a blockage, or functional, where the blood vessels are constricted. PVD causes a reduction in blood flow to the tissue supplied by the artery, resulting in tissue ischemia, gangrene, and necrosis. Treatment involves lifestyle changes, medication to reduce clotting, or rarely surgery. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media. Renal nutcracker syndrome is when the left renal vein, which drains blood from the left kidney, gets squeezed between two arteries, the superior mesenteric artery and the abdominal aorta. It's kind of like the renal vein is the nut and the two arteries are the nutcracker. Now, blood heading toward the lower body exits the left ventricle, swoops around the aortic arch, and then flows downward through the descending aorta, which is a large muscular blood vessel about as thick as a thumb. The descending aorta runs along the back of the abdominal wall next to the spine, where it's called the abdominal aorta, until it splits into the common iliac arteries. The abdominal aorta gives rise to a lot of smaller arteries, including 3 unpaired arteries: the celiac artery, the superior mesenteric artery, and the inferior mesenteric artery, all 3 of which branch off the anterior wall and supply blood to the digestive tract. It turns out that the renal vein, which carries blood returning from the kidney to the heart, passes right between the aorta and the superior mesenteric artery. The angle formed between these 2 vessels is called the aortomesenteric angle, and it's usually around 45 degrees, with the renal vein being cushioned a bit by fat in the mesentery. If that aortomesenteric angle is reduced, the arteries start to pinch the left renal vein like a nutcracker, preventing blood from getting back to the heart. This leads to a backup of blood in the left kidney and renal hypertension. Over time, the high pressures can cause small breaks in the renal blood vessels, and a tiny bit of blood can even get in the urine. Also, the left testicular vein drains into the left renal vein, so in men, blood ends up backing up into the left testicle as well. In young people, reduction of the aortomesenteric angle can happen due to normal growth, as well as changes in body proportions. As a result, sometimes the angle can widen just as easily as it narrowed. In adults, the most common cause is extreme weight loss as the result of severe or prolonged illness, like cancer, HIV and AIDS, drug use, and anorexia nervosa. Regardless of the cause, nutcracker syndrome typically results in left flank pain and hematuria, or blood in the urine. The backup of blood on the left side can also cause a varicocele in men, which is engorgement of the testicular veins, in this case the left testicular veins. Nutcracker syndrome can be diagnosed by imaging the left renal vein with something like ultrasound, and then measuring the blood flow and the aortomesenteric angle, which can get as narrow as 6 degrees. The main treatment for this is simply weight gain, because when the mesenteric fat pad gets fatter, it widens the aortomesenteric angle, relieving the left renal vein compression. In severe situations where gaining weight doesn't do the trick, surgery might be needed to place a stent within the vein to keep it open. Alright, as a quick recap, nutcracker syndrome is when the left renal vein is squeezed between the superior mesenteric artery and the aorta, because that aortomesenteric angle gets too narrow. This causes increased pressure in the left renal vein, which can lead to hematuria and flank pain, as well as a left-sided varicocele in men. Nutcracker syndrome can be corrected with weight gain, and sometimes, if necessary, surgery. Hey, what's happening, guys? Thanks for watching that short video on nutcracker syndrome. If you want to do a deeper dive on that topic, you should head over to osmosis.org. We've got a bunch of flashcards and quiz questions and other awesome stuff to help you learn medicine. So if you're interested in that, definitely check it out. Otherwise, you can always support us by donating on Patreon and subscribing to our channel and following us on social media. This particular video was written by Krista, and I believe this was her first video, so congrats, Krista. I think the script turned out really well. And then Rishi did the editing of the script, and I did the illustrating, and Yifan did the video editing. So thank you to everyone who helped make that video. I think it turned out really well. Till next time, bye guys. Superior mesenteric artery syndrome is when the first part of the small intestine, which is the duodenum, gets squeezed between 2 large arteries, the abdominal aorta and the superior mesenteric artery. So when the duodenum gets squashed, food can't easily pass by, and this leads to intestinal obstruction. Normally, blood heading toward the lower parts of the body exits the heart, swoops through the aortic arch, and then flows downward through the descending aorta, which is a large muscular blood vessel about as wide as a thumb. The descending aorta runs along the back of the abdominal wall in front of the spine, and that part's called the abdominal aorta. The abdominal aorta then forks into the common iliac arteries near the fourth lumbar vertebra, or L4. Along the way, it gives rise to a number of paired arteries like the renal arteries, as well as 3 unpaired arteries, the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery, all of which come off of the anterior or front wall of the aorta and supply blood to the stomach and intestines. Usually, the angle between the aorta and the superior mesenteric artery as it branches off, the aortomesenteric angle, is around 45 degrees. It turns out that the duodenum, which is the C-shaped first section of the small intestines, passes through this little archway. More specifically, it's the third or transverse section of the duodenum, and as it passes through, it's cushioned by the mesenteric fat pad, which is a collection of fat that protects the duodenum from getting crushed by the 2 arteries. In superior mesenteric artery syndrome, the mesenteric fat pad starts to thin out, which reduces the aortomesenteric angle, allowing the aorta and superior mesenteric artery to pinch down on the transverse duodenum. This blocks food from passing from the duodenum to the jejunum, and the backup of food leads to intestinal obstruction. There are a few reasons why this might happen, and the most common one is extreme weight loss, from any cause like an illness or even intentional weight loss like an anorexia nervosa. In young people, another common cause of superior mesenteric artery syndrome is surgery for scoliosis, which is a condition where the spine's abnormally curved. During the surgery, the spine is straightened, and the aorta and superior mesenteric artery get stretched upward, causing the aortomesenteric angle to narrow. Rarely, there can be congenital anatomic abnormalities, like when the ligament of Treitz, which holds the duodenum in place, is too short, or when the superior mesenteric artery branches off of the aorta further down than its usual spot. Regardless of the cause, the main symptom of superior mesenteric artery syndrome is small bowel obstruction, and the onset can be gradual or pretty quick, depending on the underlying cause. Depending on the severity, symptoms can range from abdominal pain and early satiety, which is where someone feels full after eating only a tiny bit, to vomiting and significant weight loss. Vomit can contain bile, which is secreted into the digestive tract before the point of compression along the transverse duodenum. Diagnosis starts with identifying the small bowel obstruction, which might be due to a lot of things, including superior mesenteric artery syndrome. Typically, on exam, a small bowel obstruction can cause high-pitched bowel sounds, as well as a succussion splash, which is the sloshing sound of built-up gas and fluid in the distended digestive tract upstream of the obstruction. If superior mesenteric artery syndrome is suspected as the underlying cause of the obstruction, imaging studies like abdominal X-rays or CT scans with oral contrast can be helpful, as well as an abdominal ultrasound to measure the aortomesenteric angle, which can get as narrow as 6 degrees. Treatment of a small bowel obstruction includes inserting a nasogastric tube to decompress the stomach and early duodenum, as well as includes offering fluids and electrolytes. The major treatment for superior mesenteric artery syndrome is weight gain to help regrow the mesenteric fat pad. Sometimes that requires a feeding tube inserted past the site of obstruction. If the underlying problem is the ligament of Treitz, treatment could include surgery to allow the duodenum to move more freely. Alright, as a quick recap, superior mesenteric artery syndrome is when the duodenum is squeezed between the superior mesenteric artery and the aorta, usually due to loss of surrounding mesenteric fat. This causes the aortomesenteric angle to go from a normal 45-degree angle down to as little as 6 degrees. The result is small bowel obstruction, which can cause early satiety and vomiting, and can be corrected with weight gain and, in certain cases, surgery.
Hey guys, thanks for watching. Just want to take a quick second to thank all of you who've taken the extra time to rate and review us on Facebook. We now have 1,000 reviews. That's amazing. We really appreciate the feedback, so thank you guys so much. Today's video is brought to you by Krista, who wrote the script, Rishi and Charles, who did the editing, Tanner, who did the voiceover, Yifan did the video editing, and I did the illustrating. As always, if you guys love our videos, be sure to share us with your friends on social media. And if you want to learn more about this topic or other topics in our other videos, definitely check us out at osmosis.org. We have lots of studying materials on there, including flashcards and quizzes and even studying schedules. It's super awesome. So thanks again, guys, for watching, and see you later. Bye.
Vascular tumors are tumors of the blood vessels, and there are actually a lot of different types, so this is just a quick overview of 3 types of tumors: Kaposi sarcoma, hemangiomas, and angiosarcomas. Kaposi sarcoma is a malignant vascular tumor that's linked with an infection of the human herpes virus 8, otherwise known as HHV8, and it's a cancer of the blood vessel endothelial cells. This virus is thought to get inside the cells and cause the cells to replicate uncontrollably. This type of cancer is seen in people who have suppressed immune systems, and that's why it's one of the common diseases that you're at risk of getting if you have AIDS, and is a complication of organ transplant patients. The most common symptoms of Kaposi sarcoma affect the skin, causing purple and red lesions.
These lesions look somewhat like a bruise, but unlike a bruise, they don't blanch or turn pale when pressed. That's because a Kaposi sarcoma has blood-filled blood vessels, whereas bruises are caused by blood leaking outside of blood vessels into the skin.
Initially, these lesions start off flat, but over time they might become raised and more painful. In people who have a compromised immune system, the disease can cause lesions in other tissues like the mouth, the nose, the throat, the lymph nodes, the lungs, and the gastrointestinal tract. You can sometimes treat affected skin by surgically removing it or freezing it off using cryotherapy. But treating the disease in immunocompromised patients is a little more difficult. If someone's immune system is compromised because of drugs like corticosteroids, it might be necessary to adjust immunosuppressants and allow the immune system to recover. It's a lot harder to treat the disease in an AIDS patient whose immune system is severely compromised, so antiretroviral therapy is commonly used by patients to restore immunity. Radiation and chemotherapy are also treatment options. Hemangiomas are the next type, and these are benign vascular tumors of the endothelial cells of the blood vessels. Too much endothelial cell growth typically leads to a messy clump of blood vessels, all filled with blood, similar to a Kaposi sarcoma, except these are benign. These tumors are usually found in the skin, but can happen pretty much anywhere. These look like birthmarks and can be raised above the skin, rubbery, and range in color from dark purple to bright red. This tumor is sometimes seen in newborns, but will usually disappear as they get older. In fact, they sometimes start out small, then grow larger, before finally shrinking by the first year of life. About half of them disappear completely before age 5, and the rest usually disappear before the teenage years. Sometimes steroids or even beta blockers are used to help these regress, and only in rare situations is surgery needed. When it's clear that a tumor will regress on its own, removing the tumor surgically can sometimes cause more permanent scarring than if it's left alone. Also, there are a couple different types of hemangiomas. Pyogenic granulomas, sometimes called eruptive hemangiomas or pregnancy tumors, look like an overgrowth of tissue and appear most often on the face and hands, but can also happen other places. This type often bleeds and can be removed by cautery. Capillary hemangiomas, sometimes called strawberry hemangiomas, are the most common type and are raised and lumpy, kind of like a strawberry, I guess. And these usually subside by age 10. Finally, cavernous hemangiomas are similar to capillary hemangiomas, except that they're typically deeper and they can disappear on their own, but sometimes might need surgical removal. Alright, if you're a dog owner, you might have heard of angiosarcoma. Angiosarcoma is a malignant cancer, just like Kaposi sarcoma, and again involves the endothelial lining of the blood vessels and is fairly common in large dogs. It's less common in humans, but enough to still be aware of. Angiosarcomas are really aggressive and can affect the blood vessels in the liver. People who are frequently exposed to vinyl chloride monomer gas in PVC manufacturing are at risk of developing the disease, along with people who are exposed to arsenic insecticides and thorotrast, which is a radio contrast used during imaging procedures back in the 1930s and 40s.
In angiosarcoma, sarcoma refers to a malignant tumor and angio refers to a blood vessel or a lymphatic vessel. So angiosarcoma is a cancer of either a blood vessel, in which case it's called a hemangiosarcoma, or a cancer of a lymphatic vessel, in which case it's called a lymphangiosarcoma. Both of these arise from the inner lining of the vessel wall, known as the endothelium. Angiosarcomas form when endothelial cells suddenly start proliferating abnormally. If these masses grow inside the blood vessel lumen, they can obstruct the blood flow, and that can interfere with the oxygen and nutrient supply to various tissues, and eventually can result in tissue ischemia. If lymph flow is obstructed, lymph fluid backs up in the tissues, causing lymphedema. Cancer cells from hemangiosarcomas and lymphangiosarcomas can also invade the vessel wall, destroying it and making it burst, which leads to bleeding or lymph fluid outflow in the surrounding tissue. In general, these cancer cells multiply at a very rapid rate, and can be easily carried by blood flow or lymphatic flow to faraway sites of the body, particularly the lungs, where they form a new metastatic tumor. And that's why angiosarcomas are considered to be extremely aggressive. Angiosarcomas can happen anywhere in the body, but most often involve the skin, bone, soft tissue, breast, or liver, and often spread to the lungs. Angiosarcoma of the skin usually shows up on the head or neck as a raised purplish skin area that looks like a bruise and doesn't heal and might bleed. It can be painful or might be accompanied with swelling in the surrounding skin. Angiosarcoma of the bone is usually multifocal, meaning that it affects multiple sites within the same bone, or involves multiple bones of the same limb. The exact causes of angiosarcoma is still unknown. One risk factor is chronic lymphedema in some parts of the body, like the arms or legs, that goes on for several years. This typically happens when lymph nodes have been removed or damaged, and fluid in the tissues have no way of draining away. Lymph nodes are sometimes surgically removed as part of cancer treatment, or might be destroyed by trauma or infection, or might not be there at all because of a congenital problem. Angiosarcomas in the liver have been associated with vinyl chloride gas, which is found in PVC manufacturing and arsenic insecticide. Symptoms of angiosarcoma depend on the affected organ. Soft tissue angiosarcomas can cause pain and swelling, and can compress the peripheral nerves, causing tingling, prickling, or numbness. In the breast, angiosarcomas form rapid-growing, palpable masses, while in the liver, hepatic angiosarcomas can cause vague symptoms like fatigue and abdominal pain. Metastasis of angiosarcoma to the lungs can cause chest pain and difficulty breathing. The diagnosis of angiosarcoma is based on a biopsy of the mass. Imaging studies like an MRI or CT scan can help establish the location and extension of the cancer. Treatment of angiosarcoma depends on the location and extent of the tumor, and it can include surgery, chemotherapy, or radiotherapy, or some combination of these three. Alright, as a quick recap, angiosarcoma is an aggressive cancer of the endothelial cells lining the walls of blood vessels or lymphatic vessels. It usually affects the skin on the head and neck, soft tissue, bones, breast, or liver, but also metastasizes quickly, especially to the lungs.
Human herpes virus 8, or HHV8, also called Kaposi's sarcoma-associated herpes virus, or KSHV, belongs to the family of human gamma herpes viruses. HHV8 is one of the 7 known oncoviruses, meaning viruses that cause cancer in people. Specifically, HHV8 causes Kaposi sarcoma, a type of cancer usually seen in individuals with AIDS. Human herpes virus 8 is a large, double-stranded linear DNA virus surrounded by an icosahedral capsid, which is a spherical protein shell made up of 20 equilateral triangular faces. The capsid is covered by a protein layer called the tegument, and finally enclosed in an envelope which is a lipid membrane that contains viral glycoproteins and is acquired from the nuclear membrane of host cells. HHV8 is transmitted through sexual contact, and once in the body, it uses the viral glycoproteins on its envelope to enter a wide variety of cells, such as B cells, endothelial cells, macrophages, and epithelial cells. Now, the virus life cycle has two phases, a latent phase and a lytic phase. In the latent phase, the virus just hangs out in the cell without destroying it and expresses the viral latency-associated nuclear antigen, or LANA1. This may sound harmless, but LANA1 inhibits p53, a tumor suppressor protein that prevents cancer formation. So when LANA1 inhibits p53, that prevents apoptosis and leads to uncontrolled cellular proliferation. In the lytic phase, the virus starts to replicate, so its DNA gets transcribed and translated by cellular enzymes in order to form viral proteins, which are packaged into new viruses. When the virus enters into the lytic phase, thousands of virus particles can be made from a single cell, which can destroy the cell and subsequently infect neighboring cells. Now, the body's immune system reacts to the infection by mounting a humoral response, where the B cells create antibodies to fight off the virus, and a cellular response, in which cytotoxic T cells work to kill the infected cells, limiting their ability to spread to other tissues. So, in people with a healthy immune system, infection rarely occurs. However, people who are immunocompromised, such as people with AIDS, people who have undergone an organ transplant, or people who take immunosuppressive medications, are at risk for developing the disease. Specifically, HHV8 causes a disease called Kaposi sarcoma, which is classified into 4 types depending on the clinical circumstances in which it develops: classic, endemic, epidemic, and immunosuppression therapy related. So, classic Kaposi sarcoma usually affects older males, it's slow growing, and it usually affects the legs. Endemic Kaposi sarcoma occurs in young adult males who live in Africa and can be more aggressive. Epidemic Kaposi sarcoma is associated with AIDS and can affect many body parts such as skin, mouth, GI tract, or lungs. Finally, immunosuppression therapy-related Kaposi sarcoma affects the skin, and it usually develops following organ transplantation. Now, regardless of type, Kaposi sarcoma is an endothelial cell neoplasm, so it causes vascular proliferation, resulting in dark or violaceous plaques. These lesions are typically found on the skin, especially on the lower limbs, back, face, and genitalia, but they can also affect the mouth, GI tract, and lungs. Lesions in the mouth are usually found on the hard palate and gums, and they can be easily damaged by chewing, so they can bleed or get infected. Involvement of the GI tract can be asymptomatic, or it can cause weight loss, nausea, vomiting, diarrhea, bleeding, malabsorption, or intestinal obstruction. When the lungs are involved, that can cause shortness of breath, chest pain, cough, and hemoptysis, which means coughing up blood. Diagnosis of Kaposi sarcoma requires a biopsy of the lesions. Microscopic examination can show tumor cells with a characteristic abnormal elongated shape called spindle cells, and immunohistochemical staining of biopsy specimens can detect the presence of LANA1 within the spindle cells and confirming the diagnosis. Finally, viral DNA can be identified with PCR. Treatment is mainly aimed to stop the progression of Kaposi sarcoma, as the disease is not curable. So when it occurs in individuals with immunodeficiency, treating the cause of the immune system dysfunction can slow or stop the progression of KS. For example, in HIV-infected individuals, treatment is done using highly active antiretroviral therapy, or HAART, which leads to HIV suppression that may shrink Kaposi sarcoma lesions. In all types of KS, skin lesions can be treated with local measures such as radiation therapy or cryosurgery, and in cases of widespread disease with involvement of internal organs, chemotherapy can be used with anthracyclines such as doxorubicin, daunorubicin, thalidomide, or paclitaxel. All right, as a quick recap, human herpes virus 8 is a double-stranded DNA virus which causes a type of cancer that most commonly occurs in AIDS patients called Kaposi's sarcoma. HHV8 expresses a viral antigen called LANA1, which prevents apoptosis and facilitates uncontrolled cellular proliferation. Kaposi's sarcoma affects most commonly the skin, but it can also affect mouth, GI tract, and lungs. Diagnosis is made with biopsy of lesions and microscopic examination, which can detect spindle cells, and also with immunohistochemical staining, which detect the presence of LANA1. Treatment in HIV-infected individuals is done with highly active antiretroviral therapy, or HAART, and treatment of widespread disease is done using chemotherapy.
Vasculitides are a group of disorders that cause vasculitis, which is an inflammation in the walls of the blood vessels. Since blood vessels pass through organs, vasculitis damages those organs and mimics a variety of diseases. They are usually systemic symptoms like fever, fatigue, joint pain, and weight loss, as well as organ-specific symptoms that may literally involve any organ. Whenever vasculitis is suspected, there's inflammation, which is often reflected by an increased ESR, CRP, and increased white blood cell count, and sometimes requires a biopsy of whichever organ or tissue is involved. The vasculitides are divided into groups based on the size of the arteries that are mainly involved. There's large vessel, medium vessel, and small vessel vasculitis, which affects, you guessed it, small arteries and capillaries. Starting with large vessel vasculitis, the first condition is giant cell arteritis, also called temporal arteritis. This is the most common vasculitis in individuals over the age of 50. The most frequently affected arteries are the external carotid, ophthalmic, and temporal arteries. Symptoms include a headache and vision loss, and a worrisome complication is that there's a high risk for a stroke. Often, the temporal artery can become tender and rigid. In addition, individuals can get jaw claudication, which is when there's temporal artery insufficiency causing ischemia of the masticatory muscles, leading to pain while chewing. Diagnosis of giant cell arteritis is done with temporal artery biopsy, looking for giant cells in the tissue. The next large vessel vasculitis is Takayasu arteritis. This is an extremely rare condition affecting mostly young women, generally younger than 40 years old, with increased incidence in Asian populations. Takayasu arteritis primarily affects the aorta and its major branches. And the inflammation can cause turbulent blood flow, which results in vascular bruit on auscultation of any involved artery, the aorta, carotid, renal, or femoral artery. Usually, there's also blood pressure asymmetry on the left compared to the right, reduced or absent peripheral pulses, and limb claudication. Diagnosis is based on CT angiography or magnetic resonance angiography of the involved artery, which shows skip lesions, where there's stenosis or aneurysms with normal tissue in between. Moving on to medium vessel vasculitis, first up is polyarteritis nodosa. Polyarteritis nodosa sometimes pops up in individuals with hepatitis B or C, likely due to molecular mimicry between hepatitis antigens and proteins within the blood vessel wall. Polyarteritis nodosa is a multisystem disease that can affect nearly any site in the body. Often there's joint and muscle pain. Also, the skin may be involved, and that can cause livedo reticularis, which is a lace-like purplish discoloration of the skin. The skin can also have palpable purpura, which are large reddish spots on the skin caused by bleeding underneath the skin. and the purpura can develop into large ulcers that might get infected. Ultimately, these ulcers can lead to gangrene. Nerve involvement may occur as well. Some individuals develop what's called a mononeuritis multiplex, which is a peripheral neuropathy that causes numbness, pain, and burning, as well as muscle weakness. Over time, individuals with polyarteritis nodosa can develop complications like intestinal ischemia and necrosis, kidney failure, and cardiovascular disease like hypertension or myocardial infarction, which can be fatal. A key diagnostic feature on angiography is the presence of clusters of small aneurysms that look like a string of beads on a rosary, called the rosary sign. Finally, a biopsy from blood vessels, skin, muscle, or nerve can show a pattern of inflammation consistent with polyarteritis nodosa. The next medium vessel disease is Kawasaki disease, and it typically affects young children. Children can develop bilateral bulbar conjunctival injection, a polymorphous rash due to sensitivity to sunlight, cervical lymphadenopathy, oral mucous membrane changes including injected or fissured lips, injected pharynx or strawberry tongue, and peripheral extremity changes including erythema of palms or soles, edema of hands or feet, and periungual desquamation. Diagnosis of Kawasaki is based on the presence of at least 4 of these features. In addition, they have a fever for at least 5 days. You can remember that these children crash and burn. A severe complication of Kawasaki disease is coronary artery aneurysms, which can cause myocardial infarction. So, an echocardiogram is done at diagnosis to evaluate for coronary artery involvement. Finally, there's small vessel vasculitis, which is divided into 2 groups. The first group is the anti-neutrophil cytoplasmic antibody, or ANCA-associated vasculitides, which includes granulomatosis with polyangiitis, which is also called Wegener's disease, eosinophilic granulomatosis with polyangiitis, which is also called Churg-Strauss disease, and microscopic polyangiitis. The second group are the immune complex vasculitides, which include cryoglobulonemic vasculitis and IgA vasculitis, which is also called Hennech-Schönlein purpura. Granulomatosis with polyangiitis is characterized by granulomatous inflammation within the blood vessels that supply the eyes, ears, nose, larynx, lungs, and kidneys. Eye involvement occurs when a granuloma is growing behind the eyeball and pushes on it, causing a painful exophthalmos, and even diplopia and optic nerve ischemia. The small vessels of the eye may also be affected, causing scleritis or uveitis. Destruction of the internal ear may lead to otitis and, ultimately, deafness. A typical finding is the saddle nose deformity, caused by a huge granuloma that destroys the bony structure of the nose and opens up the paranasal sinuses, causing recurrent sinusitis. Laryngeal involvement causes a hoarse voice, but can ultimately progress to collapse, causing suffocation. Many individuals have lung involvement nodules that resemble tumors, so diagnosis typically requires a lung biopsy. Finally, renal involvement can cause glomerulonephritis, which can cause both hematuria and proteinuria, with or without a rise in serum creatinine, and can progress to kidney failure. Laboratory tests show an elevated CANCA antibody which targets the enzyme proteinase 3, but the definitive diagnosis requires a biopsy from the affected organ, generally skin, kidney, or lung. Eosinophilic granulomatosis with polyangiitis also causes granulomatous inflammation, but there's usually a predominance of eosinophils. Symptoms are quite similar to regular old granulomatosis with polyangiitis, but these individuals also develop chronic rhinosinusitis, asthma, and blood eosinophilia. Also, laboratory tests show a prevalence for another type of ANCA called PANCA, which is specified for the enzyme myeloperoxidase. The high levels of eosinophils can cause damage to cardiac muscle, so it's important to routinely obtain an electrocardiogram and do echocardiography. and if there's an abnormality, to follow up with a cardiac magnetic resonance study. The last ANCA-associated vasculitis is microscopic polyangiitis, which basically causes the same signs and symptoms as granulomatosis with polyangiitis, and even causes an elevated PANCA. The key difference is that these individuals don't have granulomatous inflammation, which can be identified with a biopsy. Finally, there are the immune complex vasculitides. First, there's cryoglobulonemic vasculitis, which is caused by precipitation of cryoglobulins, which are serum proteins that precipitate out in cold temperatures. These proteins form immune complex with complement proteins and deposit in the walls of small capillaries, venules, and arterioles. The result is palpable purpura, joint and muscle pain, sensory and motor neuropathies, and glomerulonephritis that can evolve into renal failure. This disorder is most often associated with hepatitis C virus infection, but also hepatitis B virus and HIV as well. So, all three of these viral infections should be screened for and treated. To make the diagnosis, laboratory tests often show low levels of circulating complement factors due to complement deposition in tissues. A biopsy of a skin lesion can confirm the diagnosis by showing the precipitated cryoglobulins. Cryoglobulonemic vasculitis can lead to strokes, myocardial infarction, intestinal ischemia, or severe kidney dysfunction. Sometimes a renal biopsy is also done to check for renal disease. In severe cases, individuals may need a plasma exchange procedure like plasmapheresis, which is where plasma proteins like cryoglobulins get removed from the plasma. Finally, there's IgA vasculitis, also known as Hennech-Schönlein purpura, or HSP, which is the most common vasculitis in childhood. HSP usually follows an upper respiratory tract infection and then causes a fever, palpable purpura, typically on buttocks, back, and lower limbs, arthritis affecting large joints, abdominal pain, and sometimes affects the kidneys. For diagnosis, there's typically an increased serum IgA level, and a biopsy will show IgA deposition into an affected organ or tissue. The good news is that HSP is relatively benign and usually self-limiting, but rarely it can affect adults, and there it's usually triggered by a medication and can be more severe. In adults, there's a much higher chance of glomerulonephritis and kidney failure. Now, the backbone of initial management of most vasculitides is medium to high doses of glucocorticoids. That specifically applies to giant cell arteritis, Takayasu arteritis, and polyarteritis nodosa. Once remission has been attained, the dose of glucocorticoids is usually steadily lowered to limit the toxicity, and they're eventually discontinued in most cases. If there is glucocorticoid-related toxicity, or if the disease is refractory to glucocorticoids, individuals can be given immunosuppressant medications like azathioprine, mycophenolate, methotrexate, tocilizumab, leflunomide, or cyclophosphamide. Also, individuals with severe disease may get a combination of glucocorticoids and immunosuppressant medications. For initial treatment of ANCA-associated vasculitis and cryoglobulonemic vasculitis, immunosuppressant medications are given along with the backbone of glucocorticoids. The use of glucocorticoids in patients with IgA vasculitis is controversial, so individuals with joint or abdominal pain often get NSAIDs like naproxen, and only if that fails to manage the pain are glucocorticoids given. For Kawasaki disease, the management is different. Individuals with Kawasaki disease should get a single dose of intravenous immune globulins, or IVIG, administered within the first 10 days of illness, before aneurysms typically develop. IVIG should be administered even beyond this 10-day window in individuals with evidence of persistent vasculitis or systemic inflammation, such as persistent fever and laboratory markers like an elevated ESR and CRP. In addition, individuals should get aspirin during the acute phase of illness to prevent blood clots from forming. Aspirin therapy is started at high doses while the fever lasts, and then is continued at a low dose until laboratory markers return to normal, which usually takes about 2 months, unless there's a coronary artery involvement, in which case aspirin therapy is continued. Finally, glucocorticoids can sometimes increase the risk of coronary artery aneurysm, so they're only given as an adjunct to initial treatment in cases that are refractory to other treatment options. Finally, most forms of vasculitis can relapse, and flares of vasculitis, defined as new or worsening symptoms, can occur many years after the initial presentation. That's why ongoing monitoring of organ function with labs and imaging is so important. Alright, as a quick recap. Large vessel vasculitis includes giant cell arteritis, also called temporal arteritis because it tends to affect the temporal artery, and Takayasu arteritis, which shows skip lesions where there's stenosis or aneurysms with normal tissue in between. Medium vessel vasculitis includes polyarteritis nodosa with clusters of small aneurysms that look like a string of beads on a rosary, called the rosary sign, and Kawasaki disease, which causes children to have symptoms summarized in the mnemonic crash and burn. Small vessel vasculitides have two groups. One group is the anti-neutrophil cytoplasmic antibody, or ANCA-associated vasculitides, which includes granulomatosis with polyangiitis, or Wegener's disease, and microscopic polyangiitis, both of which cause inflammation within the blood vessels that supply the eyes, ears, nose, larynx, lungs, and kidneys, as well as an elevated CANCA antibody. The group also includes eosinophilic granulomatosis with polyangiitis, or Churg-Strauss disease, which causes chronic rhinosinusitis, asthma, and blood eosinophilia, and causes an elevated PANCA. The other group of small vessel vasculitides is immune complex vasculitis, which includes cryoglobulonemic vasculitis, which causes precipitation of cryoglobulins, and IgA vasculitis, or Hennech-Schönlein purpura, which has an increased serum IgA level, as well as IgA deposition into affected organs and tissues. Vasculitis causes systemic symptoms like fever, fatigue, joint pain, and weight loss, as well as organ-specific symptoms, and there's typically an elevated ESR, CRP, and white blood cell count. The diagnosis typically involves imaging or a biopsy of an involved organ or tissue, and the backbone of initial management is glucocorticoids for giant cell arteritis, Takayasu arteritis, and polyarteritis nodosa. This is followed by maintenance, steadily lowering the doses of glucocorticoids to limit the toxicity until achieving drug-free remission. And since most forms of vasculitis may eventually relapse, ongoing monitoring is generally indicated for many years. For initial treatment of ANCA-associated vasculitis and cryoglobulonemic vasculitis, immunosuppressant medications are given along with the backbone of glucocorticoids. For IgA vasculitis, individuals with joint or abdominal pain often get NSAIDs, and only if that fails are glucocorticoids given. Finally, individuals with Kawasaki disease should get a single dose of IVIG as well as aspirin while the fever lasts.
At the clinic, two very different people with very different symptoms showed up. Novikova is a 60-year-old woman from the Czech Republic who's been having a headache by the right temple, progressive jaw pain during chewing, and shoulder and hip stiffness, particularly in the morning. Her ESR levels are elevated, and she's beginning to develop vision loss in the right eye. The other person is Hikaru, a cute 3-year-old Japanese boy brought by his mother. He has a red, swollen tongue, unilateral neck swelling, a desquamating rash, and a fever for the past 6 days. An ECG reveals elevation of the ST segment, and an echocardiogram shows evidence of a coronary artery aneurysm. At first glance, you'd think Novikova's and Hikaru's symptoms have nothing in common, but the fact is they both have different forms of vasculitis. The majority of vasculitides are caused by some form of immune-mediated damage. Some are type 3 hypersensitivities, caused by immune complexes that deposit in vessels and cause damage. They could also be triggered by autoantibodies, like anti-neutrophil cytoplasmic antibodies, or ANCAs. Lastly, they might be caused by cell-mediated immunity due to monocytes, macrophages, or lymphocytes. Whatever the cause, immune cells cause inflammation, which damages the endothelial wall, exposing the underlying collagen. This results in thrombosis, and can lead to ischemia of the organs supplied by the affected vessels. Also, inflammation weakens the structural integrity of the blood vessel wall, leading to aneurysms. In addition, inflammation can spread to the supplied organ itself, causing tissue damage. Since vasculitides are systemic inflammatory disorders, non-specific symptoms like fever, arthritis, myalgia, weight loss, and night sweats might be present. The symptoms specific to each disease depends on which blood vessels are affected, and we can classify vasculitides into large, medium, and small vessel vasculitis. For large vessel vasculitis, let's start big, with temporal or giant cell arteritis. Age is the greatest risk factor, and it typically affects people older than 50 years. It's also more common in females of Northern European descent. Giant cell arteritis affects the branches of the carotid artery like the temporal artery. For your exams, remember that the person with this disorder often complains of having a unilateral headache located in the temporal area. They might also have fatigue or pain during chewing, or jaw claudication, which is caused by ischemia of the masseter muscle. Interestingly, you can sometimes see a prominent and tender superficial temporal artery on examination, and individuals will complain of pain when brushing their hair. About half of the people with giant cell arteritis have polymyalgia rheumatica, a chronic inflammatory disease characterized by pain and stiffness in the muscles of hips and shoulders, and is associated with fever and weight loss. Laboratory testing can reveal an elevated erythrocyte sedimentation rate, or ESR, which is not specific. But if it's normal, then you should probably think of another diagnosis. The most high-yield complication you need to remember for the test is vision loss, which happens when there's blockage of the ophthalmic artery, the first branch of the internal carotid artery. Because of this, although the diagnosis is made with a temporal artery biopsy, giant cell arteritis is always treated first, with high-dose corticosteroids to prevent irreversible blindness. The biopsy of the affected artery typically shows granulomatous inflammation, featuring monocytes that have joined forces together to make large, multinucleated cells called giant cells, which is where we get the name. In addition, intimal thickening and fragmentation of the internal elastic lamina of the blood vessels are seen. However, because giant cell arteritis affects intermittent segments of the vessel, they can appear normal. Next, we have Takayasu arteritis. This large vessel vasculitis usually affects females less than 40 years, especially those of Asian descent, and this is high yield. Branches of the aortic arch, like the subclavian artery, are typically involved. Therefore, individuals characteristically have weak upper extremity pulses on one side, which give it the name pulseless disease. This can also present as a blood pressure discrepancy between the two arms, that's greater than 10 millimeters of mercury. On auscultation, a carotid bruit is often heard. Visual loss and even strokes are also possible complications. Histologically, Takayasu arteritis looks exactly like giant cell arteritis, and the treatment is the same with corticosteroids. Because of the similarities, the best way to differentiate giant cell arteritis from Takayasu is to look at the person's age. Okay, on to medium-sized vasculitis. Polyarteritis nodosa is a necrotizing vasculitis that typically affects middle-aged men, and can involve the renal, coronary, and mesenteric arteries. Renal artery stenosis can cause secondary hypertension, renal failure, or hematuria. Mesenteric vessel involvement can lead to abdominal pain and bloody stools, and coronary artery involvement can cause acute myocardial infarction. A variety of skin manifestations can also develop, including livedo reticularis, a purplish web-like skin rash, or palpable purpura. It can also cause ischemia to multiple peripheral nerves, which is called mononeuritis multiplex. Interestingly, for unknown reasons, polyarteritis nodosa spares the pulmonary arteries. For your tests, it's important to remember that 30% of individuals are positive for the hepatitis B surface antigen, and it's thought that the immune complexes that develop in response to hepatitis B are responsible for the vessel damage. A portion of individuals are ANCA positive in polyarteritis nodosa. Although not really that helpful diagnostically, just be aware of it so you won't confuse it with the ANCA positive small vessel vasculitides. Histologically, a high-yield thing to look for in polyarteritis nodosa shows transmural inflammation and fibrinoid necrosis of the arterial wall, which means it involves all layers. But it doesn't affect the whole length of the blood vessel. Rather, it's segmental. Because the entire vessel wall is involved, small microaneurysms develop along the length of the wall, looking like beads or nodes, which gives it its name. Treatment includes corticosteroids and cyclophosphamide. Alright, next up is Kawasaki disease. It usually happens in children less than 4 years old, and of Asian descent, especially in Japan. To remember the symptoms, think of a Kawasaki motorcycle that is unfortunately about to crash and burn. So for C, we have conjunctival redness, which is usually bilateral and non-exudative. R is for rash, which typically progresses from being a polymorphous maculopapular rash to desquamation, or peeling of the skin. A is for adenopathy, which refers to enlargement of the cervical lymph nodes, usually more than 1.5 centimeters. Next is S for strawberry tongue, due to glossitis, as well as other oral mucosa changes, like lip cracking. H is for hand and foot changes, including erythema, edema, and desquamation. Finally, the burn refers to a fever that lasts for more than 5 days. The major concern in Kawasaki disease is the development of coronary artery aneurysms, which can rupture or predispose to thrombosis, causing an acute myocardial infarction. Treatment includes intravenous immunoglobulin and aspirin. It's important to remember that although aspirin is usually avoided in young children to prevent Rye syndrome, Kawasaki disease is an exception to the rule, as the antithrombotic benefits of aspirin outweigh the risk of Rye syndrome. Bergère disease, or thromboangiitis obliterans, typically affects males less than 40 years of age, and is particularly common in Ashkenazi Jews and people from Israel, Japan, and India. Remember that the high-yield risk factor is heavy smoking, which is the greatest risk factor. It's thought that tobacco triggers an immune response in genetically susceptible individuals. Bergère disease commonly affects the tibial and radial arteries, so individuals experience intermittent claudication and pain in the forefoot, ischemic ulcers, or even loss of their digits. Another common presentation is Raynaud phenomenon, which is changes in the color of the fingers and toes when exposed to the cold. However, this is nonspecific, and can also be present in other diseases like scleroderma and lupus. Histologically, thrombosis in the lumen is often seen, but interestingly, although there's prominent inflammatory cell infiltrate, the blood vessel wall integrity remains intact. Uniquely, the inflammatory process extends into adjacent arteries, veins, and even nerves, and over time, fibrosis results and encases those three structures together. The main treatment is smoking cessation. Alright, let's move on to small vessel vasculitis. There are a lot of these, so we can classify them into ANCA-associated and immune complex-mediated vasculitis. ANCA-associated vasculitis can be caused by autoantibodies against neutrophil myeloperoxidase, and this is called p-ANCA. There's also autoantibodies against neutrophil proteinase 3, and this is called c-ANCA. You might hear the term pauci-immune vasculitis, because ANCA-associated vasculitides have a paucity, or lack of immune complexes. Okay, so ANCA-associated vasculitis include granulomatous with polyangiitis, or GPA, previously called Wegener's granulomatosis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis, or EPA, previously called Churg-Strauss. GPA classically affects the blood vessels supplying 3 organ systems: the upper respiratory tract, the lower respiratory tract, and the kidneys. Upper respiratory tract symptoms include saddle nose deformity, chronic sinusitis, otitis media, mastoiditis, or even perforation of the nasal septum. Lower respiratory tract symptoms include hemoptysis and shortness of breath, and on chest x-ray, cavitating lung nodules are characteristic. Renal symptoms include hematuria due to crescentic, rapidly progressive glomerulonephritis, which would show red blood cell casts on urinalysis. On your exam, don't confuse GPA with Goodpasture syndrome, which also presents with lower respiratory tract symptoms and glomerulonephritis. But there's no upper respiratory tract symptoms. Okay, there are a couple of important lab findings to remember. For GPA, C ANCA antibodies are present, and the histology would show non-caseating granulomas. Finally, the treatment is corticosteroids and cyclophosphamide. Microscopic polyangiitis presents similarly to GPA, with lower respiratory tract symptoms and crescentic glomerulonephritis. But upper respiratory tract symptoms are absent. Remember that a unique feature is the microscopic polyangiitis is precipitated by medications, especially antibiotics like penicillin. Also remember that, like GPA, P ANCA antibodies are present, and histology does not show granulomas. Treatment, however, is similar, with corticosteroids and cyclophosphamide. EPA commonly presents with adult-onset asthma, sinusitis, as well as skin nodules and purpura. Mononeuritis multiplex is another presentation, resulting in wrist or foot drop. Apart from asthma, another clue is transient migratory pulmonary infiltrates, which are opaque densities on chest x-rays that come and go. A complete blood count, or CBC, would show eosinophilia, and laboratory testing would reveal increased IgE levels and elevation of the P ANCA antibodies. Alright, on to immune complex-mediated small vessel vasculitis, which includes immunoglobulin A vasculitis, Behçet's disease, cryoglobulinemia, and cutaneous small vessel vasculitis. Immunoglobulin A vasculitis, also known as Henoch-Schönlein purpura, or HSP, is a small vessel vasculitis seen in children between 1 and 15 years of age, and it's the most common vasculitis in children overall. On your test, a child will often develop HSP following a mucosal infection, like a viral upper respiratory tract infection or a group A streptococcal pharyngeal infection. Pathogens induce the formation of IgA immune complexes that attack the small blood vessels of the skin, gastrointestinal tract, joints, and kidneys. This manifests clinically as palpable purpura on the buttocks and lower extremities, colicky abdominal pain and gastrointestinal bleeding, and migratory arthralgia. Also, a hematoma in the intestinal wall could cause intussusception. In the kidneys, deposition of IgA immune complexes can lead to nephritis, chronic kidney damage, and even renal failure, so these individuals must be monitored carefully. For your test, it's important to remember that immunoglobulin A vasculitis is associated with Buerger's disease, also known as IgA nephropathy, not to be confused with the previously mentioned Berger disease, which is thromboangiitis obliterans. Fortunately, individuals usually spontaneously recover within a couple months without treatment. Behçet's syndrome was discovered by Hulusi Behçet, a Turkish pathologist, and that should help you remember that this syndrome is common in the Turkish and Mediterranean population. It's associated with HLA-B51 and can be precipitated by HSV and parvovirus infections. Symptoms include recurrent aphthous and genital ulcers, uveitis, and erythema nodosum. One interesting diagnostic test is the Pathology test, which involves inserting a blunt needle into the skin and looking for papule, pustule, or ulceration within 24 to 48 hours. Cryoglobulinemia is a small vessel vasculitis caused by cryoglobulins, which are abnormal immunoglobulin proteins that stick together in cold temperatures. It's usually associated with hepatitis C. Symptoms are caused by cryoglobulins depositing in the small blood vessels in the skin, leading to palpable purpura, cyanosis of the nose, ears, and digits, and Raynaud phenomenon. This could also happen in the small arteries supplying the glomerulus, leading to glomerulonephritis, or in the small arteries supplying the peripheral nerves, leading to peripheral neuropathy. The last one is cutaneous small vessel vasculitis, or CSVV. This vasculitis is characterized by inflammation of small blood vessels in the skin, but not the internal organs. It usually happens 7 to 10 days after using certain medications, like penicillin, cephalosporins, phenytoin, allopurinol, and NSAIDs, or after infections, like Streptococcus pyogenes, hepatitis C virus, or HIV. Clinical manifestations typically include palpable purpura in the lower extremities. Cutaneous small vessel vasculitis is a diagnosis of exclusion, and it's confirmed by a skin biopsy. The characteristic histopathological findings include marked perivascular inflammation of small blood vessels that results in disruption and destruction of the vessel wall, fibrinoid necrosis, extravasation of red blood cells, and predominance of neutrophils and nuclear debris, also known as leukocytoclasis. Remember, this is the reason why cutaneous small vessel vasculitis is also called cutaneous leukocytoclastic vasculitis. Vasculitis affecting the small vessels of the skin, for example the arterioles, capillaries, and postcapillary venules, tends to cause lesions like purpura, petechiae, and possibly shallow ulcers. Livedo reticularis, nodules, and deep ulcers are usually caused by vasculitis of deeper, medium, or large vessels. Okay, so now you might have developed a little bit of hatred toward the immune system for causing all these vasculitides. But hold it, there are infectious vasculitides to be aware of. For example, Rocky Mountain spotted fever caused by Rickettsia rickettsii can produce a small vessel vasculitis, and is transmitted by the dog or wood ticks, Dermacentor andersoni and variabilis, respectively. A clue is that this manifests as a petechial rash that starts in the palms and soles, which then spreads to the trunk. In addition to causing meningitis, Neisseria meningitidis can spread into the circulation, causing disseminated meningococcemia, a form of small vessel vasculitis. This manifests as petechiae, purpura, and sometimes hemorrhagic infarction of the adrenal glands, also known as Waterhouse-Friderichsen syndrome. You may have not thought of it this way, but syphilis, caused by the spirochete Treponema pallidum, is actually a form of vasculitis. The bacteria infiltrates the small vessels supplying the genitals, resulting in infarction which appears as a skin chancre. The organism can also infiltrate the vasa vasorum of the aorta, which are the tiny blood vessels that supply the aortic wall. This results in ischemia to the tunica media, weakening the aortic wall, which presents as aortic aneurysm or aortic regurgitation. Alright, as a quick recap, vasculitis is often caused by immune-mediated damage to the blood vessels, which results in ischemia, hemorrhage, and inflammation of the supplied organ. Vasculitis is classified into large, medium, and small vessel vasculitis, but some can be caused by infections. Large vessel vasculitis includes giant cell arteritis and Takayasu arteritis. Medium vessel vasculitis includes polyarteritis nodosa, Kawasaki disease, and Berger disease. Small vessel vasculitis is further subclassified into ANCA-associated vasculitis, like GPA, EPA, and microscopic polyangiitis, and immune complex-mediated vasculitis, like HSP, Behçet's disease, and cryoglobulinemia. Alright, let's not forget about Novikova and Hikaru. Novikova, this 60-year-old lady, had temporal arteritis. She had the classic symptoms of one-sided temporal headache, jaw claudication, vision problems, and her shoulder stiffness was due to polymyalgia rheumatica. She was immediately started on corticosteroids, and now her vision is improving. Hikaru, the young boy of Asian descent, was diagnosed with Kawasaki disease. The key symptoms were fever lasting over 5 days, neck adenopathy, strawberry tongue, desquamating rash, and cardiac complications. He's feeling much better now after being treated with aspirin and IVIG.
With vasculitis, you have inflammation of the blood vessels. And even though this can happen in arteries or veins, we're going to focus on vasculitis in the arteries because it's way more common. Vasculitides, plural for vasculitis, are characterized by the size of the blood vessels they affect. So we have small vessel, medium vessel, and large vessel vasculitis. Typically, vasculitis is due to an autoimmune disease, where the immune system confuses a part of the normal body as a foreign invader. And there are a couple ways this might happen. Sometimes the body confuses the innermost layer of the blood vessel, which is the endothelial layer, with a foreign pathogen and directly attacks it. To be a little bit more specific, the white blood cells of the immune system mix up the normal antigens on the endothelial cells with the antigens of foreign invaders, like bacteria, simply because they look similar, and this is called molecular mimicry. This autoimmune confusion is thought to be the cause of several types of medium vessel and large vessel vasculitides. Other times the immune system attacks healthy cells that are near the vascular endothelium, and the endothelial cells are only indirectly damaged. This is the situation in many small vessel vasculitides, where the immune system attacks white blood cell enzymes or other non-endothelial cell targets. Once the endothelium is damaged, either directly or indirectly, almost all vasculitis diseases progress in a similar way. The damaged endothelium exposes the underlying collagen and tissue factor, and these exposed materials increase the chance of blood coagulation. The blood vessel walls themselves get weaker as they're more damaged, making aneurysms more likely. And as the vessel wall heals, it becomes harder and stiffer because fibrin is deposited into the vessel walls as part of the healing process. And actually, that's vasculitis in a nutshell. The different types of vasculitis, for the most part, only vary depending on how they're triggered and where in the body they cause problems. People with vasculitis have generalized symptoms caused by the inflammatory response of the immune system. Symptoms like fever, weight loss, fatigue, and so on. More specific symptoms occur usually based off where in the body the vasculitis is occurring, and which organ is supplied by that blood vessel. When vasculitis happens in those blood vessels, you get reduced blood flow to those organs, called organ ischemia, which can happen in two ways. First, blood cells clump onto the exposed tissue factor and collagen on the inside of the blood vessels, forming blood clots that can restrict blood flow. The second way is caused by the healing process of the blood vessel. As fibrin is deposited in the vessel wall, the walls become thicker and bulge into the vessel, reducing the diameter of the vessel lumen and restricting blood flow. Alright, now that we have the general idea of vasculitis covered, let's take a look at some of the more specific conditions, starting with large vessel vasculitides. Giant cell arteritis is a vasculitis that affects branches of the carotid arteries. Vasculitis in the temporal branch of the carotid artery is the most common location and causes headaches. Vasculitis in the ophthalmic artery can cause visual disturbances, and vasculitis in any of the arteries that supply the jaw muscles can cause pain when someone chews food, called claudication. Giant cell arteritis affects older individuals, typically more than 50 years old, and women more than men, so a grandmother would be a high-risk group. Classically, this type of vasculitis causes lots of inflammation, and it results in a really high erythrocyte sedimentation rate, or ESR for short, sometimes over 100. In giant cell arteritis, a biopsy of the affected artery will show giant cells embedded in the internal elastic lamina, which is a thin layer of elastic tissue that separates the tunica intima and tunica media. To be clear, these giant cells are actually not individual cells at all, but rather they're granulomas, a group of monocytes that are packed tightly together and look like one giant cell. Now, giant cell arteritis is segmental, meaning that if you look at the entirety of an affected artery, you'll see only sections of the artery that are actually affected. This means that when biopsies are done, you have to take a long section of the artery and examine it under a microscope. It also means that if you don't see any affected tissue, you can't for sure rule out the disease because it's possible you took an unaffected section of the blood vessel. You can treat people with giant cell arteritis by giving them corticosteroids, which weakens the immune response. People whose ophthalmic artery is affected and don't receive treatment are at a high risk of blindness, again because poor blood flow to the eyes causes ischemia and irreversible blindness. Alright, so another type of large cell vasculitis is called Takayasu arteritis, and is very similar to giant cell arteritis except for two key differences. One is that it usually affects Asian women that are under 40 years old, where giant cell arteritis usually affects people over the age of 50. And two, it affects the arteries that branch off from the aortic arch, particularly around the branch points. If the inflammation happens around the aortic branches that serve the upper extremities, it can cause weak or non-existent pulse. If the inflammation happens around the aortic branch that serves the head, then it can cause visual and neurological symptoms. Histopathologically, it's pretty similar to giant cell arteritis because in Takayasu arteritis, you still see giant cells and granulomatous inflammation in the internal elastic lamina of the blood vessel. In addition, the erythrocyte sedimentation rate will be elevated, and Takayasu arteritis is treated with corticosteroids. Alright, so now let's move on to the medium-sized vasculitis diseases. These vasculitis diseases typically affect a wide range of muscular arteries that supply organs, which gives the conditions a wide range of possible symptoms. The most common type of all vasculitides is Kawasaki disease, and we've got a separate video on Kawasaki disease, but for now it's important to note that it affects the coronary arteries, the muscular arteries serving the heart. Next, there's polyarteritis nodosa, which is thought to occur when the immune cells directly attack the endothelium, confusing it with hepatitis B virus. Now, polyarteritis nodosa causes transmural inflammation, which means the entire wall, the tunica intima, the media, and the adventitia are all affected. The inflammation causes the vascular wall to die through all 3 layers of the artery, and fibrosis occurs as the vascular wall heals. And this process is called fibrinoid necrosis. The fibrosed vessel wall is left weak and prone to aneurysms, so some areas start to bulge out through the weakened walls. So if you take a step back and look at the artery, you see these fibrotic aneurysms, which are hard bulges down the length of the artery, and they look like a string of beads on angiogram. This pattern is pretty unique among the various vasculitides. Organ ischemia and the distribution of affected arteries is the main complication. If the renal arteries are affected, then a person will have hypertension, because remember that the kidneys regulate blood volume. If the mesenteric artery is affected, a person can have mesenteric ischemia and severe abdominal pain and gastrointestinal bleeding. If the arteries supplying the brain are affected, it can cause neurological symptoms. And if arteries supplying the skin are affected, then it can lead to skin lesions. Treatment is aimed at reducing the vessel inflammation and generally includes corticosteroids as well. Another medium vessel vasculitis is Berger's disease, named for a New York City pathologist, not a fancy hamburger. Its other name is thromboangiitis obliterans, which literally translates to clot vessel inflammation blockage. And as the name suggests, this vasculitis is notorious for causing blood clots in tiny arteries in the fingers and toes, which leads to ulcers and eventually dead tissue in these digits and eventually auto-amputation. Not fun. Berger's disease typically affects men between the ages of 20 and 40 years old, and the biggest risk factor for vasculitis is the use of tobacco products. In fact, it's thought that tobacco might be the trigger for the autoimmune response against the blood vessels. Stopping the use of tobacco actually slows down, but doesn't necessarily stop, the disease and need for amputations in most patients. Okay, on to small vessel vasculitis. Small vessel vasculitis affects small vessels like arterioles, capillaries, and venules. In the diseases, B cells mistakenly target their antibodies to granules made by the person's own neutrophils. In a sense, one immune cell attacking the other. The antibodies are called anti-neutrophilic cytoplasmic antibodies, or ANCAs for short, and they're mainly of the IgG type. The disease granulomatosis with polyangiitis, or GPA, which used to be called Wegener's granulomatosis, is one of these small vessel vasculitides. The B cells release an autoantibody called cytoplasmic anti-neutrophilic cytoplasmic antibody, or c-ANCA. Yes, the name is hilariously redundant, with cytoplasmic included twice to drive home the point. C-ANCAs target and bind to a specific neutrophil granule called proteinase 3, which is embedded in the membrane of some neutrophils. Once C-ANCA binds to the neutrophil, it causes the neutrophil to release oxygen-free radicals, which can then indirectly damage the nearby endothelial cells, causing vasculitis. On a biopsy, you can see evidence of inflammation and granulomas in the blood vessel wall. GPA affects the nasopharynx, lungs, and kidneys and usually occurs in middle-aged males. People with the disease can have chronic pain caused by sinusitis or bloody mucus from ulcers within the nose. Over time, the nose itself might even cave in or curl, a condition called a saddle nose deformity. Blood vessel inflammation in the lungs and air passages can also make breathing more difficult, causing air passages to constrict, and ulcers can form, causing bloody coughing. In the kidneys, the inflammation restricts blood flow to the glomeruli, causing them to die and leading to decreased urine production and an increase in blood pressure, since the kidneys are no longer as efficient at regulating blood volume. GPA is typically treated with corticosteroids and cyclophosphamide, but relapses in the disease are common, and that makes sense. The presence of C-ANCA is the main cause of the disease, and if it keeps attacking the granules from within neutrophils, then there's a good chance the disease will come back. Another small vessel vasculitis that's very similar to granulomatosis with polyangiitis is microscopic polyangiitis. It's so similar, in fact, that you need to rely on some clues to help you distinguish them. Microscopic polyangiitis doesn't affect the blood vessels of the nose and sinuses, only the kidneys and the lungs. You also won't see the granulomas in the blood vessel walls like you would in granulomatosis with polyangiitis. The third difference is that you won't find C-ANCAs. Instead, you'll find P-ANCAs. The P stands for perinuclear, which is just a different type of anti-neutrophilic cytoplasmic antibody reacting with the neutrophil granule myeloperoxidase instead of proteinase 3. You treat microscopic polyangiitis the same way you treat granulomatosis with polyangiitis, corticosteroids and cyclophosphamide, and it's also common for it to relapse. Churg-Strauss syndrome is very similar to both granulomatosis with polyangiitis and microscopic polyangiitis. It's also caused by p-ANCA antibodies, and it causes similar symptoms like sinusitis, lung damage, and kidney damage. But it also causes gastrointestinal, skin, nerve, and heart damage, like some medium vessel vasculitis diseases. A lot of the time, Churg-Strauss syndrome is mistaken as allergies and asthma because they all have similar symptoms. That, and like allergies and asthma, Churg-Strauss causes a lot of eosinophils to float around in the blood. Actually, people who have asthma and peripheral eosinophilia are more likely to develop Churg-Strauss syndrome because they both have elevated eosinophils. Also, just like granulomatosis with polyangiitis, granulomas can form. Next up is Henoch-Schönlein purpura. Now, unlike other small vessel vasculitis diseases we've talked about, Henoch-Schönlein purpura, shortened to HSP, doesn't involve ANCAs. Instead, we find elevated levels of the IgA antibodies floating around in the blood. Now, IgA is an awesome antibody that's found in our mucosal cells, which are the cells that are in some way exposed to the outside world. For example, the cells in our lungs or our gastrointestinal tract. In HSP, the person starts making IgA that directly targets their own endothelial cells, likely because of molecular mimicry. And this goes against the general trend of small vessel vasculitides being the result of indirect damage. Symptoms are going to depend on where the IgA decided to attack the small blood vessels. One more common place is the skin blood vessels around the buttocks and legs, which leads to a significant skin discoloration that looks like blood is pooling under the skin surface, called purpura. One indication that the disease is HSP is that the skin discoloration is palpable, as in you can feel it raised above the normal skin. Remember, the fibrosis of the blood vessel walls hardens and makes it palpable. So just like in polyarteritis nodosa, if the IgA attacks the blood vessels in the gastrointestinal tract, it can cause abdominal pain, and if it attacks the blood vessels in the kidneys, it can lead to hematuria, blood in the urine, and eventually affect the kidney's function, which is called IgA nephropathy. Just like the other small vessel vasculitis diseases, HSP resolves on its own, but it can reoccur. Generally, it's only treated with steroids if the symptoms are severe.
Alright, as a quick recap. Vasculitis means inflammation of the blood vessels, typically caused by immune-mediated damage to the endothelial cells. Based on the size of blood vessels they affect, there are small vessel, medium vessel, and large vessel types of vasculitis. Symptoms vary based on the organ supplied by the affected blood vessel, but more general symptoms include fever, weight loss, and fatigue. And treatment for vasculitis includes corticosteroids. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media. Kawasaki disease is a vasculitic disease in which medium-sized arteries throughout the body become inflamed. It typically affects young children from 1 to 5 years old, but can sometimes affect teenagers and even adults. It's usually a self-limited condition, with fever and manifestations of acute inflammation for at least 5 days, lasting for an average of 12 days without therapy. And it's not very responsive to treatment with paracetamol or ibuprofen. The most frequent and characteristic signs and symptoms, included in the diagnostic criteria, can be remembered with a mnemonic crash. First off, they might typically present with bilateral bulbar conjunctival injection, which typically starts within days of the onset of fever, and leads to photophobia, or discomfort or pain to the eyes due to light exposure. Then there's polymorphous rash, that usually starts during the first few days of illness due to sensitivity to light. A stands for lymphadenopathy, which tends to primarily involve the anterior cervical nodes overlying the sternocleidomastoid muscles. Next up, there are oral mucous membrane changes, including injected or fissured lips, injected pharynx, or strawberry tongue. And finally, there are peripheral extremity changes, including erythema of palms or soles, edema of hands or feet, and periungual desquamation. To make a diagnosis of Kawasaki, individuals must meet at least 4 of these features. Other common features include irritability, rhinorrhea, cough, vomiting, diarrhea, abdominal pain, and joint pain. A severe complication of Kawasaki disease is cardiovascular disease, which most commonly presents as coronary artery aneurysms and can lead to arrhythmias, myocardial infarction, and ultimately heart failure. Typically, an ECG and echocardiogram are done in individuals with Kawasaki to look for cardiovascular involvement. On rare occasion, if echocardiography isn't available to image the coronary arteries, computed tomographic angiography or magnetic resonance angiography can be used instead. Individuals with coronary aneurysms have to undergo stress testing to evaluate for myocardial perfusion and inducible ischemia, which measures the heart's ability to respond to increased stress or demand in a controlled setting. The stress is induced by exercise, which is preferred, or with the medication dobutamine. Some children are suspected of having Kawasaki disease when they have an unexplained fever for at least 5 days, even if they have only 2 or 3 of the diagnostic criteria. That's because these children might have incomplete or atypical Kawasaki disease. This is also true of infants less than 6 months of age with unexplained fever for at least 7 days, even without any of the clinical findings of Kawasaki disease. That's important because infants are at a greater risk for cardiovascular disease. The criteria to diagnose incomplete Kawasaki include a CRP above 3 mg per deciliter and ESR above 40 mm per hour, along with 3 or more abnormal supplemental laboratory findings, or abnormal echocardiography. The supplementary blood tests include a white blood cell count above 15,000 cells per microliter, platelet cell count above 450,000 cells per microliter, normocytic normochromic anemia for age, an elevated serum alanine aminotransferase above 50 units per liter, or a serum albumin level below 3 grams per deciliter. Another supplementary finding is pyuria, having more than 10 white blood cells per high-powered field on urine microscopy. For management, individuals with Kawasaki disease should get a single dose of IVIG, 2 grams per kilogram over 8 to 12 hours, administered within the first 10 days of illness, before aneurysms typically develop. IVIG should be administered even beyond this 10-day window in individuals with evidence of persistent vasculitis or systemic inflammation, such as persistent fever and laboratory markers like an elevated ESR and CRP. In addition, individuals should get aspirin during the acute phase of illness to prevent blood clots from forming. Giving a total daily aspirin dose of 30 to 50 milligrams per kilogram per day in 4 doses while the fever lasts, and then is continued 48 hours after the resolution of fever at a low dose of 3 to 5 milligrams per kilogram per day, until laboratory markers return to normal, which usually takes about 2 months. Unless there's coronary artery involvement, in which case low-dose aspirin therapy is continued. Except for Kawasaki disease and a few other indications, aspirin is otherwise normally not recommended for children due to its association with Reye syndrome, which is a rapidly progressive encephalopathy. Because children with Kawasaki disease will be on aspirin for a long time, vaccination against varicella and influenza is required, because these infections are the ones that are most likely to cause Reye syndrome. Importantly, varicella vaccine should be postponed until at least 11 months after the IVIG has been given, because it can interfere with vaccine immunogenicity. Now, if a child has a persistent fever even 24 hours after completion of initial therapy, or becomes afebrile and then develops a fever without an alternative source within the 2-week window after initial therapy, then that's considered refractory Kawasaki disease. Refractory Kawasaki disease can put individuals at higher risk for cardiovascular disease. Risk factors for failing to respond to a single dose of IVIG include male gender, age less than 6 months, elevated CRP, and low sodium or low platelet levels. In refractory Kawasaki disease, the first step is to give another dose of IVIG, 2 grams per kilogram over 8 to 12 hours. If that doesn't work and the fevers persist, then glucocorticoids can be given. Usually it's pulse dose methylprednisolone, giving 30 milligrams per kilogram per day. given until there's a full response, or until 3 doses have been given. Alternatively, you can give a 15 to 30-day course of twice or thrice daily oral prednisone, for a total daily dose of 1 to 2 milligrams per kilogram. Since glucocorticoids can sometimes increase the risk of coronary artery aneurysm, they're only given as an adjunct to initial treatment in cases that are refractory to IVIG. Alright, as a quick recap. Kawasaki disease causes a fever for at least 5 days. In addition, they can develop bilateral bulbar conjunctival injection, a polymorphous rash due to sensitivity to sunlight, cervical lymphadenopathy, oral mucous membrane changes, including injected or fissured lips, injected pharynx or strawberry tongue, and peripheral extremity changes, including erythema of palms or soles, edema of hands or feet, and periungual desquamation. Diagnosis of Kawasaki is based on the presence of at least 4 of those features. A severe complication of Kawasaki disease is cardiovascular disease, so all affected individuals must get an ECG and echocardiography. Children suspected of having Kawasaki disease who do not fulfill diagnostic criteria might be diagnosed with atypical or incomplete Kawasaki if they present with elevated ESR and CRP plus 3 or more abnormal supplemental laboratory findings, or abnormal echocardiography. For treatment, individuals with Kawasaki disease should get a single dose of IVIG, which is 2 grams per kilogram over 8 to 12 hours, as well as aspirin, giving a total daily aspirin dose of 30 to 50 milligrams per kilogram per day in 4 divided doses, for a maximum dose of 4 grams per day, while the fever lasts. Those with refractory Kawasaki might get a second dose of IVIG, and if that doesn't work, then glucocorticoids can be given as an adjunct to initial treatment.
Kawasaki disease isn't at all related to the motorcycle and engine company, other than the fact that they were both founded or first described in Japan. Kawasaki disease is a vasculitis, or an inflammation of the blood vessels, that mostly affects the coronary arteries, but can also affect any large or medium-sized arteries as well. With Kawasaki disease, the immune system attacks the arteries. Ultimately, it's not quite known why this happens, though. Some theories suggest it has some infectious cause, though autoimmune reactions and genetic predisposition probably play a part as well. Whatever the case, when the endothelial cells in the blood vessels are attacked, they become damaged, which exposes the underlying collagen and tissue factor found in the middle layer of the blood vessel, or the tunica media. And this leads to a few serious problems. First, these exposed materials increase the chance of blood coagulation. When blood coagulates, it forms clots that can block blood flow in the coronary arteries, leading to ischemia of the heart muscle. Secondly, damaged endothelial cells in the coronary arteries means weak artery walls, which can lead to coronary aneurysms. These aneurysms form because fibrin is deposited in the blood vessel wall as part of the healing process. Fibrin makes the vessels stiffer, less elastic, and unable to gently stretch with high arterial pressures. Instead, the arteries develop permanent bulges that we call aneurysms. Aneurysms 8 millimeters or larger are at the most risk of rupturing, which reduces blood flow to the heart, causing ischemia and potentially myocardial infarction, or heart attack. And third, in some cases the fibrosis doesn't lead to aneurysms, but instead the fibrosis of the blood vessel walls makes the vessel walls thicker, which reduces the lumen diameter and restricts blood flow. If blood flow is restricted or reduced, the heart again might become ischemic, leading to heart attack. Kawasaki disease is most commonly seen in infants and children under 5 years old, and is more likely to affect boys. This disease is self-limited, which means that the inflammation will resolve after 6 to 8 weeks, but if we left it untreated, there's a 20 to 25% risk of the heart complications we went over. Alright, so let's look at the symptoms of Kawasaki disease. We rarely see any cardiac symptoms in the first few weeks, unless the patient has an underlying heart condition already, and so cardiac symptoms typically evolve later. Now, the classic symptoms of Kawasaki disease are as follows. Conjunctivitis with limbus sparing, which is red eyes with a margin right around the iris that's still white. A rash that might extend across other parts of the body and starts polymorphous but later desquamates or flakes off. Adenopathy, or enlarged lymph nodes, especially the cervical lymph nodes. A strawberry tongue, which is when the top layer of the cells on their tongue slough off, giving the tongue a very red, strawberry-like appearance. Also, their mouth and throat may look really red too, and their lips might become dry and cracked. Their hands and feet might get swollen and develop a rash as well. And finally, they might have 5 or more days of high fever that typically doesn't resolve with antipyretics. Just remember that the patients crash and burn. Okay, there isn't a specific test to diagnose Kawasaki disease, but there are a number of lab tests that can act as clues. At the beginning of the disease, many patients are anemic and have an increased number of white blood cells with a shift to the left, which means that there are more immature white blood cells than normal. After a few weeks, the patient's platelet count generally rises as well. They'll also have an increased C-reactive protein and erythrocyte sedimentation rate, as well as increased liver enzymes, which are all good clues to tell us that some sort of inflammation is happening. After a few weeks, the patient's platelet count generally rises as well. Microscopic urinalysis will show mononuclear white blood cells in the urine without evidence of bacteria. Whoa, that was a lot of tests. But one last test that we'd want to do is an echocardiogram to take a look at the coronary artery and the heart muscle to see if any of those complications we talked about earlier having to do with the heart are happening. Kawasaki disease is diagnosed based on a combination of patient symptoms and lab tests. In order for Kawasaki disease to be diagnosed, they need 4 of the 5 crash symptoms we talked about earlier, as well as a fever that lasts for 5 or more days. Sometimes patients don't meet these strict criteria though. Vasculitis in the coronary arteries is a definitive sign that the disease is Kawasaki disease, but you probably wouldn't want to wait to find that out, right? People who don't perfectly meet all the diagnostic criteria for Kawasaki disease are sometimes classified as incomplete Kawasaki disease. There are guidelines in place to help healthcare providers figure out if they should treat these atypical cases as Kawasaki disease or not. But just know that it's possible to have cases that don't meet all the clinical diagnostic requirements. Now, treating Kawasaki disease is also helpful diagnostically, because if the therapy works, then it also reassures you that the right diagnosis was made. The main treatment is to give IVIG, which is an antibody taken from other individuals. It's thought that this actually helps to calm down the immune system and reduce inflammation. We also give ASA, otherwise known as acetylsalicylic acid, or aspirin. Aspirin inhibits platelet cyclooxygenase, which prevents platelets from aggregating together. Now, wait a second. There should be alarm bells going off, right? We're not supposed to give aspirin to kids because they could develop Reye's syndrome, which is encephalopathy and serious liver injury. Bad news. Kawasaki's disease is also bad news, though, so we actually take the risk and monitor the child very carefully.
Alright, as a quick recap. Kawasaki disease is a vasculitis mostly affecting children where the immune system attacks arteries, which damages endothelial cells of blood vessels. The mnemonic crash and burn summarizes its classic symptoms. The disease will resolve on its own, but left untreated it can lead to complications like blood clots, coronary aneurysms, and ischemia. For this reason, it's treated with IVIG and aspirin.
Varicose veins are veins that have become enlarged and twisted, and this most commonly happens in the veins of the leg. How do these form? Well, the arterial circulation, going away from the heart, is a high-pressure system, meaning the movement of blood is dependent on high pressures that essentially push it through the arteries, on the order of 120 millimeters of mercury. The venous circulation, going back to the heart, on the other hand, is a low-pressure system with a central venous pressure around 5 millimeters of mercury. This means that the movement of blood has to rely heavily on what's called the skeletal muscle pump, which is just a way of saying that it relies on the contraction of surrounding skeletal muscles, which compresses the vein and propels blood through the vessels. But let's think about the veins in the legs when you're standing. Now, to get to the heart, the blood has to go up, right? Which is working against gravity. So if your calf muscles contract and squeeze the blood inside, some blood gets propelled downward, while some gets propelled upward. But then gravity pushes that upward moving blood back down. And it doesn't seem like much gets accomplished. And it wouldn't, but that's not the whole story. Most veins also have one-way valves. These valves only let blood move in one direction, toward the heart. So now as the skeletal muscles contract, it squeezes the veins, and this lower valve stays closed to prevent blood from going downward, while the upper valve lets blood through. But even though gravity wants to push it back down, that blood isn't allowed to fall back down through the upper valve, right? For some people, the downward gravitational pull on blood causes the walls of the leg veins to stretch apart over time, which tends to also pull apart those valves. If these valves fail to close properly, they can allow blood to leak backward and pool in the veins, which can lead to more valves stretching out and failing. The veins have now become varicose veins, and from this additional blood, they start becoming tortuous, or twisted. This most commonly affects the superficial veins on the surface of the legs, since they see high pressures when standing, rather than the deep veins buried inside the muscles. Oftentimes, though, collateral veins are used instead, which is where other veins can take the blood as an alternate pathway, so it doesn't stagnate in the varicose vein. And these tend to actually be the deep veins in the legs. Other than the legs, in men it can also occur in the scrotum, usually on the left side, where it's called a varicocele. This develops because the left testicular vein brings blood back to the left renal vein at about a 90-degree angle, while the right testicular vein drains directly into the inferior vena cava. Getting blood back up through a tight 90-degree turn isn't that easy, and so blood backs up, and the backup of venous blood around the testicle causes the testicular vein to enlarge and get tortuous, where it starts to loop back and forth on itself, and it makes the scrotum look like a bag of worms, which gets larger when standing and smaller when lying flat. Also, all this warm, stagnant venous blood can cause the testicular temperature to rise, and over time this can result in testicular atrophy or wasting away, as well as poor quality sperm and infertility. Generally, embolization or a surgery can be used to get rid of this problematic vein, and the testicles then drain through smaller collateral veins. Alright, back to the legs. So now the deep veins are acting as collateral veins and taking blood back, right? Over time, those deep veins, though, can be affected as well, resulting in even more pooling of blood in the gravity-dependent parts of the body. If this happens for prolonged periods of time, it progresses to what we call chronic venous insufficiency, or CVI. With CVI, the stagnant blood in the lower extremities starts to cause an inflammatory reaction in the vessels and the surrounding tissue, which leads to fibrosis and potentially even ulcers, called venous stasis ulcers. Other symptoms of CVI include hyperpigmentation, or darkening of the skin, as well as pruritus, or itchiness, and pain. There can also be a lot of edema, as some of this fluid starts to leak out of the veins and into the surrounding tissues of the ankles and lower legs. Although there are probably a lot of factors that play into the development of varicose veins in the legs and resulting CVI, women tend to be more at risk than men. People that stand or cross their knees for long periods of time are also at risk, as well as those who are obese. Treatment options for varicose veins and CVI might involve manual compression to help increase blood flow, as well as compressive bandages and stockings, and frequent periods of elevating the legs above the heart. Besides these more conservative options, there are various surgical treatments that can help cure the disease, like for example a vein transplant, a vein repair, or a vein removal. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media.
Deep vein thrombosis, or DVT, is a blood clot that develops in the deep veins, most commonly of the lower limbs. Less commonly, DVT can form in the deep veins of the arms or mesenteric veins of the bowel. The pathogenesis of DVT centers around the Virchow triad, which includes venous stasis, hypercoagulability, and endothelial injury. If untreated, the thrombus can lead to limb ischemia, hemodynamic instability, pulmonary embolism, and even death. Now, if your patient presents with signs and symptoms suggestive of DVT, first you should perform an ABCDE assessment to determine if your patient is unstable or stable. If the patient is unstable, stabilize the airway, breathing, and circulation. Next, obtain IV access and start continuous vital sign monitoring, including pulse oximetry, blood pressure, and heart rate. If needed, provide supplemental oxygen to maintain the oxygen saturation above 92%. All right. Now let's go back to the ABCDE assessment and discuss how to manage stable individuals. First, obtain a focused history and physical examination. History usually reveals pain, swelling, and warmth in the affected limb, as well as DVT risk factors, such as age above 65, recent surgery, prolonged immobilization, and active cancer, as well as smoking and obesity. Also keep in mind that estrogen increases the risk of venous thrombosis, so pregnancy and the use of oral contraceptives are also important risk factors. Finally, a family history of DVT can indicate a familial inheritance of genetic conditions predisposing to DVT, such as factor V Leiden mutation. On the other hand, the physical examination usually reveals edema, erythema, warmth, and tenderness of the affected area. In some individuals, you might even be able to palpate the thrombotic vein. Another important test is to see if you can elicit the Hohmann sign. To do this, lift the affected leg and slightly bend it in the knee. Next, abruptly and firmly perform dorsiflexion of the patient's foot. The Hohmann sign is positive if dorsiflexion of the foot results in deep calf pain. But here's the thing. Even though it's associated with DVT, the Hohmann sign is not sufficiently specific or sensitive to confirm the diagnosis because it's often positive in individuals without DVT. At this point, you can suspect DVT. So at this point, your next step is to order labs, including CBC, D-dimer, and coagulation profile, as well as renal and liver studies. Now, while you are waiting for lab results, use a validated metric, such as the Wells criteria, to predict the likelihood of DVT. The Wells criteria scores historical findings, physical findings, and alternative diagnoses. Historical findings are worth 1 point and include a history of prior DVT, active cancer, surgery or prolonged bed rest within 3 months, or any recent condition that has weakened or immobilized the suspect limb, like a splint. Physical features are also worth 1 point, and they include localized pitting edema of the affected leg, swelling of the entire lower limb, calf circumference asymmetry of 3 centimeters or greater in the affected leg, tenderness over a deep leg vein, or collateral vein distension in the affected leg. Finally, if you are considering alternative diagnoses, like cellulitis or a ruptured Baker cyst, then you'll subtract 2 points from the score. Now, let's take a look at the Wells score. If your patient scores 2 or more points, then there's a high likelihood of DVT, so you should order an ultrasound of the affected limb. On the other hand, if the score is below 2, then there's a low likelihood of DVT. However, to really rule out a DVT, you should assess D-dimer levels. If the D-dimer is less than 500 nanograms per milliliter, you can consider an alternative diagnosis. On the flip side, if the D-dimer is equal to or greater than 500 nanograms per milliliter, proceed with an ultrasound of the affected limb. Alright, now that you have determined the patient's probability of DVT, let's take a look at the ultrasound. Ultrasound of the affected limb is used to assess the condition of deep and superficial veins. If the vein collapses under probe pressure, the finding is negative, so you should consider an alternative diagnosis. On the flip side, when there's a thrombus within the vein does not collapse. This means that the finding is positive, which confirms the diagnosis of DVT. Now, once you diagnose a DVT, the next step is to assess whether or not it's complicated. Complicated DVT includes the presence of additional conditions, such as pulmonary embolism and limb ischemia, but also pregnancy and malignancy. If your patient presents with any of these conditions, you may need to admit them to the hospital for further evaluation, closer monitoring, and management, such as anticoagulation, systemic or local thrombolysis, and in some cases, mechanical thrombectomy. On the other hand, if none of these are present, the patient has an uncomplicated DVT. These patients usually don't require hospitalization. Since these patients don't require hospitalization, the next step is to assess contraindications to anticoagulation. If contraindications are present in your patient, such as a history of intracranial hemorrhage, recent GI bleeding, or lab abnormalities like thrombocytopenia, then giving them anticoagulants might be too risky. In this case, you should consult the interventional radiology team for inferior vena cava or IVC filter placement. This filter acts as a small cage that captures thrombus fragments and reduces the risk of pulmonary embolism. Keep in mind that the IVC filter doesn't actually treat the DVT, so as soon as the contraindication to anticoagulation resolves, it's best to remove the filter and start anticoagulation. Now, let's take a look at patients with no contraindications to anticoagulation. If contraindications are absent, treat your patient with anticoagulant medications, which stabilize the thrombus and reduce the risk of fragmentation. These include initial anticoagulation for 5 to 10 days with subcutaneous injection of low molecular weight heparins, or LMWH, like enoxaparin, or IV unfractionated heparin, followed by anticoagulation for 3 to 12 months with oral warfarin. As an alternative, patients can get monotherapy with direct oral anticoagulants, or DOACs for short, like rivaroxaban, without the need for initial anticoagulation with heparin. Now, here's a high-yield fact to keep in mind. DVT is considered provoked if it's associated with risk factors, such as recent surgery or the use of oral contraceptives. In these individuals, you should address their risk factor as soon as possible. For example, you might need to discontinue oral contraceptives. Once you address the risk factor, continue anticoagulants for an additional 3 months. On the other hand, DVT is considered unprovoked when you can't identify the underlying cause or when the cause is permanent. For example, the patient might have an inherited thrombotic disorder. In this case, you should go with a long-term, sometimes lifelong, anticoagulation therapy. Alright, as a quick recap, deep vein thrombosis, or DVT, is a condition that can result in life-threatening complications, such as pulmonary embolism, so you need to diagnose it quickly. If your patient is unstable, first you need to stabilize them before you continue further evaluation. On the other hand, if the patient is stable, use the Wells score to determine the probability of DVT. A score of 2 or higher indicates a high likelihood of DVT, so you should proceed with an ultrasound of the affected limb. On the flip side, a score below 2 refers to a low likelihood of DVT, so your next step is to assess D-dimer levels. D-dimer levels of 500 nanograms per milliliter and above require an ultrasound, while below 500 nanograms per milliliter indicates an alternative diagnosis. Next, negative ultrasound findings rule out DVT, while positive findings confirm the diagnosis. Once you make the diagnosis, determine whether the DVT is complicated or uncomplicated. Individuals with complicated DVT may require hospitalization, while patients with uncomplicated DVT usually don't, but should be assessed for contraindications to anticoagulation. If contraindications to anticoagulation are present, proceed with an IVC filter. However, if there are no contraindications, start the anticoagulant therapy with LMWH or unfractionated heparin, followed by warfarin or DOACs.
Deep vein refers to the veins that typically run between muscles as they travel back towards the heart, as opposed to the superficial veins that you can see on the surface. And thrombosis refers to a blood clot. So a deep vein thrombosis, or DVT, is a blood clot in one of those deep veins. Normally, blood makes it back to the heart from all the tissues and organs through a network of veins that merge over and over. Superficial veins drain blood into deep veins, which rely on the skeletal muscle pump to move blood forward. The way this works is that the surrounding skeletal muscles compress the vein and propel blood forward, and the veins prevent blood from moving backwards by using one-way valves. Ultimately, all the blood ends up in the superior or inferior vena cava and dumps into the right atrium. From there, the blood goes into the right ventricle and gets pumped into the pulmonary artery, and eventually to the lungs. A deep vein thrombosis most commonly develops in the lower legs, below the knee, although a blood clot can form in both superficial and deep veins, and also in other parts of the body as well. Normally, the process starts with damage to the endothelium, or inner lining of the blood vessel walls, after which there's an immediate vasoconstriction, or narrowing of the blood vessel, which limits the amount of blood flow. After that, some platelets adhere to the damaged vessel wall and become activated by collagen and tissue factor, which are proteins that are normally kept separated from the blood by an intact endothelium. These platelets then recruit additional platelets to form a platelet plug. This formation of the platelet plug is called primary hemostasis. After that, the coagulation cascade is activated. First off, in the blood, there's a set of clotting factors, most of which are proteins synthesized by the liver, and usually these are inactive and just floating around in the blood. The coagulation cascade starts when one of these proteins gets proteolytically cleaved. This active protein then proteolytically cleaves and activates the next clotting factor, and so on. The final step is activation of the protein fibrinogen to fibrin, which deposits and polymerizes to form a mesh around the platelets. So these steps leading up to the fibrin reinforcement of the platelet plug make up the process called secondary hemostasis, and result in a hard clot at the site of the injury. This cascade has a huge degree of amplification, and takes only a few minutes from injury to clot formation. So the activation of the cascade is carefully controlled by anticoagulation proteins that target and inactivate key clotting factors. For example, antithrombin inactivates factors 9A, 10A, 11A, 12A, 7A, and thrombin, while protein C inactivates factors 5A and 8A. As the clot grows in size, it limits the amount of blood able to pass by, and pressure in the vein increases. Usually, the clot might start naturally breaking down. For example, enzymes like plasmin break down fibrin into fragments called D-dimers. But sometimes that increased pressure in the vein can cause a part of that main clot to break free, becoming an embolism, which can travel downstream towards the heart. When that happens, a thromboembolism, which is a blood clot that's on the move, can move from the spot of clot formation and get into the right atrium, and then into the right ventricle and get pumped into the lungs where it can get lodged someplace, causing a pulmonary embolism. This is a life-threatening situation because it literally blocks blood from getting into the lungs to pick up oxygen. Now, sometimes individuals might have an atrial septal defect, which is a small opening between the right and left atrium. In these individuals, it's possible for a blood clot to go from the right atrium to the left atrium, bypassing the lungs completely. Unfortunately, the clot goes into the left ventricle and can get pumped out to the body, often heading towards the brain and cutting off a blood vessel serving the brain, which can cause an embolic stroke. There are three main factors that lead to a deep vein thrombosis, which are referred to as Virchow's triad. The first factor is slowed blood flow, also called stasis, in the veins. Typically, blood continuously flows smoothly through the blood vessel. But if the blood flow becomes turbulent, the linear flow is disrupted and slow or static pockets of blood are formed. Stasis can also happen during long periods of inactivity of the skeletal muscle pump, like bed rest or long flights and car rides. Or even during pregnancy when a growing baby compresses nearby veins. During stasis, platelets and other clotting factors contact the endothelium, and prolonged interaction leads to clotting factor adhesion, and ultimately activation of the clotting cascade. The second factor is a state of hypercoagulation, where altered amounts of clotting factors increase primary or secondary hemostasis. This can happen for genetic or acquired reasons like surgery, or taking certain medications like birth control pills. During surgery, physical damage to the vessels activates the clotting cascade. And birth control pills tip the balance towards clotting because they increase the levels of clotting factors and decrease the levels of some of the anticoagulation factors like protein C and antithrombin. A third factor is damage to the endothelial cell lining of a blood vessel, which exposes tissue factor and collagen. Damage can be caused by infections, chronic inflammation, or toxins like those found in tobacco cigarettes. A deep vein thrombosis is most common in a limb, usually the lower leg, and it can make the area around the clot inflamed, causing pain, swelling, redness, and warmth. If a pulmonary embolism happens, it can cause sudden shortness of breath and chest pain, and depending on the amount of lung tissue affected, it can even be fatal. The diagnosis of a deep vein thrombosis can be made by ultrasound. Alternatively, if the ultrasound is inconclusive, a more invasive venography procedure can be performed. This is when a dye is injected into the veins and an X-ray is taken to identify blockages. Also, a D-dimer blood test can be helpful, because fibrin breakdown product levels are usually higher in the presence of a clot. Generally speaking, the body makes and breaks blood clots all the time, and some small clots resolve on their own. But large clots that cause symptoms typically need an intervention. Thrombolytic enzymes can be given to help break down the clot, or a thrombectomy can be done to surgically remove the clot. Long-term treatment to prevent future thrombi from forming can include anticoagulant medications like warfarin or heparin, which inhibit the clotting cascade and prevent clot formation. Also, a filter can be surgically placed in the inferior vena cava to prevent pulmonary embolisms. Prevention of a deep vein thrombosis is also important. Compression stockings and frequent calf exercises during long periods of sitting still can help move blood through the veins to prevent stasis. Low-dose aspirin has also been shown to help prevent the formation of blood clots, especially if there's an increased risk of DVT because of a hip or knee replacement surgery. Alright, as a quick recap, a deep vein thrombosis is a blood clot found in the deep tissue, particularly in the lower leg. The three main causes, stasis, hypercoagulation of clotting factors, and damage to the endothelial lining, are often referred to as Virchow's triad. A deep vein thrombosis can also send off a thromboembolism to the lungs, which can cause a sudden pulmonary embolism, which can be fatal. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine. Otherwise, you can always support us by donating on Patreon, subscribing to our channel, or following us on social media. Thrombophlebitis can be broken down into thrombo, or thrombus, which refers to a blood clot, phleb, which refers to a vein, and itis, which refers to inflammation. So thrombophlebitis is a blood clot that gets lodged in a vein and causes inflammation. Normally, the process starts with damage to the endothelium, or inner lining of the blood vessel walls, after which there's an immediate vasoconstriction or narrowing of the blood vessel, which limits the amount of blood flow. After that, some platelets adhere to the damaged vessel wall and become activated by collagen and tissue factor, which are proteins that are normally kept separated from the blood by an intact endothelium. These platelets then recruit additional platelets to form a platelet plug. This formation of the platelet plug is called primary hemostasis. After that, the coagulation cascade is activated. First off, in the blood, there's a set of clotting factors, most of which are proteins synthesized by the liver, and usually these are inactive and just floating around in the blood. The coagulation cascade starts when one of these proteins gets proteolytically cleaved. This active protein then proteolytically cleaves and activates the next clotting factor, and so on. The final step is activation of the protein fibrinogen to fibrin, which deposits and polymerizes to form a mesh around the platelets. So these steps leading up to the fibrin reinforcement of the platelet plug make up the process called secondary hemostasis, and result in a hard clot at the site of the injury. This cascade has a huge degree of amplification, and takes only a few minutes from injury to clot formation. So the activation of the cascade is carefully controlled by anticoagulation proteins that target and inactivate key clotting factors. For example, antithrombin inactivates factors 9A, 10A, 11A, 12A, 7A, and thrombin, while protein C inactivates factors 5A and 8A. As the clot grows in size, it limits the amount of blood able to pass by, and pressure in the vein increases. Usually, the clot might start naturally breaking down. For example, enzymes like plasmin break down fibrin into fragments called D-dimers. There are three main factors that lead to thrombosis, which are referred to as Virchow's triad. The first factor is slowed blood flow, also called stasis, in the veins. Typically, blood continuously flows smoothly through the blood vessel. But if the blood flow becomes turbulent, the linear flow is disrupted and slow or static pockets of blood are formed. Stasis can also happen during long periods of inactivity of the skeletal muscle pump, like bed rest or long flights and car rides. Or even during pregnancy when a growing baby compresses nearby veins. During stasis, platelets and other clotting factors contact the endothelium, and prolonged interaction leads to clotting factor adhesion, and ultimately activation of the clotting cascade. The second factor is a state of hypercoagulation, where altered amounts of clotting factors increase primary or secondary hemostasis. This can happen for genetic or acquired reasons like surgery, or taking certain medications like birth control pills. During surgery, physical damage to the vessels activates the clotting cascade. And birth control pills tip the balance towards clotting because they increase the levels of clotting factors and decrease the levels of some of the anticoagulation factors like protein C and antithrombin. A third factor is damage to the endothelial cell lining of a blood vessel, which exposes tissue factor and collagen. Damage can be caused by infections, chronic inflammation, or toxins like those found in tobacco cigarettes. Thrombophlebitis most often happens in superficial and deep leg veins, leading to superficial thrombophlebitis and deep venous thrombosis, called a DVT. That being said, it can also develop in other areas of the body, like at the site of an IV insertion, especially if that IV has been sitting in the vein for days to weeks. Other conditions that can increase the risk of thrombophlebitis are Trousseau syndrome, which is where some people with pancreatic cancer get thrombophlebitis in various veins, as well as Mondor disease, where thrombophlebitis happens in the breast or front chest wall. Sometimes thrombophlebitis can get infected, or it can happen the other way around with an infection in the skin or soft tissue causing the thrombophlebitis. A classic cause is Staphylococcus aureus, and when the blood clot's infected, it's called septic thrombophlebitis. As you might guess, having an infected blood clot can be pretty dangerous, because it can lead to sepsis and can quickly allow that infection to get carried in the blood to other parts of the circulatory system. Thrombophlebitis is most common in a limb, usually the lower leg, and it can make the area around the clot inflamed. And this causes pain, swelling, redness, and warmth. Superficial thrombophlebitis can cause the affected vein to get hard like an electric cord. If there's septic thrombophlebitis, it can also cause systemic symptoms like fevers. If the septic thrombophlebitis is severe enough, it can lead to shock, where there's a drop in blood pressure and organs can fail from not getting enough blood. The diagnosis of thrombophlebitis can be made by ultrasound. Alternatively, if the ultrasound is inconclusive, a more invasive venography procedure can be performed. This is when a dye is injected into the veins and an X-ray is taken to identify blockages. Also, a D-dimer blood test can be helpful, because fibrin breakdown product levels are usually higher in the presence of a clot. Generally speaking, the body makes and breaks blood clots all the time, and some small clots resolve on their own. But large clots that cause symptoms typically need an intervention. Thrombolytic enzymes can be given to help break down the clot, or a thrombectomy can be done to surgically remove the clot. Long-term treatment to prevent future thrombi from forming can include anticoagulant medications like warfarin or heparin, which inhibit the clotting cascade and prevent clot formation. Prevention of a deep vein thrombosis is also important. Compression stockings and frequent calf exercises during long periods of sitting still can help move blood through the veins to prevent stasis. Alright, as a quick recap, thrombophlebitis is the inflammation of a vein around a blood clot, and if it gets infected, it's called septic thrombophlebitis. The three main causes, stasis, hypercoagulation of clotting factors, and damage of the endothelial lining, are often referred to as Virchow's triad. It most often develops in the legs and can be categorized as either superficial thrombophlebitis or deep venous thrombosis, though it can also happen in other areas of the body, especially at the site of an IV insertion.
Hey guys, Vince here. So, thrombophlebitis, deep vein thrombosis, and pulmonary embolisms are all very interconnected, and they all have the potential to become nasty. So, I hope that today's video was useful to you. Today's script was written by Emma Solar, it was edited by Risha Desai, Tanner Marshall performed the voiceover, and I created the illustrations. If you'd like to support the creation of more of these kinds of videos, I encourage you to check us out at osmosis.org. There we have study schedules, quizzes, flashcards, unreleased videos, and other great tools that'll help you learn medicine. But don't take my word for it. Check us out at Facebook. We have over 800 5-star reviews and a bunch of great testimonials from people that have told us exactly how osmosis has helped them learn medicine. All right. Thanks a lot, guys. Bye.